चोट लगा मेरे चाले में तो सीधी चाल चलू तेरी चाल मेरी आदत है मेरी चाल क्योंकि लालच है जुबान के पीछे नहीं भरोसा कागज पे भाई बड़ी सबको भाई बना सबको चलना छोटे छुड़ा आहिस्ते आहिस्ते फरमाइश से क्या होता है मेरे लेके तुम लोग वो ऐसे खेल लगा फिर भी कोई चक्कर सी लगा और जो मेरा होना है नहीं पता नहीं तू बस छोटी सी मजबूरी मेहनत को सोने पर करना भाव अपनी बता
Hello, check one. Hey, hey, one, check test. Hey, hey, check one. Hello, hello, check. Hey, one. Hello, hello. Babu Sabagar, check. Hello. Hello, check. Hey, hey. Hey, one, mic test. 1, 2, 3. 1, 1, 2, 3, 3. Check. One. Hello, hello. Hello, check. Hey, hey. Hey, hey. 1, 1. 1, 1, 2, 2, 3, 3. Hello, check one. Hey, hey. Hey, one. Hello. Hello, mic test. 1, 2, 1, 2, 1, 2. One, check. Hello, hello. Hello, check. Hey, 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 hey. Hey, hey, check one. Hello, hello. Hey, one, test. Hey, hey, check. Hello, hello. Hello, check one. Hey, hey. Hey, 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 hey. Hey, 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 check one. Hello, hey, hey, check. Check. Check one. Check. 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 Hello. Check.
तो भी जाय आपण सगळे उपासवाले पुरे आज खाऊ
Hello.
नाही तर का मिक्स करू
अपने खास बना अब ये भाग ताउम्र सदैव
लेके पूजा की जोत वाली सारा सारा दे दिया सहारा सुख जीवन का सारा तेरे चरणों पे वारू भोली माँ ओ लेके आया माता रानी के भवन में बड़ा सुख पाया बड़ा सुख पाया माता रानी के भवन में भवन में
गणे सोमा मैया सम्मुख गौरी गणे सोमा भवानी नारी नारी हमारा सम्मुख गौरी
निदाहनी सन्मुख रहे गणेश, पांच देव रक्षा करे, ब्रह्मा विष्णु महेश। करे भगति हो आरती माई धोई बिरिया, करे भगति हो आरती माई धोई बिरिया, करे भगति हो आरती माई धोई बिरिया, करे भगति हो आरती माई धोई बिरिया। सोने के लोटा गंगा जल पानी माई धोई बिरिया, सोने के लोटा गंगा जल पानी माई धोई बिरिया, अतर चढ़े दो दो शिष्या, अतर चढ़े दो दो शिष्या माई धोई बिरिया, करे भगति हो आरती माई धोई बिरिया, करे भगति हो आरती माई धोई बिरिया। लाए नदन बन से फुलवा माई धोई बिरिया, लाए नदन बन से फुलवा माई धोई बिरिया, आर बनाए चुन चुन कलियां, आर बनाए चुन चुन कलियां माई धोई बिरिया, करे भगत हो आरती माई धोई बिरिया, करे भगत हो आरती माई धोई बिरिया। पान सुपारी मैया ध्वजा नारियल धोई बिरिया, पान सुपारी मैया ध्वजा नारियल धोई बिरिया, मेवा खीर सजी थरिया, मेवा खीर सजी थरिया माई धोई बिरिया, करे भगत हो आरती माई धोई बिरिया, करे भगत हो आरती माई धोई बिरिया। लाल बरन सिंगार करे माई धोई बिरिया, लाल बरन सिंगार करे माई धोई बिरिया, धूप कपूर चढ़ी चुरिया,
धूप कपूर चढ़ी चूरियां माई दोई बिरियां अरे भगत हो आरती माई दोई बिरियां अरे भगत हो आरती माई दोई बिरियां पांच भगत मिल जस तोरे गावे माई धोई बिरिया गुप्तेश्वर की पीर हरो माई धोई बिरिया काट विपत की भई डरिया काट विपत की भई डरिया माई धोई बिरिया करे भगत हो आरती 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 माई धोई बिरिया
लेके पूजा की थाली जोत मन की जगाली तेरी आरती उतारू बोली माँ तू जो दे सहारा सुख जीवन का सारा तेरे चरणों पे वारू बोली माँ ओ माँ ओ माँ लेके पूजा की थाली जोत मन की जगाली तेरी आरती उतारू बोली माँ तू जो दे सहारा सुख जीवन का सारा तेरे चरणों पे वारू बोली माँ ओ माँ ओ माँ धूल तेरे चरणों के लेकर माथे तिलक लगाया ओ धूल तेरे चरणों के लेकर माथे तिलक लगाया यही कामना लेकर मैया द्वार तेरे मैं आया रहूं मैं तेरा होके तेरी सेवा में खोके सारा जीवन गुजारूं बोली माँ तू जो दे सहारा सुख जीवन का सारा तेरे चरणों पे वारू बोली माँ ओ माँ ओ माँ सफल हुआ ये जन्म के मैं था जन्मों से कंगाल ओ सफल हुआ ये जन्म के मैं था जन्मों से कंगाल तूने भक्ति का धन दे के कर दिया माला माल रहे जब तक ये प्राण करूं तेरा ही ध्यान, नाम तेरा पुकारूं भोली माँ। तू जो दे दे सहारा सुख जीवन का सारा, तेरे चरणों पे वारूं भोली माँ। ओ माँ, ओ माँ, लेके पूजा की थाली जो तुम मन की जगाली, तेरी आरती उतारूं भोली माँ। तू जो दे दे सहारा सुख जीवन का सारा, तेरे चरणों पे वारूं भोली माँ। ओ माँ, ओ माँ, ओ माँ, ओ माँ। जयकारा शेरवाली दा, धरती गगन में होती है तेरी जय जयकार मैया, ऊंचे भवन में होती है तेरी जय जयकार। दुनिया तेरा नाम जपे हो, दुनिया तेरा नाम जपे, तुझको पूजे संसार।
सरस्वती महालक्ष्मी काली तीनों की तू प्यारी, गुफा के अंदर तेरा मंदिर तेरी महिमा, शिव की जटा से निकली गंगा आई शरण तिहारी, आदि शक्ति आदि भवानी तेरी शेर। धरती गगन में होती है तेरी जयकार मैया, ऊंचे भवन में हो तेरी जय
ब्रह्मा विष्णु महेश भी तेरे आगे शीश झुकाए, सूरज चांद सितारे तुझसे उजियारा ले जाए। देवलोक के देव भी मैया तेरे ही गुण गाए, मानव करे जो तेरी भक्ति भव सागर तर जाए। ओ मैया धरती गगन में होती है तेरी जय जयकार हो मैया, ऊंचे भवन में होती है तेरी जय जयकार। दुनिया तेरा नाम जपे हो, दुनिया तेरा नाम जपे, तुझको पूजे संसार हो मैया, धरती गगन में होती है तेरी जय जयकार हो मैया, ऊंचे भवन में होती है तेरी जय जयकार।
ओए तेरे भवन दे दे अपनी शरण, ओए तेरे भवन दे दे अपनी शरण, रहे तुझ में मगन काम कर ये चरण, तन मन में भक्ति ज्योत तेरी हे माता जलती रहे, तन मन में भक्ति ज्योत तेरी हे माता जलती रहे।
तन मन में भक्ति ज्योत तेरी हे माता जलती रहे, तेरी हे माता जलती रहे।
उत्सव मनाए नाचे गाए, उत्सव मनाए नाचे गाए, चलो मैया के दर जाए। जय माता दी जोर से बोलो, सूरज भी किरणों की माला ले आया, कुदरत ने धरती का आंगन सजाया। सनन गाए पवन सभी तुझ में मगन,
हे
ओ तन मन में भक्ति ज्योत तेरी हे माता जलती रहे। फूलों ने रंगों से रंगोली सजाई, फूलों ने रंगों से रंगोली सजाई, सारी धरती ये महकाए।
जय माता दी जोर से बोलो,
पुरवैया देखो चवर कैसे झुलाए, ऋतुएं भी माता का झूला झुलाए। करके तेरा सुमिरन खुले अंतर नयन,
तेरी हे माता जलती रहे।
तन मन में भक्ति ज्योत तेरी हे माता जलती रहे। रहे तुझ में मगन थाम कर ये चरण,
हे माता जलती रहे।
ओ तन मन में भक्ति ज्योत तेरी हे माता जलती रहे। मेरे नैनों की प्यास बुझा दे, माँ तू मुझे दर्शन दे। अपने चरणों का दास बना ले, माँ तू मुझे दर्शन दे। शेर पे सवार मेरी शेरा वाली माँ, पहाड़ों में बसी मेरी मेरा वाली माँ। रूप है तेरे कई जोता वाली माँ, नाम है तेरे कई लखना वाली माँ। जग जननी है मेरी बोली वाली माँ। दयालु तू है माँ, क्षमा कर देती है।
रख लेंगे। शिंदेने सांगितलं काय हो गया हो गया ना भैया
Good morning, everyone, and welcome to this third day of the CME. Today, we'll be beginning our session now, and we'll be starting first with the session one, that is how I do it, the video sessions. And for the first video, I'd like to invite Dr. Vijay Kumar Bada from Hyderabad for his presentation on robotic pancreatico-jejunal anastomosis. And for chairing this session, I would like to invite Dr. Venu Madhav from NIMS, Dr. Rahul, Dr. Arjit Gupta, and Dr. Radhika ma'am. Sorry, ma'am. Ragini ma'am, Dr. Ragini.
Vijay sir, you can start. Good morning, all of you. Thanks for this opportunity to the organizing team and IASG. So today I'll be just showing a brief video about the robotic pancreatic jejunostomy, which is the most critical anastomosis in pancreatiodectomy. With the advent of robotics, this has made this has become very much more easier and more effective. We all know that invagination or dunking is one of the technique for pancreatic jejunostomy, and the second is the ductal mucosa. And this is the most common and found to be more effective. And this is the most widely performed procedure. And I will be showing ductal mucosa because I do almost all pancreatic jejunostomies ductal mucosa only. So before this, we have to know that there are various techniques for ductal mucosa, like the modified Heidelberg technique is there. We have the Blumgard technique, we have Kakita, many others, and also the age-old Cattle and Warren technique with little modifications. This is the procedure that I commonly perform, wherein we have a posterior layer, then we have the ductal mucosa posterior layer, then we have the anterior ductal mucosa, and then the anterior layer. That's the fourth layer. So this is the common procedure. But before I actually come to the video, we should know what a safe anastomosis in a PJ is. There are four components. One is we should have a very good stump of pancreas, 2 to 3 centimeters approximately, or based on the situation. But it should be well vascularized. To create a big, good stump of pancreas, we should not devascularize the pancreatic stump. If there are any important vessels, especially from the inferior aspect of the pancreas, we should retain them. Then we should have a very mobile vascular jejunal stump. We should not have a congested loop at the end of when we are starting the anastomosis. Second is I usually use a 50 or a 60 PDS of proline depending on the size of the duct. And of course, we should maintain very good hemostasis around the anastomosis, and I still leave a drain so that we can act upon if in chance there is a small leak around that. So this is the how we do this. Make a retrocolic. This is I take the posterior layer. The cephalic to caudal is the approach. We do take a bite on the pancreas and then a small seromuscular bite. Here, advent of robotic is I use that fourth arm to lift that one, retract the stay, and then we take 3 or 4 interrupted sutures. The robotics advantage is that we have a very good vision. We know that we have a 3D natural vision with 10 to 12 times of magnification, and the suturing is made much more easier. So we don't take very tight sutures, not very thick bites, and this will be the caudalmost bite where it's reasonably thicker bite than the other two. We can make a small drain depending on how much we need on the jejunal side. We make sure that the mucosa is very well seen, and this is the ductal mucosa first layer. We take the corner. This is the advantage of robotics. You can see how my needle holder is turning, and I'm having a clear vision of taking a bite coming close to the pancreas. And then I do not do any pre-placed suturing. I cut the sutures because the advantage in robotics is we can see the tissue so well that we will be able to take the bites as close as to the next suture. In the decent sized duct, I usually take 2 corners and 2 or 3 posterior sutures and 2 or 3 anterior sutures. Again, you can see here that the needle, the dexterity of the needle holder helps me in actually taking it very close. Again, you can see this is the corner bite at the 6 o'clock. We can completely turn the needle drive and also the left hand Maryland, and make sure that we have a very good view of suturing. This one suture I leave, you can see that I'm not leaving any sutures stay. I'm cutting all the sutures because of the confidence that the robotic technology will help me to take the bites very appropriately. Then we come to the anterior ductal mucosa layer. We take 2 or 3 bites, spaced equally, and the sutures should not be very tight. The only thing is in robotic technology, because of lack of haptic feedback, we tend to, what happened? Yeah, sorry for that glitch. So we make sure that because of the lack of haptic feedback, we tend to tighten the sutures too much, and they either make it too tight or the sutures get denuded. So this will be the last ducting mucosa suture. So we can see the bites very clearly, and then the fourth layer. So this is when we have a decent duct where we're able to see the spacing between the sutures very clearly. I'll have a small clip of what a robotic can help. You know that here while cutting the sutures, I've used the laparoscopic assistant port to cut the sutures. And in case you have the threads coming in between the next bite, we also can use the robotic technology very well. Here you can see that I'm using a suture cut needle driver where we can cut the suture as it is. Here you can see that suture is coming in between. I'm using the needle drive, creating an angle so that my other instrument will help to tie the suture very well. So this is a few of the advantages of robotic technology for doing a PJ. This is a small duct anastomosis. You know that I've placed this infant fluid tube while I'm preparing for the PJ so that we have a little bit of increase in the size of the duct. Again, the same technique, but what I want to show here is that the smallest possible duct also will be able to do a very good anastomosis using robotic technology. Here again, I take 2 corner sutures and 1 or 2 max posterior layer and only 1 anterior layer. Here the dexterity of these instruments will help to come from 12 to 6 o'clock. This bite will be able to come so easily under complete vision and in a single throw. So this will help in having a minimal tissue trauma on the pancreatic duct, because the ducts will be very fragile. And most of the times I make sure that when I'm transecting the pancreatic duct pops out 1 or 2 millimeters outside the pancreatic tissue so that we'll be able to take better bites. You can see here that without any hindrance, I'm able to take the posterior bite under complete view. We take the duct and also some amount of pancreatic tissue also. The movement of the instruments will be so delicate that we do not have too much of wear and tear on the tissues while we are taking these bites. Here I'm using the stay. I'm using the first arm, that's the retracting arm, to just hold those stay switches, give adequate traction, and that traction is fixed. We have in laparoscopy, if we have an assistant, the traction may be variable or there may be tremors, but this traction is fixed, and I know that I'm exactly able to see where I'm going to take the next bite. I don't leave very long sutures because there are only 3 sutures and we'll be able to see them very well. See that the previous traction is helping me to take this bite, and this is the corner 6 o'clock suture which I am taking. This view where we are able to see very clearly the mucosa, the serosa and the duct helps us. Again, I'm giving traction at 6 o'clock and then I tie off these 2 posterior layer sutures. There's some problem, boss. Color. I think there's taking too much of the glitches in between. So now we tie the posterior 3 sutures which we have left untied, because with the traction at 6 o'clock and 12 o'clock, we'll be able to tie these 2 sutures, and then we come to the anterior. When we come to the anterior layer of the PJ, I usually put this infant feeding tube back so that I don't take the posterior layer when I'm taking these bites. So this is again I open up this stay, I leave the sutures open so that I have a little bit more space while taking the anterior layer. So this is the infant feeding tube. We are able to see exactly that it's only the anterior layer. We are able to see the lumen and the posterior wall of the pancreatic duct very clearly. So this makes this anastomosis very safe and reassuring for us. And then we complete the anastomosis. Here again we can leave these sutures tray, and then we put this inflammatory tube inside, not really to act as an internal stent, but to avoid any wear and tear while pulling out the tube. This tube is used only to have a good anterior layer suturing and not take the posterior layer. And other one is the pancreaticojejunostomy for chronic pancreatitis. This is pretty much straightforward. We take a rule loop through the retrocolic trunk. Again, I use only 3 arms with no assistant trocas, only for suction if necessary. Then we start corner from the tail of the pancreas using a barbed suture. We take a U-stitch at the end. I usually use a 30 centimeters 2 barbed suture and continuous. I don't put the first layer interrupted as we do in open surgery. Here again, the dexterity of the instruments helps us in able to see the duct, see the mucosa and the sera of the bowel very well. The important point in a pancreaticojejunostomy for chronic pancreatitis is the corner. When we come towards the head of the pancreas after doing a head coring, there will be very thin rim of tissue around. So here you can see how the needle drive will help us in turning the needle around, and at the same time you can see this is the corner stitch I am taking. We turn the needle drive, and the dexterity at the angle of this wrist of the needle drive will help us in visualizing where exactly the suture we are coming. This is what I was telling. So we don't have any blind exit of the needle, and then 30 centimeters we end 2 or 3 bites on the anterior layer, and then we take a fresh suture. Either we start from here or we start from the tail. I usually start from where I leave here so that we don't have any interruptions. Thank you very much.
Thank you, Dr. Vijay. Because of lack of time, we'll move on to the next presentation.
Sure.
Very nice video. Thank you.
For the next talk on laparoscopic right hepatectomy, I invite Dr. Senthil Nathan from GEM Chennai.
Good morning to all. At the outset, I thank the organizers for inviting, especially Dr. Manish Mandal and the office bearers of IASG. I'll be speaking about laparoscopic right hepatectomy. Without wasting much time, I'll go directly to the details of the patient as well as play the video. The patient, 69-year-old male patient, has got various comorbidities, presented with, not playing. Now we can see a tumor, the lower segments of the right lobe, segment 7, and extending on to the 8, segment 8, various, reasonably large tumor, and these are the port placements. We generally go on little onto the right side so that we'll have a good exposure of the porta. The first step is to go for the mobilization of the liver. So, and then this patient given ICG 3 days prior. Now we can see the tumor and the surrounding tumoral peritumoral tissue retain the ICG. After intraoperative ultrasound assessment to note whether additional lesions are there, then we'll go for the surgery per se. We use a lot of retraction so that the exact parenchymal transection plane can be visualized clearly. The first step is the porta dissection. As you can see, the right hepatic artery and the right branch, right hepatic and right portal vein are dissected in the porta hepatis. This is the bile duct. Once during the surgery, again we'll give one shot of the ICG for marking the parenchymal transection. We start with doing the Callott's triangle dissection, identify the cystic duct and the artery, divide it, which can be used to retract the liver nicely. This is what we have been doing it, and now you can see clearly that various phases we can also use point. At various phases we use ICG, so that whether it is a biliary anatomy as well as vascular anatomy, we can able to identify it very correctly. The next, as you can see, is the identification and dissection of the right hepatic artery. When we go to the pre-border of the hepatoduodenal ligament, you have on the right side, you have the hepatic artery. We have to be very careful in the sense prior, we need to identify all the anatomical variations that's arising out of the vascular and the biliary anatomy. Now we can see the hepatic artery is coming out, branching out, a small branch onto the segment 4. This is preserved, and then we can see we go well close to the porta, and then we divide, we come onto the lateral side and then hook it. And then this is how porta, this is the most crucial step compared to the parenchymal transection. Sometimes we have the caudate rope branch which can bleed, so we have to be very careful. Once we identify it, we ligate it in continuity first, and then with the traction we use a hemolock clip. So once this is done, then we have, you can see this is a small branch, not we have seen the anatomy, so that after identifying that this is onto the right, staying onto the right side, we divide those branches, and the main thing is right branch is taken care. Once we divide the right hepatic artery, then we have space for the portal vein. Again, here care has to be taken for caudate lobe branch. After that, we give the second dose of ICG, which beautifully eliminates the vascularized and devascularized segment. This is the sync mode, the combination of white light as well as green light. So ICG mode, IR mode, so that in this mode we can able to do the both lights, both views clearly. So once retract, this is called the retraction, dynamic retraction onto the right left side, so that we start the parenchymal transection. So now we have got a very clear demarcation line, aided not only by the visual assessment, but also by the color assessment, so that we have a nice cantilever plane for us to go into the same exactly vascularized and devascularized plane. We use again a couple of rubber retraction. Now it's like an open book. We are on the front of the book, and then we go divide the right and left liver completely. Everything will be in our hand. There will not be any slogging. If there is a bleeding, it can be easily controlled, so that we no need to slog basically. We use a combination of bipolar vessel sealer, harmonic ultrasonic shears, as well as CUSA, to have a fine, precise parenchymal transection. Whether it is vessel, major outflow control, pedicle, portal pedicle, everything can be tackled, can be first visualized for us to be tackled. So that's the combination of these three energy sources, which gives us a fine, precise parenchymal transection. I would say here, a slow and steady wins the race. We have to be very slow, meticulous, so that you identify all the structures. This is the one of the branch origin of the middle hepatic vein, which we divide. It is from segment 5, and then from 4 it joins to form the middle hepatic vein, which is identified, clipped and divided. So bleeding happens when we apply energy source without knowing that there is a thin vein and then later come into picture. Here, we identify all the structures clearly so that we tackle depending on the caliber of the vessel as well as the thickness of the vein or the vessel, we clip it, we suture it, or we just burst it depending on those vessel thickness and the caliber. So throughout, we also get the ICG mode in place so that we will know where exactly these structures are. Now we can you see a bigger pedicle, and then once we have these kind of any white lined structure is portal pedicle. Any thin wall veins or outflow veins. So by that we'll come to know, are we dealing with a portal pedicle intrahepatically or a branch of the hepatic vein. So as we make our progress deep inside, the same trend continues, have a fine parenchymal transaction, and then this is intrahepatic division of the portal pedicle. We can still do the same thing extrahepatically, but being right hepatic repetectomy, sometimes we can do this particular arrangement so that right anterior and posterior can be tackled separately without the need to go very close to the porta. It can doubly ligated, still we can have the portal pedicle, the main portal pedicle tackled intraparenchymally. And then part of the caudate lobe is removed, as you can see, because the tumor is situated well away from the porta, as it's a lateral and posterior segment. This is partial caudate lobe resection. And then again, the last one which I clipped was a hepatic vein branch, as you can see, thin wall. Then as we go near the deeper parenchymal transection, we mobilize. Here, this is an anterior approach where initially we have not mobilized because the tumor is laterally placed. Once we divide the parenchyma, then we mobilize the lateral attachments, including the triangular ligament, put additional liver retraction so that we can go and then gain access to the deeper parenchymal plane. Again, this is segment 8 vein draining into the middle hepatic vein. And then once we do this one, then we'll go to this is the instrument which I'm using is the endo-mini retract. As I told you, for larger caliber vessels, we use clips, especially the hemolock. I think in about 30 minutes, I'll be closing this. So once we come to this, the final bit, we have to be very careful because segment 8 vein sometimes can avulse, and more importantly, we should be very careful about the right hepatic vein, which is clipped and stapled and divided, so that we don't again slog as far as the bleeding. Now we can see a well vascularized left lobe, which is which has got a clear transection plane and no bleeding whatsoever. I also take this opportunity to welcome you all to the next edition of iasgcon, which is happening at Chennai. On behalf of Tamil Nadu Surgical Gastroenterology Alumni Association, I hope to see you all there the next 2025 at Chennai. Thank you very much.
Thank you, Dr. Senthil, for the beautiful video. Any questions from the audience? Thank you, sir.
Thank you.
So we'll proceed with the next topic, that is laparoscopic total cystopericystectomy. I would like to invite Dr. Praveen Suryavanshi from Aurangabad for the same.
Good morning. At the outset, I am thankful to the organizing committee and office bearer of ISG for their kind invitation, and also I congratulate all the organizing committee for hosting this conference in such a great enthusiasm. So I'll be talking about laparoscopic cystopericystectomy. So as far as surgical management are concerned, there are two options, either partial excision or the radical excision. In partial excision, what we do is just decompress the cyst and take out the protruding part of the cyst wall outside the liver parenchyma, and then we leave behind the cyst cavity. The problem with this residual cyst cavity is that it leads to chances of recurrence, which ranges from 8% to 25%. Complication associated with residual cyst cavity, formation of pus or biliary leak from the residual cyst cavity, which is very difficult to treat because most of the time this residual cyst cavity is very fibrous and they refuse to heal for months together. So the best option to give complete cure to the patient is the radical excision. For radical excision, we have three options: lobectomy, if it is involving more than 2 segments of the liver; sectionectomy, if it is limited to 1 segment; or cystopericystectomy, if it is involving more segment of the liver. So I will be talking about the cystopericystectomy. So what we do here, we excise, we decompress the cyst, or if it is a small cyst, we don't decompress it, and then we excise the cyst with pericyst leaving behind the normal liver parenchyma, so that there is no complication associated with the residual cyst cavity. So this is the patient where we have a large agitated cyst of the left lobe of the liver involving all segment 4, 2 and 3, and we decided to go for the total cystopericystectomy. So now you can appreciate this is the falciform ligament here, this segment 2 and 3, and on the right side of the falciform ligament segment 4. So initially we release all the adhesions from the anterior abdominal wall, and then this cyst was decompressed. So we always keep one suction cannula outside the cyst, outside the puncture, so that if at all there is an accidental spillage of the additive fluid, we can suck it immediately without contaminating further peritoneal cavity. And further, all these adhesions are released until the IVC, so that the whole cyst wall which is protruding outside the liver parenchyma, that is mobilized adequately. We have to go to the inferior vena cava. Once adequate dissection is done, then all this protruding cyst wall is excised, just leaving behind the cyst wall which is adherent to the liver parenchyma. Since we have already decompressed this cyst adequately, so there will not be any spillage of the peritoneal cavity with the cyst content. We can appreciate this is a adherent cyst wall to the right lobe of the liver. This is the left hepatic vein. So we are dissected. Most of the time these veins are collapsed because there is no venous return. Whole left lobe was replaced with the agitated cyst. So this left hepatic vein was dissected and then it was clipped. So this is a left hepatic vein. As we mentioned, it is completely collapsed. We can comfortably clip with the hemoclip. Once this left hepatic vein is divided, then we have to dissect the rest of the cyst wall from the right lobe of the liver, which is normal lobe. So we have to be very careful and very patient in dissecting and clipping these small, either portal radical or biliary radical, hepatic radical, which are very densely adherent to the cyst wall. So they need to be dissected, clipped, and then divided. And we came to the distally to the pedicle of the left hepatic pedicle. So it was dissected and transfixed with the Prolin suture. In our practice, almost in 75% of the patient, we are able to do total cystopericystectomy. And then if there is a problem that the cyst is, so here you can appreciate now, this is the hepatic vein pedicle, and this is the portal pedicle. So you must examine the rest of the liver parenchyma for any biliary leak and the foraging. So now you can appreciate these are the stretched out Particularly this cystopericystectomy, we don't compromise as far as the normal liver parenchyma is concerned. So in sectionectomy or lobectomy, we may excise some normal liver parenchyma. In cystopericystectomy, normal liver parenchyma is not compromised. And if at all there is small leak, we can clip it comfortably. So as I mentioned that again we can for the cysts which are placed in the central in the right lobe of the liver. So these also can be managed very comfortably with the total cystopericystectomy. So this is a large cyst involving segment 8, 7, 5 and 6 exactly sitting in the center of the liver parenchyma. So these are the cysts which are very difficult. If you leave behind the cyst wall, they are very difficult to collapse post-operatively and they keep attracting fluid collection which later on get infected and then the problem with the residual cyst cavity management. So gently with the blunt dissection and where required sharp dissection, we can separate out this cyst wall from the normal liver parenchyma. We have to be very gentle and everything has to be done under vision. So these are again the densely adherent portal hepatic radicals which needs to be ligated before we divide them. So this was typically, centrally placed hydrated cyst with hardly any protrusion into the outside. So you can appreciate the hepatic radical which were stretched out over the cyst wall. So these are the locations which are they refuse to heal post-operatively or keep creating complications. So recently we are using this ICG for the precise demarcation between the cyst wall and the liver parenchyma. So the cyst wall which are very thick and densely adherent to the liver parenchyma, in such cases you can appreciate very precisely, you can go between the normal liver parenchyma and the cyst wall. Even it's true with if there is a biliary communication between the cyst wall and the biliary tree, you can identify with the help of the ICG. We can do intraoperative cholangiogram, assess whether any filling defects. With the balloon, we can take out these filling defects and then you can excise complete cyst. So what is subtotal pericystectomy? If there is a large residual cavity and it is very densely adherent to the major vessels, we are not able to take out this part of the pericyst. And what we do, we excise the lateral wall of the pericyst, which is safe to excise. Then what happens, this normal liver parenchyma grows inside the cavity and it practically obliterates the cavity so that there is no residual fluid collection. Just 30 seconds more. You can appreciate again the large cyst, very densely adherent to the diaphragm. We mobilize the cyst, now you can appreciate. So it was very densely adherent to the right hepatic vein and the IVC even. So laterally, the vein between the normal liver parenchyma and the cyst wall, you can appreciate this cyst wall is almost 12 mm, very thick wall. So if you leave behind this cyst wall, it will not collapse and it will keep accumulating fluid. So laterally we are mobilizing it and then we are excising this cyst wall like this. So the middle part which is densely adherent to the vessel, we are keeping it behind. And the lateral part we are excising. So the cup shape deformity we are making into sausage shape deformity so that it will not accumulate any fluid and this normal part of the liver will go inside and it will obliterate the cavity. Same thing you can appreciate, this is the hydrated cyst in the caudate lobe of the liver. And you can see this is the portal veins which are stretched out very densely adherent to the entry wall of the cyst. Again, we decompressed it. Now you can appreciate the part of the cyst which are adherent to the hepatic veins, but which was under visual control. We excise it. This is the pedicle here, and below is the IVC. Done. So this is the left small part which was adherent to the portal vein that was left behind, but the part which was over the IVC and the hepatic veins, it was completely excised. So this is a subtotal cystopericystectomy. So, medical management has very limited role. Cystopericystectomy and lobectomy gives radical cure. In cystopericystectomy, we should know inflow and outflow control techniques if at all there is you encounter any bleeding. Thank you so much.
Thank you, sir. A very nice talk and a very elaborate description. I have just one question. Do you advise for medical therapy after this radical procedure? And
Yes, sir.
what is the incidence of bile leak following this procedure in your case?
Yeah. So, medical therapy we advise before surgery also. And if it is a significant spillage, definitely after that we continue. If there is no spillage, we just give 20-day cycle of medical therapy. If there is a significant spillage, then we give minimum 3 cycles of medical therapy post-operatively. And if you go for the cystopericystectomy, because we excise complete cyst wall, if at all any biliary communication is there, we take care of it. So you don't miss any biliary communication. So they are taken care of, they are ligated or clipped. So post-operatively, you don't get any biliary leak in cystopericystectomy.
Thank you, sir. So we invite the
I just have one question.
Yes.
When you are planning for a total cystopericystectomy, in all your cases, do you necessarily decompress? Because, or do you feel that at least in some peripherally placed lesions, if you do not decompress, then the cyst itself gives you some traction which helps
That's
to
right.
make the cystopericystectomy easier. Once it's decompressed, the stretch goes away. So,
That's right. If a cyst are present in the peripherally, then you can avoid decompression. But if it is centrally placed, what I shared, so to go beyond the cyst, we need to decompress it. Otherwise, posteriorly or is difficult to reach. So if it is peripherally placed cyst, definitely you can avoid decompression. So it is a in toto excision of the cyst that is possible.
Thank you, sir.
Thank you so much.
For the next talk, I would like to invite Dr. Pradeep Jain from New Delhi for his talk on laparoscopic total proctocolectomy with ileal pouch anal anastomosis.
Good morning, everyone. First of all, I'd like to thank the organizers of ISG for having me here. Thank you so much. My presentation is on total proctocolectomy with ileal pouch anal anastomosis. We can do this procedure by 2 methods, by mesocolic excision or by pericolic excision. Mesocolic excision is when you have a suspicion or a confirmed malignancy, and pericolic excision is an ulcerative colitis when do not have any suspicion of malignancy. So these are the port position. I take the patient in supine position with leg split. We start these procedures with 5 ports. 1 port at the umbilicus. The second port is 12 millimeter port and the 2 centimeter medial and inferior to the right anterior superior iliac spine. 5 mm port in the mid clavicular line on the right side, just above the umbilicus level. And the 4th port left subcostal mid clavicular line, and 5th port left iliac fossa. So these are the steps I follow. First step is the ligation of IMA pedicle and medial to lateral mobilization. And then after that, I mobilize the rectum. Then left mesocolic mobilization is completed. Splenic flexure I keep intact. We remove it in the later part of the surgery. The right sided mesocolic excision is done. That is done from the inferior approach with the vessel ligations. And after that, I transversely colon is mobilized and transection of the anorectal junction is done after that. Then I mobilize both the flexures, hepatic and the splenic flexure. And the delivery of the specimen is done either from the suprapubic incision or by ileostomy site. Basically, I always make a pouch outside because sometimes when we make the pouch inside, there's a issues of the lengthening. The pouch does not come. We have to make sure that the pouch comes down 2 centimeter below the pubic mi. So I always make the pouch outside. And the pouch anal anastomosis is done, and the ileal, this ileostomy is done. So this is the video. This was a case of ulcerative colitis with malignancy in the transverse colon. This was a obese patient who had a BMI of more than 40. Normally, I do these dissections with the monopolar cautery, but because in this patient the mesentery was very heavy and there was a possibility of them having a cauterized injury into the bowel, so I do not do it with the monopolar cautery. Do it with the harmonic scalpel. This is the ligation of inferior mesenteric artery. After that, I do the medial to lateral mobilization, taking care that I have to keep my dissection plane anterior to the fascia zerota. Now we safeguard the ureter by visualizing the gonadal vessels and ureter and keep our plane of dissection anterior to that. After that, the mobilization of the rectum is started. You have to be very careful in this area to preserve the nerves. So we have to keep our plane anterior to the nerves. This is the lateral pattern fold on the right side which is being sliced. Retrorectal mobilization. Here we have to be very careful that we go deeper to the fascia vulvae. We can have a lot of bleeding. So we have to keep our plane of dissection anterior to that. This is the lateral mobilization of the patternal fold on the right side and taking our plane of dissection anteriorly. After that, we mobilize the sigmoid colon and then mobilize the left lateral pattern fold. This is the ureter you can see here. The left lateral pattern fold is being divided gradually. The completion of the left lateral pattern fold. Now the anterior pattern fold is divided. You have to be careful here because in these fatty patients, sometimes you're not able to see the posterior vaginal wall properly. You can end up damaging that. This plane, you have to be very careful and slow and deliberate. Take the dissection right up to the lower part of the pelvis. Do not divide it. Because if we divide the anorectum at this point of time, then you have a very loose colon and the dissection, the rest of the part of surgery becomes difficult. After doing the pelvic dissection, further mobilization of the left mesocolon, and we do the high ligation of IMV. After this, we just mobilize the upper part of the left mesocolon, remaining just anterior to the fascia of zerota. You can see there. Fascia of zerota. After this, the patternal fold above the pancreas, body of the pancreas, is cut. Then after this, I start my dissection on the right side. Do it with the inferior approach. We lift the cecum and the terminal allele mesentery and thus dissect the anterior part of the fascia of zerota. And this is the duodenum. You have to see the duodenum, and normally in thinner patients, we take our plane of dissection from here to the hepatic flexure. But this patient was fatty, so that was not possible in this patient. So we leave this dissection here, keep all the ileum and right colon in their anatomical position. This is a traction being given to the allocolic pedicle. Dissection is being done on the right side of superior mesenteric vein. The dissection of allocolic pedicle. The allocolic artery which is being clipped, cut. Allocolic vein. We take our plane of dissection from here upwards, and normally we don't see the right colic artery. It's present only in the 40% of the patients, but this was present here. So this is cut. After this, our plane of dissection is just anterior to the uncinate process of the pancreas, the ligation of right colic vein. You have to be careful here because if we don't take good care here, we can end up damaging the gastrocolic trunk. The accessory right colic vein. Then the plane of dissection on first part of the duodenum and the anterior part of the head of the pancreas. Now this is when we dissect this transverse mesocolon, right branch of middle colic artery being ligated, left branch of middle colic artery, so the transverse mesocolon is being cut. After doing all this dissection, mesocolic excision, after this, now we remove both the flexures. Before mobilizing the flexures, I just transect the rectum at the anorectal junction. Then we start mobilizing the splenic flexure and the hepatic flexure. This is the opening of the lesser sac. We take because this was a patient who had malignancy in the transverse colon, we're taking the entire omentum with the specimen. Of splenic flexure. Going for the mobilization of hepatic flexure. After this, we take out the specimen from the suprapubic incision, make a pouch of 15 centimeter. Inserting the anvil, we put the specimen, put the pouch back, do anastomosis. After making the anastomosis, sometimes there is a twisting in the pouch. So we have to keep the alignment of pouch properly. So I always suture the pouch with the lateral perineural fold, the pelvis. Keep it straight. The time permit, can I show the pericolic? I can continue?
Continue, sir.
Thank you. This is how we do it in the ulcerative colitis without any malignancy. We just mobilize the entire colon, do just like this division of the mesocolon just near the colon. It's a very simple procedure this way. Mobilization of sigmoid colon and then start cutting the mesocolon just near the colon. Mobilization of transverse mesocolon. The omentum is being separated from the transverse colon. Now gradually, we just take this dissection on the right side and mobilize the right colon and do a pericolic excision. That's all. Thank you so much.
Thank you, sir, for a nice demonstration. So in this case, you had a transverse colon malignancy. Does your approach changes depending on site of malignancy, or all cases you proceed with the same steps?
So whenever there is a malignancy or suspicion of malignancy, I do a mesocolic excision only. Without even bothering.
Like if it's right colon growth, do you approach the growth first, or in all cases you approach the rectum first, mobilization of the rectum?
When there is a, this was the case of transverse colon, so I did from the anterior side, right? But if you have a right-sided colon malignancy, then you start from the right side.
Okay. Any further questions?
I have a question. Do you always take the ileocolic pedicle at the base if it is not a case of malignancy, or do you spare that? And if another question is, if there is no malignancy and you're doing, do you always do a mesorectal excision, or you do core colectomy in the mesorectum as well?
No, and even if there is no malignancy, I always ligate the ileocolic pedicle at the base because that helps me in lengthening of the pouch.
So if there are no further questions from the house, we close this session, and thanks for a very good talk, sir.
Thank you.
Thank you, everyone. And to begin the next session, we have the special mention posters session. And for that, as judges, I would like to welcome on the stage Dr. T.D. Yadav, Dr. Vikram Kate, Dr. Venkat Reddy from Tirupati, Dr. Nilesh from Mumbai. And the first presenter, I'd like to welcome Senthil Muthuraman, and the topic is intestinal transplant in Indian scenario. Please come on the stage.
Good morning, everybody. Before we start, I believe the presenters must have been told that in special mention poster, we have total 10 minutes. Out of that, 4 minutes you have to present. 4 minutes there'll be critique from us and the audience, and 2 minutes will be for the discussion. So kindly present in that manner.
Thank you. Good morning to everyone. So, I'd like to present about the Indian scenario on intestinal transplant. Just before going to transplant, one brief slide on intestinal failure. Any cause that cause a gastrointestinal tract is not able to meet the body need, nutritional, water and electrolyte enterally results in the parenteral nutrition. Once the patient has been put on the parenteral nutrition, the options are any parenteral nutrition or intestinal transplant. But what are the challenges we face in India in home parenteral nutrition? Main challenges are appropriate access to the home parenteral nutrition and the financial constraint to buy the parenteral nutrition daily basis, maintenance of electrolyte and fluid imbalance, and the complication related to central line handling that may cause repeated infection or venous access loss. So these patients can get benefited from intestinal transplant. It's a life-saving procedure. So indication for intestinal transplant are patient with the irreversible intestinal failure and having complications from TPN or line-related complications. So we present our experience. We started this program in April 2023 to September 2024. We have done 9 isolated intestinal transplant in our center. Grafts are brain dead patients. Graft selection criteria is we select BMI less than 25. And donor should be optimized hemodynamically and lactate less than 3. And in drop, we especially look at the mesentery and mesocolon, and that it should not be fatty, so that because the recipient majority of them will not have the domain and will be difficult to close. So majority of these patients, we say transparent mesocolon and mesentery. In this, it's a picture of a donor able to see the mesocolon and the vessels are seen transparently. And obviously there should not be any bowel injury or mass lesion. We tend to keep our cold ischemia not more than 8 hours. And the donor details, the age of the donor ranges from 12 to 24, the mean of 16, and BMI mean 22, and majority of them is RTA, and the average cold ischemia in our series is 6 hours and 10 minutes. And this is the demography of the 9 patients. See, mean age is 36, youngest of 8 years, and older patient is 67. 80% are male and 20% is female. The majority of these patients has lost their gut due to mesenteric ischemia. One patient following multiple laparotomy has multiple enterocutaneous fistula are not able to maintain the enteral nutrition. One patient has a desmoid of the mesentery that result in the obstruction, not able to maintain the enteral nutrition. So the mean TPN is 38 weeks, ranges from 4 to 205. One patient who was on TPN for 4 years came to us after that. So if we exclude that patient, the average TPN is around 17.8 weeks. And this is a picture of isolated transplant. In the back table, you're able to see the mesentery is cleared up to the base. You're able to see the portal vein, SMV and the SMA. Donal, we harvest the entire small bowel with the large intestine up to the left of the middle colic, along with the C loop of the duodenum, pancreas and spleen. Pancreas and spleen, C loop of duodenum was removed in the back table and isolate up to the mesentery. We preserve the splenic vein for bleed out. Recipient bed preparation, IVC and infrarenal aortas are looped. We usually tend to do the donor vein and artery jump graft so that the implantation becomes easy. Stoma is not routinely done on patient. Only if there is no distal colon for connectivity, we do stoma. One patient has a leak and we have to go and do a stoma. Abdominal closure is always a skin closure because to avoid tension. I'm able to see the on the right side is the venous anastomosis, left side is the artery in middle. After reperfusion, we are seeing the right angle over the splenic vein is ligated. Picture after reperfusion. So induction immunosuppression, use alantisibap 30 mg and solometrol 1 and post-op tapering dose of steroids, and we maintain TAC level around 10 and we don't use MMF in intestinal transplant. Anticoagulant dextran for 36 hours followed by clexane and ecosprin. Majority of these patients will have mesenteric ischemia, so they need a long-term apexaban. Post-op, we keep the patient 5 days NBM and then we do a CECT, IV and oral contrast, following which we start with the liquid and progress to soft diet. Mean hospital stay is around 19 days. As of now, all patients are enteral fit. There's no graft loss or no patient on TPN. We had one mortality recently. The first patient we did 1.5 years back died of pneumonia with functional graft. Other is almost 44% re-expiration. 2 patients had a bleed. 1 patient has a SAO due to adhesion, where we went and did resection anastomosis. 1 patient has anastomotic leak in the distal end. We disconnected the anastomosis, did a stoma. 1 patient had pseudoaneurysm, needed coiling, and 2 fungal infection that was treated successfully, and 1 anastomotic intraluminal bleed that was managed conservatively. So we believe that intestinal transplant can be done safely in India despite of its morbidity. Pre-op nutritional optimization is the backbone. Don't take the patient and the patient is on refeeding syndrome. Proper selection of the donor, standard surgical technique, important short cold ischemia, and then meticulous follow the key to success of intestinal transplant in India.
Thank you for your presentation. The paper is open for discussion.
Okay, let me start. So you have shown that pancreas is taken on the bench. So all these patients, pancreatic transplant is not done?
Combined isolated intestinal with pancreas transplant, asking, sir.
Not done or done?
Not done, sir.
Not done. No. Pancreas, it's not combined intestinal pancreas. It's combined simultaneous kidney and
No.
pancreas.
Only isolated intestine.
So suppose there is a pancreas is being taken by another team, which is good, want to do pancreatic transplant. Then what modification will you do in terms of SMB?
As of now, we have not encountered the situation in India where we are 2 teams need like a pancreas and then intestine.
My question is,
it has to be separated in the back table, and then we have to have a good jump graft so that the SMV can be directly implant. Yes, splenic vein will not be available if we take the pancreas, so we want to do a warm bleed out at the anastomotic site.
So it means in none of the cases pancreatic transplant was done in that particular site?
Yeah, when we harvested small bowel, none of them has opted for pancreas in the same graft.
Any
based on the experience of 9 patients, what further message you'd like to give to improve the morbidity and the mortality?
The main thing is optimization of nutritional optimization of the patient. Normally, after majority of centers who do resection, the TPN was not properly managed, and whatever patient we get, everybody has a refeeding syndrome, almost 100%. So don't take the patient, even if you have a good graft, when the patient is on refeeding. Actually, we had one patient taken early, had interrupt cardiac arrest, and then revived. We put them on TPN for 2 months. Then we did successfully after 2 months. So the lesson learned from that is don't take the patient so early when the patient is on not optimized nutritionally and electrolyte imbalance and water imbalances are there.
Thank you very much, Dr. Santil, for your presentation. Thank you. We invite the next presenter, Dr. Ravi Poleti.
Good morning, respected professors. I am Dr. Ravi Teja from Meenakshi Mission Hospital. My topic is about role of endosine in lowering bile duct injuries in laparoscopic cholecystectomy. The incidence of bile duct injuries in lap cholecystectomy is around 0.3% in non-inflammatory cases to up to 4% in patients with inflammation. And despite using various procedures like BSAFE and intraoperative ultrasounds, the incidence of injuries are still high, especially when there is a difficult anatomy. So the aim of this study is to evaluate the feasibility and usefulness of ICG in intraoperative assessment of bile duct anatomy and avoiding bile duct injury. It's a retrospective study done from May 22 to May 24 in our department. 1 hour prior to procedure, we injected 5 milligram of ICG IV. The primary outcome is to assess the incidence of bile duct injuries. Our analysis included 973 patients, including multiple cases of symptomatic gallstone disease, acute cholecystitis, chronic cholecystitis, empyema, gallbladder, gangrenous cholecystitis, and mucocele of gallbladder, Mirizi syndrome, gallbladder polyps, emphysematous cholecystitis, as well as a Mirizi syndrome with a choledococutaneous fistula. This is the case of symptomatic gallstone disease, where ICG showed the cystic duct insertion into the CBD, and you can assess in multiple modes. The real use of ICG comes in these cases like gangrenous cholecystitis, where the entire callout's anatomy is frozen. And this you can see. We could not make out the CBD initially. So after changing the ICG camera to Firefly mode, we could trace out the CBD, and from there we could dissect the entire cystic duct and cystic artery over it and clip them. And this is the case of seal of gallbladder perforation, where the entire omentum duodenum got stuck to the gallbladder, and there is lot of pus. And while dissecting, there was lot of bleeding. After changing to Firefly mode, we could identify the CVD, over which we could dissect the cystic duct carefully and clipped it. And this is a case of subtotal cholecystectomy done operated in outside hospital, where he had a choledococutaneous fistula. So we posted him for completion cholecystectomy as well as CBD repair. He presented with obstructive jaundice with cystic duct stone impinging on the CBD. So in this case, after giving ICG, we could easily trace out the CBD, and we proceeded to dissect out this entire gallbladder of the CBD. This you can see the cystic duct and CBD in monochromatic mode. After identifying the junction, we performed dissection over the CBD. So we had visible fluorescence in 100% of the cases, and none of these patients were converted to open. The mean day of discharge of this patient was day 3. Totally 4 patients had bile duct injury. And when one patient of gangrenous cholecystitis is a type A injury, which was managed with ERCP stenting, and in 2 patients of acute cholecystitis, we had a type D injury. Even that was managed with ERCP and stenting. But one patient with a symptomatic gallstone disease, we had a type E2 injury. 3 months post surgery, we operated her with Roux-en-Y hepaticojejunostomy. The overall bile duct injury rate in this study is 0.2% in simple gallbladder surgery, whereas it is 0.57% in cases with inflammation, which is way less than 4% as described in the literature. To conclude, lab cholecystectomy with real-time ICG fluorescence angiography helps better visualization and identification of biliary anatomy and is a means of achieving safety in lab cholecystectomy. Thank you.
Thank you for your presentation. You have not proven that it reduces your injury rate, because can you compare it to your previous 1,000 patients or some other, because you have got an injury rate of 0.22, normal rate is 0.3 to 0.4. So how do you say that you have reduced your?
I will compare it with the literature rates. In literature, it was 4% in cases with inflammation, whereas in our case,
no, there's no literature which is 0.4%.
No, 0.4% in without inflammation.
No. I think 4% is never acceptable. There is no data anywhere mentioned in the literature 4% bile duct injury. 4 in 100 is too high and it's not there. Please.
Actually, what just now Dr. Nilesh has mentioned, this study would have been good if you would have compared it with the comparative arm of your own cases which were there done without the ICG. Without that, you can't tell. 2 problems are there. That is one. Other one is the event rate is very low. You've got only 4 bile duct injuries.
Yes, sir.
So with the 4 bile duct injuries, if you compare even with the retrospective series of 1,000, if you have 1 or 2 more, it will not give you any statistical interference. So the number should have been larger because the event rate is so low. Sample size calculation was not done. If you do it, you'll find for this, you'll require at least 8 to 9,000 cases of sample size to get a proper interpretation from this sort of study.
Yes.
But otherwise, you have shown the illustrations and all fine.
Also, you have to compare it to something which is standardized now, like critical view of safety. So if you have comparison to that, how will you say that ICG is better than a critical view? You have to compare it to something, no? So your series is not really comparing it to anything else. So how do you conclude that ICG is safer in preventing bile duct injuries? Because you have to compare it to something, no?
Instead of comparing with those things, ICG can be used as a bailout procedure. I can say that.
Yeah, so the topic should have been different. It's not, the topic is not conclusively to prove that it reduces bile duct injuries. You can say that the visuality is very good. You can have called it that difficult gallbladders, it can be used as a bailout procedure. So that would have been a more appropriate, topic, because that's what you have concluded. You cannot conclude from this study that you have reduced the bile duct injury rate.
Yeah, same thing. You should have compared to that, whether you could achieve this critical view of safety, and then in those cases where you didn't achieve that, whether it made any difference. That should have been there.
Yes.
And at the end, what is the take-home message? You want to suggest that it should be used routinely or in selective cases?
So I want to make it making ICG as a routine practice will be helpful to decrease bile duct injuries.
Yeah.
And have a proper visualization of anatomy.
Yes, Dr. Rajneesh, please.
A great study, but part of the queries was exactly what the judges have asked. The second part of it is your recommendation. We are very used to saying that it's a fashionable thing to have ICG compatible system in your OR. Laparoscopic cholecystectomy can be done without ICG enabled system as well, which is far cheaper as well. So what in your study makes you recommend that you should buy an ICG compatible system, and hence, your conclusion would be very justified. That is difficult to say from your side, right? You are adding a cost to a surgery. Of course, it's not that you are not adding cost to surgery by having an ICG enabled system.
As of now, whatever the recent laboratory equipment, they're all equipped with ICG, sir. Another thing,
there are hundreds of equipments across the country which are not ICG enabled. So you're asking in your study, you're asking all of them to shift to ICG-enabled system because there is some benefit.
Yes.
That
No,
benefit is not very clear. That is what the whole idea was.
Yes.
Thank you.
Thank you.
Thank you, Doctor. Thank you. Next, I invite Dr. Sanjam Singh to do the presentation.
Good morning. I am presenting near infrared fluorescence guided lymphadenectomy during esophagectomy for the esophageal carcinoma. Start with, for esophageal carcinoma, the neoadjuvant therapy followed by esophagectomy with two-field lymphadenectomy has been a standard of choice. In the post-neoadjuvant era, the lymph node positivity has been a matter of concern. And the near-infrared fluorescence imaging with indocyanine green has been an emerging method for intraoperative decision making. But there is always a lack of, there is still a lack of literature with regards to the use of ICG for the lymph node retrieval and the histopathological correlation. We performed a prospective observational study, included 30 patients with a primary objective to assess the lymph node yield during the esophagectomy after giving intratumoral ICG injection in the esophageal carcinoma. And secondary objective, we correlated the ICG positive lymph nodes with the histopathologically positive lymph nodes. We included all the cases of squamous cell carcinoma of esophagus who underwent minimal invasive McKeon esophagectomy with the age of more than 18 years. In the preoperative period, we did upper GI endoscopy 18 to 24 hours before surgery, injected 4-quadrant ICG in the peritumoral and submucosal area, did a near infrared imaging during esophagectomy and identified the ICG positive lymph nodes and then correlated it with the pathologically positive lymph nodes. These images show the upper GI endoscopy in which the ICG is being injected in the peritumoral area, 4-quadrant ICG injection. In the intraoperative image, we can see in the first image the site of the ICG injection which correlated to the site of the tumor. And in the next two images, these two lymph nodes show that these are the ICG negative lymph nodes. The next three images show the ICG positive lymph nodes, and the other three images show the post-operative after the resection of the specimen. In the preoperative evaluation, we can see that majority of our patients were included within the middle and the lower thoracic esophagus, and all our patients received the neoadjuvant therapy, and based on the clinical and the PET CT response, majority of our patients had the partial response with a complete response in 3 and 7 patients respectively. In intraoperative, the ICG positive lymph nodes median was 2 with a range of 0 to 5. And on the histopathological analysis, we can see that the N0 disease was found in 19 patients after neoadjuvant therapy. And the total lymph nodes retrieved was 678, out of which the median was 25, and out of which the positive for malignancy median was positive for malignancy, it was 20 with a median of 0 with a range of 0 to 4. On doing the lymph node analysis, we can see that out of total ICG positive 57 lymph nodes, the histopathologically positive lymph nodes were only 16. And out of total histopathologically positive 20 lymph nodes, ICG positive were 16, that is 80%. But we can also see that the ICG negative correlated well with the histopathologically negative lymph nodes, that was 99.3%. And in comparison with the other studies, we can see that all our patients received the neoadjuvant as compared to the other studies in which most of the patients did not receive the neoadjuvant therapy. Our lymph node yield, sensitivity, specificity, negative predictive value was comparable to the other studies. The high negative predictive value with neoadjuvant therapy meant that if the lymph node is ICG negative, there are less chances of it being histopathologically positive. And low positive predictive value meant that ICG imaging was unable to identify metastatic lymph nodes in the neoadjuvant era, but rather helpful in the lymphatic mapping. And it also helped in retrieving a higher number of lymph nodes compared to the traditional approach. To conclude, ICG imaging during esophagectomy can enhance lymph node visualization during surgery, and it is a safe, feasible, and helpful technique for lymphadenectomy. Thank you.
Hello. Thank you for your nice presentation. So the main question that is important is that if you just did a standard lymphadenectomy that you would normally do, compared to doing giving the ICG first, would you say that if you just did a better visualization, did you get a higher lymph node yield compared to what you would do in standard? And how would that improve or change survival benefit?
Sir, based on the literature, sir, and the RCTs in which the standard lymphadenectomy was done in the neoadjuvant era, it showed the median of around 22 to 23, sir. But it ranged from less than to less than 15 till around 26. And in the studies which have done the ICG, but none of the study has done all the patients, including after the neoadjuvant. So even if some patients have been included after neoadjuvant in after giving ICG, they have shown a median of around 28, sir, which was comparable to our study of 25, sir.
Dr. Agnish.
Yeah, hi. Great study. Your team has done fantastic work, but I'm a little confused with your last conclusions. The conclusion was you can have that on the that can enhance lymph node visualization. And I assume it improves your lymphadenectomy. Is that the conclusion?
Sir, actually, the lymphatic mapping improves, sir. The lymphatic channels open up after
Let's take that
neoadjuvant.
forward, the lymphatic mapping part. So if I were you, what I would ask you is that if I have to improve my lymphadenectomy, and after I have finished with the lymphadenectomy, there should be no ICG avid lymph node in the field, correct?
Yes, sir.
Now that is the problem because there are ICG negative lymph nodes which can be pathologically positive.
Yes, sir.
That
Actually,
is the data you are interested in.
that was, sir.
Not the concordance with
Four.
the negative lymph nodes. I would be interested in lymph nodes which are ICG negative but pathologically positive.
Yes, sir. 4,
Those are
sir.
the lymph node. No. So the question really is that you're harping on the 99%. That is not the right
Yes,
number
sir.
to look at. Number to look at would be the
4.
4 lymph nodes, which would be missed if you were to guide your lymphadenectomy using ICG. That's what you are attempting to do, correct?
Yes,
You
sir.
are guiding your lymphadenectomy by using ICG, which means lymph nodes which are ICG negative would not be picked up in your lymphadenectomy specimen,
Yes, sir.
right?
Actually,
You're
sir,
missing those lymph nodes.
sir, based on comparing with the other studies, sir, they also had a positive predictive value, but it was less, sir. It was less than 5%. R was around 28%. So that was one of the point. We also had a lymph nodes which were ICG negative, but they were histologically positive in the post neoadjuvant era. That was the
I have two
point.
more questions here. One is that how do you deal with the non-passable tumors?
Yes, sir.
How do you deal with the non-passable tumors, endoscopically not possible?
Sir,
You had those in your group. Did you include them in your?
yes, sir. If endoscopically or PET-CT there was a complete response or we were not able to go beyond the tumor, sir.
Yes,
Then, sir, at the site of the tumor only, sir, peritumoral 4-quadrant ICG injection. we
Proximal
have
to
done.
the tumor.
Yes, sir.
Proximal to the tumor.
Yes, sir. Just proximal at like this.
I understand. So
Yes, sir.
in those patients, there'll be no injection done distal to the tumor because you were interested in both sides, correct?
We gave injection only on the proximal, mainly on the proximal side of the tumor only, sir. Whether it was
All patients.
on all the patients, sir.
So you're not putting any injection to the distal part of the
Distal
tumor.
part. Yes, sir.
Okay. And did you have any patients who had no neoadjuvant therapy? You had some.
Sir.
No neoadjuvant therapy.
Sir, all our patients received neoadjuvant therapy.
All
sir.
of them.
All of our patients received neoadjuvant therapy as compared to the other studies, sir, in which.
Thank you.
Yes, sir. Thank you, sir.
One question I'd like to ask, why you have not put the endpoint as lymph node yield? So ultimately visualization has to lead to that itself.
Yes, sir. Our primary objective was, sir, lymph node yield, sir.
But you have not mentioned that in the conclusion.
Sir,
Look at the conclusion, there is nothing mentioned because conclusion has to be the answer to the objectives. Is it not?
Yes, sir.
Because visualization is very subjective. Otherwise, you have to define what is visualization if you put it as a conclusion. So lymph node yield, which is based on the pathological examination, becomes a very objective endpoint.
Yes, sir.
Any other question? Yeah.
And this one, you had these positive lymph nodes from the this thing, 4 cases something you had. Did you
Yes.
analyze which are these patients who had these positive lymph nodes? I mean, ICG negative and positive lymph node. Is it something like what Dr. Rajneesh was telling? Is it the cases where you couldn't inject all around the tumor, something like that? Did you assess that? Any technical difficulties you had in these 4 lymph node positive cases with ICG negative?
So retrospectively, we did not analyze, sir. We have the data, sir, but
we did not analyze which, matlab, based on what the 4 patients came positive, sir. 4 lymph nodes were positive.
Hi. Based on your data, hello, here.
Yes, sir.
Based on your study, are you going to recommend that you can do a more limited lymphadenectomy if you give ICG rather than the standard lymphadenectomy that you're going to do?
Yes, sir.
You think you can recommend that?
So based on this study, sir, the sample size is less, sir. We'll need further studies and we need a comparative data in the post-neoadjuvant era to compare whether we can go ahead with a limited lymphadenectomy or we need a standard lymphadenectomy. Because as we can see, the 4 lymph nodes still came out to be positive after even if they were ICG negative, sir. So, we cannot recommend, but yes, we can do further studies to evaluate whether
You
the
think it's
limited
in that line, it's in that pathway.
Yes, sir, it is towards that, sir. Because before the study, we did not know where.
Okay, Sanjam.
Thank you.
Thank you,
sir.
We have already crossed 2 minutes. Thank you.
Next, we invite Dr. Ashish Sharma for the presentation.
Morning, sir. My presentation is on colorectal anastomosic leak, the factors and their effects. First of all, we all know anastomosic leak is a devastating complication following the colorectal surgeries, and the reported incidence in the literature is 1 to 13%. The morbidity being 20 to 30%, and mortality reaching up to 7 to 12%. According to leading to the communication between the intraluminal and extraluminal compartments, which is further confirmed radiologically, endoscopically, or intraoperatively. Our study evaluated the risk factors for the anastomotic leak following the surgeries, which involved colon or rectal anastomosis and their impacts. The aim of the study was to estimate the incidence of the anastomotic leak following the colorectal surgeries, the risk factors for developing anastomotic leak and their effects, the impact of the anastomotic leak on the mortality and the morbidity. So this is a prospective observational study conducted at our hospital. It included 82 patients in total who underwent surgeries which incorporated either colon or rectal anastomosis. The patients were preoperatively evaluated with the detailed history, clinical examination, blood investigation, and radiological investigations. The intraoperatively, the factors like operative setting, surgical approach, operative time, ASA grade, blood loss, whether it was more than 200, anastomotic type, orientation, location, etc. were noted. And post-operatively, hospital course and post-operative on day 3, the routine blood investigation along with the CRP were sent. Complications occurring within the 30 days of the surgery were noted in a register, and risk factors were further analyzed based using univariate and multivariate analysis. So these are the results. As anastomotic leak, we had 12.3% total leak, out of which the grade A leak was 3, grade B were 1, and grade C were 6. There was no leak in 72 patients. So we divided the factors in patient factors, disease factors, and intraoperative factors. Amongst the patient factors, except for preoperative serum albumin, we did not find any factor which was significantly associated with the leak. Amongst the perioperative factors like blood loss, anastomosis orientation, methodology, operative setting, surgical approach, anastomotic site, and duration of surgery, only the duration of surgery and blood loss were found to be significant factors on univariate analysis. Amongst the disease factors, though malignant had a more incidence of leak, but the p-value was not significant. The section margin was also not associated with the leak, but though we had only a very small sample size for this. We further took some predictors of leak based on previous studies in the literature, which was preoperative TLC, preoperative serum albumin, postoperative day 3 serum albumin, and postoperative day 3 CRP. And we found Though preoperative TLC were higher in the leak rate, but they were not significant. Though and preoperative serum albumin, postoperative serum day 3 serum albumin, postoperative day 3 CRP were found to be significant. The mortality and morbidity were further analyzed. And it was seen, though the complications were more in case of the leak, they were not significant except for the mortality, which was total mortality in our study was 5. The 4 were found in the patients which had grade C leak. So the factors which came out to be significant on univariate analysis, we analyzed them with a multivariate analysis, and on multivariate analysis we found that except for the CRP, rest of had p-value more than 0.05. We also checked the accuracy of the postoperative day 3 CRP based on the values in various studies, and we took 2 values. One was 58.5, another was 47.5. And we found that the accuracy of the CRP was quite moderate in 58.5, but not that great in 47.5. So both the tests had a significant p-value, and also the negative predictive value in both were quite high, so that it could actually rule out the leak. On conclusion, in our study, the anastomotic leak was 12.3%. Total number of cases of leak were 10. The intraoperative blood loss more than 200 ml, the duration of surgery, the preoperative serum albumin, the postoperative day 3 serum albumin, or postoperative day 3 CRP were significantly associated with the anastomotic leak on univariate analysis, whereas only the postoperative day 3 CRP levels were significantly associated with the leak on multivariate analysis. Postoperative day 3 CRP levels at 58.5 had a good negative, had a high sensitivity, moderate specificity, and high negative predictive value, but low positive predictive value. Whereas at the threshold of 47.5, the sensitivity was again 90%, the specificity decreased to 52.78%, the negative predictive value was still high, the positive predictive value further decreased.
Thank you for your presentation, very well presented. 2 or 3 points or just concerns I wanted to ask is, one is you should have done definitely a sample size calculation in this sort of study, which you have not shown. Then I believe that this 58.5 you must have got through an ROC curve. That is also missing in this. Must have got through the ROC curve, no?
Yes, sir. I did get
so that you should have put. And the thing is, I feel that although you have 12.3%, the incidence of leak was okay, but it is not very high to get. See, you got 3 or 4 factors, which we know very well that albumin, if the duration of surgery is prolonged, chances of leak are there. But you did not find that on multivariable analysis, is it not?
No,
so
sir.
What could be the reason for that?
Sir,
Those are well-known factors.
I guess the sample size, we are still having this
Yeah, this
study
is a
going on in our
classical
department.
example of beta error, what you have commented. Because if you would have had sample size of 200 or 250,
yes, sir,
then this would not have happened. That
Yes,
would
sir.
have become significant on multivariable, and that's why I said sample size is this. It's open for discussion.
This is what do you think is the original thing from your poster that adds to our? We have extensive knowledge on leaks after colonic surgery. What do you think your paper adds to that knowledge? Are you able to give some additional message? Because these are all very well-known factors.
Sir, yes, sir. Obviously, there are well-known factors, but we also took the CRP level for the negative predictive value. So I think that is the thing. We can get our CRP on day 3, and if the value is normal, we can be assured that there is no leak. On the other hand, if it is the on the higher side, we should be a little vigilant in patient management.
Yeah, this is all lab or open one?
Sir, the lab and open both, sir.
Both. And what about the usage of staplers or hand?
Yes, sir. I considered it all, sir. I also showed it. Majority of our anastomosis were hand sewn, though there were like 5% of the anastomosis which were a stapler, and we did not find any significant difference in.
But there are a lot of other technical issues which are not mentioned in this. So if you use a stapler, was the donuts were complete? So all that issues comes on. Did you do any post-op leak test intraoperatively, any air leak? So all this actually, there are a lot of technical factors also which which are there in the anastomotic leak as a thing, which you have
Right,
not mentioned, I think.
Right.
So I think that should have also come into the picture to have the total complete
So
leaks
I
outside.
took the number of layers, I took orientation, I took the side-to-side anastomosis, whether we did side-to-side anastomosis, end-to-side anastomosis, I took it all, sir. But they were not significant. Also, the number is quite small to compare, sir. So I think if the sample size would increase, we can comment on that more.
Stomas were done for these patients?
Sir, stoma, no, sir. It was an exclusion criteria. We did not take any patient with stoma.
So one more important point is colon and rectum both has been taken.
Yes, sir.
So is there a difference in the leak rate in colon and rectum?
Sir, literature do say there is a leak rate. They say there is a high risk of the leak in the rectal surgeries, but in our study, we have not found any significant difference.
Second, I am just thinking if there is a leak you find, CRP level on day 3, CRP would be raised once there is any inflammatory process going on.
Yes, sir.
Maybe, so how are you sure that, and then what you do? You have not done an anastomosis.
Sir,
So
exact-
suppose CRP gets higher, then what will you do?
Sir, exactly my point, sir. Sir, it has a very low positive predictive value. We cannot say if the CRP is high, we cannot say that it is only due to leak. But if it is normal, we
Now
can.
what will you do for the clinical management? How it is getting
So
applicable?
we will examine the patient. We will keep an eye on the symptoms and patient's
That you
abdomen.
do routinely.
We get an ultrasound, sir.
You get ultrasound.
Yes, sir.
Then what?
Sir, and we keep an eye on the patient. If there is no fever, abdomen is fine. We do not take it as leak.
Okay. Thank you.
Thank you. Thank you, sir.
Next, we call Dr. Utkarsh Anand for the presentation.
Good morning, everyone. My topic is outcomes of enhanced recovery after trauma following non-operative management of blunt liver and splenic trauma and RCT. I'm Dr. Utkarsh Anand from PGIM Chandigarh. So, traumatic patients are constitute 52% of all emergency cases, out of which 26 and 13% are splenic and liver traumas. The current guidelines by World Society of Emergency Surgery recommend ICU admission for patients with grade 3 injuries or higher, planned for non-operative management. Pediatric studies have challenged ICU admission for low-grade injuries managed that can be managed in the emergency department or can be even discharged from the emergency department. We are in alignment with the studies that advocate for early enteral nutrition and early ambulation, similar to the concept of enhanced recovery after surgery. This is a review of literature showing how in 1960s and 70s, most of the patients with liver and splenic injuries were managed operatively, and how we have come forward with non-operative management of most of the injuries. And the current lacuna is whether how frequent investigation or how frequent monitoring is required for patients being managed non-operatively. My study protocol was, we divided the patients into two groups. The experimental group had, on these 6 parameters, they had a less frequent monitoring and an early ambulation or early catheter removal, while the control group were managed according to the standard guidelines. So the RICE tube was removed 24 hours post perforation exclusion, and abdominal breath was monitored every 6 hours. Vital signs were monitored every 4 hours. Ambulation, if the patient was pain-free, the patient was allowed to ambulate after 24 hours. Hemoglobin monitoring every 12 hours. And similarly, in the group B, that is the control group, patients had a more frequent monitoring and a delayed return to ambulation or catheter removal. So the primary objectives were to compare duration of hospital stay, readmission rates, and failure rates in both the groups, while secondary objectives were assessed tolerance to early artery removal and oral intake, early urinary catheter removal, and active ambulation. This was a single center parallel non-inferiority randomized control trial, 1:1 allocation ratio for each arm. 60 patients were included and 30 patients in each group with a study duration of 18 months. Patients having age 18 years or more and blunt liver and splenic injuries grade 1 to 4 were included, while patients who arrived after 48 hours to the emergency or were hemodynamically unstable even after resuscitation signs of generalized peritonitis, patients with pancreatic injury, contrast, leak, or vascular injury on CT abdomen, or who require urgent surgical intervention for non-abdominal injuries, or who are on anticoagulant antiplatelet medicines were excluded. These were the statistical models used. The observation, majority of the patients belong to grade 3 and grade 4 splenic injuries, while the extra abdominal injuries, in 50% of the patients, they had no extra abdominal injuries. And the second most common was the duration of hospital stay for both the groups was not significant. This was one of the primary outcome. The secondary primary outcome was readmission rates within 30 days were also not significantly different between the two groups. Only one patient required readmission in the group A. That was because of a delayed complication bilioma. The third primary outcome, that is the comparison of failure of non-operative management, was also not significantly different between the two groups. Only one patient in group B required an operative management. Coming to the secondary outcomes, toleration of oral initiation in both the groups were also not significantly different. And tolerance to PUC removal and active ambulation was also not significantly different between the two groups. So there was no inferiority in outcomes for both the groups, and only one patient in group B failed non-operative management. Early enteral feeding did not result in more complications in group A, and no patients experienced delayed bleeding attributable to early ambulation. Patients, this study showed that hemodynamically stable patients with blunt liver and splenic injury are managed effectively in non-ICU settings without increased risk of delayed complications, which though rare need monitoring. So the aim of the conclusion of our study was that unnecessary ICU admissions and referral of patients to level 1 trauma centers can be reduced, and this can reduce the prolonged ICU stay of the patients and load on tertiary care facilities. There are no conflicts of interest or disclosures. So the limitations of my study was that it was a single center study with a small sample size and a low event occurrence bias. So because only very few patients in both the groups had a failure of non-operative management. Thank you, sir.
Thank you very much for your presentation. I didn't understand when you are doing a randomized control trial, why you are saying that sample size is a limitation. Because you would have calculated, I saw, where you said it is a non-inferiority trial, but you have used the duration of length of hospitalization as one of the primary outcome.
Yes,
The length of hospitalization in ERAS arm, we expect it to be less. So that
Yes.
becomes a superiority trial. Why you have mixed up the complications and the duration for the outcome? If you have more than one primary outcome, then the samples has to be calculated for all three. So all those problems, I don't know why you invited in this study. Usually samples, the length of hospitalization is one of the primary outcomes that is used for this ERAS protocols. So you have used complications as well as this combination. You have not mentioned in the sample size calculation what is the effect size based on which you have done 30 in each arm. Why you have taken 30 in each arm?
Sir, the sample size was calculated to have a power of 80%, and
no, but reducing the length of duration, how many days? That is not mentioned there.
So the average, I've not mentioned in this PowerPoint, but the average length of duration for the group A was 3 days, and for group B it was 6 days.
No, that is your results. I am asking the calculation. Anyway, it's open for discussion. Your conclusion is very vague. Conclusion should have been, you have told readmission rates, duration of hospitalization. That should have come clearly in the conclusion that ERAS arm reduces the duration. It does not increase the readmission rates, and the third was also one of the complications. That is how it should have come. But
Yes,
you have written so many things in the conclusion which are not aligned with the objectives. Any other questions from the floor? Fine. Thank you. Thank you very much.
Thank you, sir.
Last presenter, Dr. Varsha Vijayan, we invite her for the presentation.
Good morning, everyone. I'm Dr. Varsha from Osmania General Hospitals, Hyderabad. I'll be presenting about pancreatectomy with arterial resection in locally advanced pancreatic tumors. Background, arterial resection during pancreatectomy for pancreatic cancer has long been associated with unacceptable perioperative morbidity and mortality and poor oncological outcome. However, recent insight from high-volume centers has revealed that arterial infiltration can be considered selectively for curative intent resection with acceptable morbidity and in-hospital mortality rate approaching around 5%. The periarterial and the subadventitial divestment helps in R0 resection of locally advanced pancreatic tumors without compromise in oncological outcomes and offers an alternative surgical approach to the morbid arterial resection. So the methods and materials we use data between 2018 to 2024 in our hospital. A total of 16 patients underwent surgery. In that, 7 cases were excluded due to metastasis. 9 patients underwent definitive surgery. The median age was about 46 to 66 years. 1 patient had neuroendocrine tumor. 1 patient had GIST. 7 patients had pancreatic adenocarcinoma. All received neoadjuvant chemotherapy. 1 patient underwent modified Applebee's procedure, that is distal pancreatectomy, splenectomy, and celiac axis resection. 2 patients underwent Whipple's with common hepatic artery resection. 2 patients underwent Whipple with right replaced hepatic artery resection. 1 was reconstructed with GDA and other with IMA. 4 patients underwent triangle operation from SMA abutment or encasement. 1 case, the SMA resection and reconstruction with PTFE graft was done, and the other 3 underwent periarterial divestment of SMA. In all these cases, we achieved R0 resection. The 30-day mortality was nil, but 1 patient with SMA arterial divestment died after 82 days due to COVID pneumonia. The tumor recurrence was noted in 2 cases after 2 years of follow-up. So arterial divestment is done depending on the depth of invasion of the arterial wall. There is periarterial tissue, the nerve plexus outside the tunica adventitia, and divestment is done in a layer between the tunica adventitia and this periarterial tissue. This is periarterial divestment, whereas subadventitial divestment is when the tumor is involving the adventitia. Here the dissection will be done between the tunica adventitia and the tunica media outside the elastic lamina. But there are problems with divestment, like the external elastic lamina is an incomplete layer. Post neoadjuvant chemotherapy, the arterial anatomy will be distorted. And the halo versus string sign in CT, where if there is a string sign present, the divestment might be more difficult. At the points of branching, the divestment will be difficult. Presence of arterial atheroma, inflammatory plaques can make the divestment procedure more difficult, and there is risk of rupture and formation of aneurysm. Now, data which suggests that in most of the cases, the tumor will be involving the tunica adventitia. Hence, we can resort to a divestment procedure instead of the more morbid arterial resection procedure. So these are some of the pictures, intraoperative pictures, the Whipples where there was resection of right replaced hepatic artery, and on the left hand side we can see the replaced right hepatic artery being reconstructed primarily with the GDA. Here, it was a neuroendocrine tumor in the head of the pancreas, which was involving the CHA, the RHA, and the LHA, and the GDA. And we had to remove a part of it, and reconstruction of the right hepatic artery with PTFE graft was done. Here we can see the SMA arterial divestment in the left-hand side picture, the complete divestment of the SMA. The portal vein has also been reconstructed using a graft. Whipples where the SMA and SMB resection and reconstruction was done using a PTFE graft. Modified Appleby procedure done in a tumor which was involving the body of the pancreas, and it was infiltrating the celiac axis. So the distal pancreatectomy, splenectomy, and celiac axis resection was done. We can see the celiac axis ligated in the subsequent pictures, and the post-op CT which shows proper flow of the right hepatic artery and left hepatic artery based on the GDA. Concluding, advanced techniques of surgical resection and vessel reconstruction provide a toolkit for curative intent surgery in locally advanced pancreatic tumors. Multimodal concepts will enhance options for surgery of tumors previously deemed unresectable. Effects of these surgical approaches on overall survival remain to be proven with high-level clinical evidence. The tumor biology is the key in selecting cases for arterial resection or divestment. That's it.
Thank you for your presentation. So you said NSCT was given in all the patients. So what NSCT you give in neuroendocrine tumor?
So folfirinox.
Neuroendocrine tumor also?
No, not for neuroendocrine tumors, sir. The pancreatic adenocarcinomas.
You said NSCT was given in all patients.
No, sir.
One of your patient is a neuroendocrine.
One patient was neuroendocrine tumor, one patient was GIST, sir. It was preoperatively diagnosed, and in those
So
cases, we did not
What
give.
NSCT was given?
For them, it was not used, sir.
So the two patients did not receive NSCT.
No, sir. No.
And what about the post-operative complications? Or post-operative fistula rate, early morbidity?
Sir, it was more or less comparative, sir. And,
But it is not mentioned in this
yes,
one.
sir, I did not mention.
So you just presented the operative success, but what about post-operative complications?
Yes, sir.
Any,
Most of the patients were
No, it's,
discharged within
it's
2
not
weeks.
in the
I-
presentation. That is
yes,
very
sir.
important.
Okay, sir.
What is the message from your, this is a feasibility study or what is it?
Sir, it's still like we have done a few cases in our hospital, sir. So it's under follow-up, and
Okay, it's open for discussion. Any questions from the floor?
With Shastra's bleed.
sorry, sir, I could not hear the question.
Using PTFE for arterial reconstruction in pancreatic surgery, where you're likely to have pancreatic leak, I think that practice should never be done. You'll have torrential bleeding if there is even a minor pancreatic leak.
Dr. Ravish.
Would you like to respond to that, Dr. Varsha? Like you should have, that's what Dr. Yadav mentioned, that you should have told what complications, what are the problems post-op, but you stopped at the procedure level. That is what is the question that is raised. Yeah.
What I would have really liked to know from your study is, what was your mean follow-up? I followed these patients. How many did you follow up? What was the mean follow-up, and how long did they survive? Because ultimately the issue is survival. If you tell me no, they are as good as everybody else, that's great. But if not, survival is only 6 months, and I say, okay, it's not for me. So what was your follow-up, and how long did they survive?
Sir, over to the study we have started from 2018, sir, and of the patients we had recurrence in 2 patients, sir, during follow-up, and the rest are doing well, sir.
Any other questions from the floor? No further questions are there. Thank you. Thank you, Dr. Varsha,
Thank you,
for
sir.
presentation. Thank you. That concludes the session with all the 6 presentations for the special mention poster. Thank you very much.
Thank you, everyone. Thank you, the judges. And so we'll begin with the next session, that is landmark publications. And we have the first topic is on foregut, and the presenter is Dr. Arun Kumar. And for chairing this session, I would like to invite Dr. Mahesh Thomre, Dr. Sanjeev Patinkar, Dr. Sunil, and Dr. John Griffson.
Meanwhile, the chairpersons, while they take their places, can I request the, yesterday I had introduced the IASG website. We are in the process of upgrading it. So this is a small video from our web manager, 2-minute video. Kindly have a go through it. And we're trying to upgrade a website just for introduction purpose. And then we can continue the session.
Welcome to a new era of iasg. Place for your professional journeys. A dynamic digital space, powered by Muna, designed to provide an intuitive place to connect, share, and grow. A gateway to the world of benefits. Seamlessly connect with colleagues, access exclusive resources, and stay updated with the latest in surgical gastroenterology. Connect with your peers like never before through topic-based discussion. Share insights, collaborate cases, and engage in meaningful conversations with fellow surgeons. Effortlessly manage your member profile and control the visibility of your data. Update what's visible to others in the Find a Surgeon page and easily access your digital credentials and certificates. All in one place. Experience the future of iasg with a new platform designed to enhance connection, engagement, and professional growth. To get started, visit www.iasgindia.com and log into your exclusive member page today. Or download the Community app, Play Store or App Store, and log into the IASG community.
So we'll begin with the session.
Distinguished chairpersons, my dear teachers, friends, good morning. My health is not very well. I am having running nose and sore throat. My apologies for the same. Let's move to landmark publications in the forget in the last 2 years, thanks to the wonderful team of the partner team, as well as the IAC office bearers for this opportunity. In want of time, I selected only 2 papers. One is about adenocarcinoma of the esophagus. The second one, the same thing about stomach. So this is ESOPEC trial. Most of the inputs have been, I copied from the ASCO 2024 annual meeting from the Master Hepner. So the background of the study was, on one side, the perioperative chemotherapy, especially the magic behind the magic trial, where the ECF-ECX surgery improved the overall survival and disease-free survival in adenocarcinoma of the esophagus. Which was from 2017, we have the FLOW trial, which definitely showed some superiority with good perioperative outcome in terms of overall survival as well as disease-free survival. So FLOT is more or less the standard of practice in locally advanced non-metastatic adenocarcinoma of the esophagus. There we have this, on the other side, we have the preoperative chemoradiation, that's a cross trial, which significantly showed up to 29% of pathological complete response, along with good overall survival, disease-free survival, and an excellent loco-regional control. So the control arm will be the perioperative chemo, the float magic stuff, and the experimental arm will be the cross trial. So this is published in 2024. It's a prospective, randomized, multi-center phase 3 trial comparing perioperative chemo, the FLOT protocol, to neoadjuvant chemoradiation, the cross protocol. That was done from 25 German centers from February 2016 to April 2022. And the inclusions were histology should be adeno, and the stages should be T1, N1 or T2 to T4A, N0 or N1, M0. The exclusions, other histology than adeno, gastric cancer, and metastatic disease. Total 438 patients with a median follow-up of 55 months. Even while during follow-up, 218 deaths occurred, 97 in the float group and 121 in the cross group. So the regimen will be the control arm, the perioperative chemo with float, wait for 4 to 6 weeks surgery, then continue with the same course, another 4 cycles of chemo. In the experimental group, the cross trial with 41.4 gray radiotherapy, then 5 cycles of chemo in 5 weeks, wait for 4 to 6 weeks, followed by surgery. The primary endpoint was overall survival. In addition, the secondary endpoints, progression-free survival, post-pathological stage, complications, adverse events, relapse-free survival, site of tumor recurrence, and quality of life. So the control group versus the experimental group, more or less the patient demographic factors like age, sex distribution, performance status, T and N stage are similar. Then the post-operative complications, we have a fear of radiotherapy prior surgery, but still the complications in both groups fared similar. Whether it is, and the Clavien Dendo 4 type was around 6.8% in float versus 4.4% in cross. The post-operative mortality, 30 days and 90 days, again almost similar. The pathological response, maybe to our surprise, the float group had more chance of pathological complete response, that is around 16.8% versus 10% in the experimental cross group. But rest all things are faring similar. But when it comes to progression-free survival, the intention to treat analysis population showed the red curvature definitely has a better survival. That is, a float group has a better survival compared to the preoperative radiotherapy group. In the intention to treat analysis, the overall survival and the per protocol population also, the float group has a better survival compared with the cross group. So overall survival in exploratory subgroups in terms of sex distribution, age, performance status, T status, N status, it's almost having the same pattern. The plot is showing a shift towards supporting the float trial. So ESOPEC trial finally concludes saying that perioperative chemotherapy, the float plus surgery improves overall survival compared to neoadjuvant chemoradiation, the cross group plus surgery for patients with T1, N1 or T2 to T4A, N0 or N1, but M0, esophageal adenocarcinoma. Perioperative chemotherapy, float should be preferred over neoadjuvant chemoradiation. That's a cross protocol for improving survival in resectable esophageal adenocarcinoma. That's about the ESOPAC. Further thoughts, definitely we know, but squamous we will always give radiation. We would like to know if there is a subpopulation to address on squamous. The next one is a Top Gear trial, the trial of perioperative chemotherapy for gastric and esophageal junction adenocarcinoma, NEGM, published in NEGM in September 13, 2024. Here, the randomizations between preoperative chemoradiotherapy and perioperative chemotherapy for resectable gastric cancers, adenocarcinoma, from 4 groups combined together for this data with a median follow of 67 months from September 2009 to May 2021. The eligibility is, it should be adeno, stomach and G junction type 2, 3 are taken with this study, but type 1 will go for the esophagus, T3 or T4 lesions, and N0 or N1 with a good performance status. So the initial conventional group will be the ECF or ECS till 2017. From 2017, the float with perioperative chemo, but which is compared with a preoperative chemoradiotherapy group. That is 1 cycle less of chemo, wait for 2 to 4 weeks, chemoradiation, and then the same post-op chemotherapy after surgery, which we will do after 4 to 6 weeks. So baseline characteristics almost same, distributions everything same, but two or three definitely advantages for the preoperative chemoradiotherapy group will be a higher percentage showed pathological complete response, more tumors showed radiological downgrading, downstaging, and less chance of you are getting a node positive disease after preoperative chemoradiation. But just we mentioned 3 important advantages for the preoperative chemoradiation group, but just look at the survival. No significant difference in overall survival and progression-free survival noted. The 2 curves actually, they just go together, they merge together. Median progression-free survival was 31 versus 32 months, not much difference. The overall survival, again, adding chemotherapy, radiation beforehand does not imply any good overall survival. The results are no even surgical results, we may have a fear that it could be an increased post-surgical complications, but it is almost same, especially the grade 3 clavient endo or higher complications. And the mortality rates were also same. So addition of preoperative chemoradiation doubled the percentage of patients getting a pathological complete response, improved tumor downstaging, lower percentage of patients completed the postoperative chemotherapy. That's a problem with preoperative chemoradiation. But no improvements in overall survival or progression-free survival. So the second trial concluded by saying that the addition of preoperative chemoradiation to perioperative chemo in T3, T4 adeno M0 stomach did not improve overall survival as compared with perioperative chemo alone among the patients with resectable gastric and GE junction adenocarcinoma. So preoperative chemoradiation should not become a routine standard of care. That's about the Top Gear trial. The strength is they have assured quality in every radiotherapy schedule, the type of surgery. Most of the surgery were D1 plus or D2 resections of nodes, and almost all specimens yielded more than 20 number of lymph nodes. A subgroup analysis could be better, like adenocarcinoma of the mid-body, distal, or a localized form of linitis. Could it behave differently? A distal stomach lesion with acute or subacute outlet obstruction, whether we can include this into upfront surgery or versus such protocols. But the problem is control group will have both ECF regime as well as a float, because that is just because of the timeline, because they have a huge database from starting from very early onwards. So 2017 made a difference to err on float side. It may be immature to make such a comment from these two trials, but maybe one message which I got, maybe right or wrong, is with more of systemic therapy, including immunotherapy, the loco-regional control of disease in adenostomach and adenoesophagus is with surgery, and radiotherapy may potentially wean off in this panel of adeno. That's what I mean, of stomach. Thank you so much.
Do you think the radiotherapy can induce, obviously, in some patients, complete pathological response? So to detect the difference, you require probably more number of patients or a longer follow-up, more than maybe even 5 years, to show some difference.
Yes, sir. Probably their next publication will give us at the end of 3 to 5 years. Definitely, yes. Squamous, there is no doubt. That's what, I mean, we have limited number of patients, but still we feel squamous esophagus, definitely radiation has more role compared to adeno.
In the first paper, there was a poor survival in the cross group. So is it actually due to the effect of radiation as such, or what do you feel? Because we all know that operating following radiation, there are added complications. So is there any relationship between the increased mortality due to the increased mortality and morbidity in the post-operative period?
I think I should agree with that, because in esophagus as well as stomach, after radiation, the surgical difficulties, length of surgery, intraoperative crystalloid use, transfusion rates, hospital stay are definitely higher. So it could be one of the reasons for this.
Any questions from the floor? Thank you very much, Dr. Arun Kumar.
Thank you.
And we'll
Thank you,
go
sir.
on to the next presentation.
Hi, good morning, everybody. Thank you to the organizers for asking me to present in this important landmark publications session. When I was going through all the landmark publications of the last couple of years, there are quite a few. So I've tried to divide 3 or 4 in rectal cancer and a couple in colon cancer. So when we come to rectal cancer, one of the first important things in the last couple of years, there seems to be a step towards patient-centric treatment in decision making. So the two important trials which have tried to address this, the CONVERT trial and the PROSPECT trial, in there they're trying to see whether reduction of radiotherapy to these patients is going to improve or affect in any way the 3-year disease-free survival. In both, the outcome is the disease-free survival at 3 years, which is still to be achieved in the CONVERT trial and the PROSPECT trial. So what they've tried to do is to try and achieve complete clinical response for organ preservation. They've tried to omit radiotherapy in these two trials and see. So in the CONVERT trial, only 2 patients in the adjuvant chemotherapy group achieved complete clinical response. So the complete clinical response rates are much lower compared to the other conventional total neoadjuvant treatments, but the overall organ preservation and the patient tolerance seems to be much better. So the final conclusion in this paper, which assessed both these CONVERT and the two trials, there seems to be a growing need to shift back to patient needs, which seems to avoid radiotherapy because this seems to keep the same results and similar disease-free survivals without really affecting patient morbidity, improving patient morbidity. The second important thing is the evolution of total neoadjuvant therapy. As you know, total neoadjuvant therapy is where you give your neoadjuvant treatment and you give the post-operative chemotherapy that you give normally after the surgery. You give consolidation chemotherapy before. So there is a network meta-analysis and a systematic review in JAMA 2024, which tries to assess a total neoadjuvant therapy and tries to put it in overall perspective. And they say there says to be a lot of advantages to giving total neoadjuvant treatment in rectal cancer because the number of patients who get complete clinical response, the number of patients who get complete pathological response seems to be much higher. The third important study or landmark that we see published in ANZ Journal of Surgery in 2022, a lot of Indian data also in this. There's a clear demarcation now that if you do an intersphincteric resection or an ultra-low anterior resection, the results with intersphincteric resection seem to be much worse in all the Wexner scores, incontinence scores, stool fragmentation, antidiarrheal medication dependence. So there's a clear movement towards not doing intersphincteric resection compared to an ultra-low anterior resection. So if you see the functional results also, there seems to be a much worse off effect in if you do a intersphincteric resection. The last one in rectal cancer is the robotic surgery in LAR syndrome. So there's this important paper which has come up in surgical endoscopy, surprisingly, published recently, where the major endpoint comparing laparoscopic and robotic surgery is the LAR scores. So at 18 months postoperatively, the LAR scores were lower in robotic surgery. So this is one of the first data which tells us that robotic surgery, at least compared to laparoscopic surgery for low rectal cancer, may improve patient results. The long-term results of a 2-stage Turnbull catheter pull-through procedure. So a lot of, again, to patient-centric care, this new procedure, actually it's a very old procedure and they have tried to use it for low rectal cancer in a randomized clinical trial where there's a standard hand-sewn coloanal compared to a Turnbull pull-through procedure. When you do the pull-through procedure, it's done in 2 stages and you can avoid an ileostomy because at the first stage you don't do a coloanal anastomosis, you do it at a second stage. So apart from the avoidance of ileostomy, so it reduces the morbidity substantially, there is no change in the overall patient outcome. So they suggest that in this randomized trial where they have randomized 92 patients, the Turnbull cutate procedure, the biggest advantage is that even though all the oncological results are the same, you can completely avoid an ileostomy. This is a very good small trial published from Finland, multi-center double-blind placebo-controlled trial in which they added oral placebo with oral neomycin and metronidazole to the standard mechanical bowel preparation. And the primary outcome was overall cumulative postoperative complications, which definitely are better or reduce postoperative complications if you add neomycin and oral metronidazole to the patients with rectal cancer surgery. For colon surgery, one important landmark publication this year, published in Annals of Surgical Oncology, as you know that a locally advanced colon cancer, we still go for surgery first. So here they have said that the R1 resections, or especially the right-sided surgeries, where the majority of the mismatch repair deficient gene comes. So as you know that right-sided colon cancer is more aggressive in terms of its genetics, and the mismatch repair gene deficiency is the main reason for it. So here, this paper, they have suggested that if you, in the phase 2 niche trial, that if you give these patients immunotherapy, so this is where one of the few areas where precision oncology may be actually useful, where 111 patients with a repair deficient colon cancer mismatch gene was given a 4-week treatment with nivolumab and ipilimumab. And you can see here that in this niche 2 trial and the PIC trial, where they have given 12 weeks of toripalimab, there is a large number of pathological complete responses. So there is a suggestion after these 2 papers that patients with right-sided colon cancer or those with mismatched repair deficient colon cancer should be given the neoadjuvant treatment with this prior to resection, unlike most colon cancers where we do an upfront resection. The 2 papers on ICG and anastomotic perfusion in the last 2-3 years have created a lot of interest in ICG for anastomotic perfusion. As you all know, the 2 big trials are the AVOID trial and the Essential trial. So both these trials have got different results. The AVOID and Essential trials both show that at the end of the day, if you have a colonic anastomosis, this is Essential trial is a much better trial in many ways. It tells us that if using this ICG is definitely not inferior, and there is a benefit in terms of the number of patients who have anastomotic leak. So in the ICG group, the leak rate was 7.6% versus the no ICG group where it was 11.8%, because they were able to revise the anastomosis in patients where the ICG was not perfusing. However, the AVOID trial is not able to prove that. I would still go because it's so easy to use, it's not very costly, that it is a very easy addition to your colonic anastomotic surgery. Even if it reduces the leak rate in a small percentage of patients, it could be very useful. The Essential trial is also very well conducted. It's published in the Annals of Surgery last year, exactly a year ago, and it's randomized, and it's a very large study with 850 patients. And there's an editorial published this year in the Lancet, which says that really it's a simple, inexpensive way to, an easy to interpret adjunct for bowel perfusion. So really, it's especially for left-sided surgeries, you should try to use ICG. So I think this is the few landmark papers that I found in rectal cancer and colon cancer published in the last couple of years. Thank you.
Thank you very much. That was a lot of information. Yes, there has been so many interesting articles. I would focus just on one of them, which is your first article that you presented, whether preoperative radiation can be omitted. I think that would be the most interesting concept. If we can fit the chemotherapy to the type of the patient, the biology of the tumor, omitting radiation has the highest benefit that I can see. Traditionally, we have always considered that the benefit of the neoadjuvant chemoradiation is that the cells are killed by, it's a radiation kill effect, and the chemotherapy simply enhances the radiation kill effect. So now we are looking at different perspectives altogether. And when you have a patient who gets preoperative radiation, that is what then mandates that no matter how good the anastomosis looks, the anastomosis needs to be protected by a loop ileostomy. I mean, I have had very harsh, eye-opening results from the patients. So what would
I
you
think
say?
both the trials, the important thing to remember is that in one of the trials, most patients had no demonstrable nodal disease on the MRI. So they were T3 or early T4 disease, but with N0. The other trials have included N plus disease also. So they're trying to, the conclusion of both is that they're both small studies, and this is just a suggestion. But I think this is a space to watch.
Yeah,
because
larger
in the
numbers
next
are
2-3
needed.
years, if you're able to, in selective groups of patients, now exactly what the selected group is, I think a T3 N0 on MRI is a very good group to start with, because if you don't have disease in the mesorectum at all, then this is a good group you can start without, giving any preoperative radiotherapy.
I think this is just the start. A lot of studies need to be conducted
Yes.
to confirm this. Thank you.
Any questions from the floor?
Thank you.
None. Thank you very much.
Thank you.
Next, we have Dr. Piyush Varshney from Jodhpur, presenting papers, the landmark papers on HPB.
Good morning, everyone. At the outset, I would like to thank the organizing and the scientific committee for this opportunity. I'm going to present the landmark publications under the three following headings. First is the pancreas. The first trial is the effect of robotic versus open pancreatenectomy on post-operative length of hospital stay. This is a multicentric trial conducted in China, published in Lancet Gastroenterology and Hepatology with an impact factor of 30.9. The authors claim to be this as the first and the largest trial published so far. So they included 78 patients in the robotic arm and 76 patients in the open arm. The primary outcome was post-operative length of hospital stay, and secondary outcomes were operative time, blood loss, and other post-operative complications. If you look at the results, the operative time and the estimated blood loss was less in the robotic arm as compared to the open arm, and that was significantly better. The important thing to note that the operative time was less in the robotic arm, and this is in the contrast with the previously published retrospective studies that say that the operative time is longer in the robotic arm. Coming on to the primary outcome, the hospital stay was less in the robotic arm, and it was also statistically significant. Other parameters reflecting the outcome of surgery like lymph node harvest, tumor positive nodes, and positive resection margin were similar in both the groups. Other post-operative outcomes like post-operative recovery days and nasogastric tube removal were also better in the robotic arm and was statistically significant, although the difference was only 1 day, but were found to be statistically significant. Other complications like POPF and hemorrhage and bile leak were similar in both the groups. Important thing to note was that time to first adjuvant therapy was 42 days versus 48 days in the open arm, and that was also found to have statistical significance. Whether this will impact the long-term implications is still unknown. So they concluded that the robotic PD is safe and feasible with advantage of shorter post-operative length of hospital stay, and future research should focus on medium and long-term outcomes. Limitations include generalizability, cost was not analyzed, quality of life was not seen as it is a complex procedure, so masking was not done for the surgeons and the patients, and whether this 2 days benefit of hospital stay will impact a real clinical benefit is still unknown. And as there are almost 4 randomized trials between laparoscopic and open PD, none of them have published the long-term outcome, so will the long-term outcome will be there or not, still not known. Next study in the pancreas group is the neourgent FOLFIRINOX, comparing the neourgent FOLFIRINOX with upfront surgery in the resectable pancreatic head cancer. This was also published in Lancet with impact factor of 30 and was conducted in Nordic countries, and this is the first trial to use full dose FOLFIRINOX in the neourgent setting. So they included 61 patients who received neourgent FOLFIRINOX, and finally 77 patients were included in intention to treat analysis in the neourgent arm and 63 patients in the upfront surgery arm. The primary outcome was overall survival at 18 months with secondary outcomes of progression-free survival, mortality, overall survival, and complication rates. So if we look at the results, the proportion of the patients alive at 18 months was 73% in the upfront surgery arm versus only 60% in the neourgent arm, and that was statistically significant. And the secondary outcomes like overall survival and progression-free survival were better in upfront surgery, and the difference was significant, 38 months versus 25 months. Important thing to note that the almost equal number of patients reached surgery in both the arms. And as neourgent therapy has good effect, so the venous resections were less in the upfront surgery arm as compared to neourgent arm versus upfront arm. Other parameters that reflect the advantage of neoadjuvant chemotherapy like lymph node status and arterial resection were better in the neoadjuvant chemotherapy arm. As the histopathological proof was not mandatory in the upfront arm, there were other pathologies also that were included in the, although they were present in the other arm also, but these were more in the upfront surgery arm. Important thing was that almost 57% of the patient required preoperative biliary drainage because of the starting of the neoadjuvant therapy. So that led to the increased time. Although 82% of the patients reached surgery, but only 60% of the patients were able to complete all the 4 cycles. And the main reason was toxicity, followed by decrease in the performance status and metastasis. As we can see the Kaplan-Meier curves, the overall survivor as well as the progression-free survival was better in the upfront surgery arm, and similar was found in the protocol analysis. So this is the summary of the trials that have specifically looked at the resectable pancreatic cancer, indicating the neoadjuvant chemotherapy or chemoradiotherapy. So current trial shows a survival of 25 months versus 38 months. Other trials have showed modest benefit with neoadjuvant chemotherapy, but this is the only trial that have shown no benefit with neoadjuvant chemotherapy, rather a benefit with upfront surgery. So if we look at the survival with neoadjuvant chemotherapy, it is in line with the previously published studies that compare the neoadjuvant chemoradiotherapy or chemotherapy. But in the upfront surgery arm, the survival was far better as compared to the previous surgeries that have been published previously in the literature. So they concluded that it did not show a survival benefit with neoadjuvant FOLFIRINOX. So there were several limitations. One important limitation was that the workup for histological proof and biliary drainage led to the increased lead time before starting neoadjuvant therapy. That might have led to the patient's progress to metastasis or deterioration in the performance status and lead to the survival. Coming on to the biliary, the first article is the prognostic impact of neoadjuvant chemotherapy in localized or local regionally advanced gallbladder cancer. This is a propensity score matching analysis done by Chinese authors of American database, published in Cancer Control with an impact factor of 4.3. So they included almost 2,676 patients and did a 1:3 PSM analysis with nearest caliber value of 0.05 and included 78 patients in NSCT arm and 234 patients in non-NSCT arm. So as we can see, after propensity score matching analysis, all the blue dots are within the 2 standard differences, and they were able to match all the parameters. Finally, in the NSCT arm, 78 patients were included, and non-NSCT arm, 234 patients were included, out of which 67 and 195 patients underwent radical surgery. As we can see the Kaplan-Meier curve, the survival benefit was there. The overall survival and cancer-specific survival was better in the NSCT arm when the entire cohort was taken, and the similar results were found when only the radical surgery groups were taken. They also did a univariate and Cox-variate analysis for the factors affecting overall survival and cancer-specific survival, and they find out that neoadjuvant chemotherapy is one of the factors that affects the overall and cancer-specific survival, apart from the stage and the patients who underwent radical surgery. There's several limitations. It is a retrospective study. It is only an American database analysis, and sample size in the NSCT arm was less, and also the specific regimen of the NSCT was not mentioned in this paper. Just a quick follow-up with this study with the Indian study from Tata Memorial Hospital of perioperative outcomes of 1,300 consecutive patients. They were published in European Journal of Surgical Oncology with impact factor of 3.5. Although this paper had looked at many other factors, the important thing was that 254 patients received neoadjuvant chemotherapy in locally advanced gallbladder cancer according to the TMH group. But when they divided these patients on the pathological T and N stage, there was a tendency to give neoadjuvant chemotherapy to more locally advanced patients. They did analysis for median overall survival and disease-free survival, but that was similar between the direct surgery and the neoadjuvant chemotherapy arm. But when they matched these patients with pathological T and N stage, the disease-free survival was better in the neoadjuvant chemotherapy arm. The important limitation of this study was that the matching was done after pathological T and N stage rather than clinical T and N stage. And coming on to the last publication from the liver is the use of atezolizumab with bevacizumab versus active surveillance in patients with resected or ablated high-risk hepatocellular carcinoma, IM Brave 050, a randomized open-label multicentric trial. This was published in Lancet with an impact factor of 98.4 and was conducted in multiple countries of USA, Japan, South Korea, France, Singapore, and this is the first positive trial implicating the results. After IM Brave 150, this regimen has become now almost standard of care in unresectable SCC. The authors wanted to look in the resectable SCC in the follow-up period. So this was the criteria of looking out the patient high risk recurrence based on the European study of liver diseases. And these patients received 17 cycles of dual inhibition in 1 year. Almost 334 patients was included in each arm. And we can see the Kaplan-Meier curve. The recurrence-free survival was better in the dual inhibition therapy arm. And it was statistically significant with a hazard ratio of 0.72. And there was 110 recurrences in the immunotherapy arm versus 133, that is 40% recurrence in the active surveillance arm. So the authors concluded that giving dual inhibition immunotherapy improves the recurrence-free survival. Although longer follow-up is needed to comment on the overall survival, and the ongoing trials will also provide an insight regarding the benefit of immunotherapy. To summarize, in the pancreas, robotic pancreadenectomy has an acceptable short-term outcome in experienced centers. Neourgent chemotherapy in the resectable pancreatic cancer should be given with caution, as it can delay treatment in potentially non-chemoresponsive patients. In gallbladder, neourgent chemotherapy improves survival, and in liver, adjuvant therapy with dual inhibition immunotherapy improves recurrence-free survival in hepatocellular cancer after surgery or ablation. Thank you.
Any question? Yeah, Dr. Sudeep.
Very well presented. I'll ask you a couple of questions.
Sure, sir.
In the Lancet article that you quoted on robotic surgery, there were 2 articles.
Yes.
The first you mentioned.
Yeah.
You not mentioned anything about the Europa trial.
Yeah.
Would you like to tell us something about that firstly? And secondly, in this paper that you quoted, if the robotic surgery was so superb and the patients recovered so well, why is it that the shortest patient stay was 11.5 days? If you see the gap, is that your standard practice, that the Whipples goes very smoothly and the minimum stay is only 11.5 days? So 2 questions on the robot.
So regarding the Europa trial, sir, although that was published in the other Lancet journal, I have not presented that article because there were many flaws and the sample size was less. And the authors themselves concluded in the discussion that the learning curve was not surpassed, and there was 23% conversion in the robotic arm. And there was small sample size, only 19 patients in the robotic arm.
Yeah, but this is the largest center in the world doing pancreatic surgery.
Yeah, that was...
They had done a minimum of 40 robotic Whipples. Don't you think that they're not inexperienced? So robotic may not be as smooth as made out by the study you presented. That is the only point.
Yeah, I agree, sir. Regarding them, sir, they have a strict protocol of discharging the patient's objective criteria when the patient is taking oral diet, able to ambulate so and so distance, and able to do the daily activities. So maybe based on that criteria, their hospital stay was 11.5.
If you have an uneventful Whipples, don't you think the patient fulfills all that in 6 and 7 days?
Yeah,
Then
I
why
agree.
11.5 is the minimum stay?
Yeah.
Yep, thank you.
Thank you. We have run out of the time now. Thank you very much.
Thank you, sir.
Thank you, chairpersons and the presenters. So actually, since we are running before time, so we'll be taking a short tea break, and we'll gather at 10:50 and we'll start the next session, that is oration, on time at 11 o'clock. Thank you.
Hi, doctor.
Good morning, everyone. Now we are going to commence the most awaited and prestigious oration for year 2024. Veerabhai J.R. Das Agrawal oration. I would like to call upon Dr. Piyush Sahni on the stage for the oration, and Dr. Rajneesh sir, Dr. C. Khandelwal sir, and Dr. Subhas Gupta sir on the stage. Dr. Subhash Gupta sir, Dr. Rajneesh Kumar Singh sir, and Dr. C. Khandelwal sir to chair the session. I would like to call Dr. Rajneesh sir to take the proceedings forward.
A very good morning to all. Dr. Khandelwal is not here. Can I request Dr. Khandelwal to come to the podium, please? Gives me great pleasure to introduce Professor Piyush Sahni as the orator for the Veerabhai J.R. Das Agrawal oration. May I request our incoming president, Dr. Subhash Gupta, to kindly honor Dr. Piyush Sahni with medallion and a bouquet. The Veerabhai J.R. Das Agrawal oration was actually had a very interesting beginning. When this organization was started by our founder secretary, Dr. R.C. Aranya, there was no money. And there was this businessman, rather a surgeon from New Delhi, who came forward and donated the initial corpus on which today our organization stands. And so to honor him, an oration was instituted in the memory of his mother, Mrs. Veerabhai J.R. Das Agrawal. And we have continued this for a fairly long time. Initially, it was to be delivered by the president of IASG. Thereafter, in 2016, it was decided that a specific way of selection would be constituted, and any eminent member of IASG would be eligible for applying for this. A galaxy of eminent speakers have delivered this oration. Here is a list for the perusal of this audience. From Dr. Khanduri as one of the initial speakers, we have Dr. Amresh Adhanari in 2023, who delivered an oration in Hyderabad, title being Lessons Learned in Lifetime of GI Surgery. It gives me great pleasure to introduce Professor Piyush Sahni as the orator of this year. Sorry, the title shouldn't be there, but okay. Give me a second. I really don't need his CV to introduce him, because it's been a long time I've been associated with him as a teacher, as a mentor, and I have regarded him as an elder brother in advice for a whole lot of medical, surgical, as well as life issues. And I think a host of other people in this audience have the same experience. Started his career as a medical student in AIMS in 70s, and graduated to becoming a faculty in, I think, 1992, from one of the founding members of Department of GI Surgery at the All Indian Institute of Medical Sciences, New Delhi, along with the legendary Professor Sumiran Nandi. From there, he's trained a whole lot of people who are now part of this audience as young as well as senior members in the surgical gastroenterology community. Published extensively, he's got a very rock solid background of research and research teaching as well.
Gives me great pleasure to request Professor Piyush Sahni to deliver the J.R. Das Agarwal Veerabai oration for this year. Please put your hands together.
Morning, everybody. Gratitude to the Indian Association for Surgical Gastroenterology for giving me this opportunity. Thank you for that introduction, Rajneesh. So I'm going to talk about understanding the pathophysiology of acute pancreatitis, some insights from studies on animal models. You'd wonder why I would choose this kind of a boring topic. Animal models, nobody works on, nobody knows anything about them. We don't use it in our day-to-day practice. Why didn't I talk about something on clinical research? Portal hypertension has been spoken on 2 or 3 times previously in this oration. I thought that was not something I would want to do. Life experiences, well, I keep talking about them all the time, so I talked about it here. So I thought we'd done some work with animal models in pancreatitis, both acute and more recently chronic. Some of this has been presented at various meetings, but little of this has been published for various reasons. Some work is going on, some the results weren't great, some we tried to publish but didn't publish because journals didn't like what we sent to them, but still others we have published. It's a useful thing to understand some disease processes. It's very useful to my mind for youngsters to work in an animal lab because it allows them, gives them skills to work with fine instruments in small animals in small spaces. Helps you in your routine clinical work. Also tells you how to collaborate with other people. You can't do everything on your own, so you need some help somewhere. Another department, a person working in the lab itself, so on and so forth. But more importantly, I hope to motivate some of you sitting in this audience, youngsters at least, think about working with animal models because it's something that can be exciting at times. So a little background about acute pancreatitis. All of you know this, and about 20% of patients develop severe acute pancreatitis with a high mortality. There have been a number of advances. We've improved our understanding. We assess severity better. Early enteral nutrition we know is good for these patients. You don't need to give them antibiotics. Don't need to intervene early with ERCPs. Probably you've understood the importance of fluid resuscitation, though I have a query there because there's again a rethink on some aspects of this. And we've obviously improved ICU care. However, we haven't changed mortality much over a period of time. The major determinants of mortality seem to be organ failure, which comes because of systemic inflammation, and infected necrosis, which is largely because of the local injury to the gland. And the persistent organ failure seems to be the cause of mortality. So there's the early organ failure, which tends to happen early on along with the necrosis, and then with the infection setting in comes a late organ failure. Both are associated with a higher mortality. Animal models allow us to understand some of these pathophysiological changes, and if used appropriately, we could look at possible therapies to intervene at different points in time in this disease. Now, different models available, animal models of acute pancreatitis, 2 broad groups, the non-invasive and the invasive models. Amongst the non-invasive models is the cerulin model, where a variety of animals can be used, rats, mice, dogs, hamsters, and different routes, intravenous, intraperitoneal, subcutaneous, though the most common one used is the intravenous route. You can control the infusion rate, and timing and severity of acute pancreatitis can be controlled in these. They're usually simple to create and cheap, not very expensive, don't need too much by way of paraphernalia. but they cause only mild acute pancreatitis with a low mortality. Therefore, not suitable for assessing certain things that you want to assess in patients with acute pancreatitis. The other non-invasive model commonly used is the L-arginine model, which has a high reproducibility. You can do an experiment in it and you will be able to reproduce it more often than not. There's selective dose-dependent pancreatic acinar cell necrosis. Depending upon how much you give, you get necrosis. And suitable to study the early and late phases of acute pancreatitis. Also, it's an interesting model because you can look at extrapancreatic organ damage and assess that and the mechanisms of the extrapancreatic organ damage. There are other models available, an alcohol-induced model, which is really very inconsistent. There's a diet-induced model, but can be used only in female mice and requires a fair amount of supervision as to what diet is being given to the mice. There's an immune-mediated model, which is difficult to maintain and time-consuming. And there's a gene knockout model, which is expensive. So we haven't used any one of these. The ones that we've used are the first two models. Then there are the invasive models, and we looked at the first one is the duct ligation model, and this is a model that we have used. It avoids any artificial drug use, which could possibly cause unwanted systemic effects. It's technically difficult to perform, especially for non-surgical colleagues. People who don't have a surgical background, they find it difficult to use these. But for a surgeon, it's not too tricky or too difficult to perform. All that you need to do is ligate the common biliopancreatic duct in the rat. It causes a clinical syndrome that resembles organ failure that's seen in humans, and therefore you can assess these animals for this purpose. The other invasive models are a closed duodenal loop model, requires a surgical intervention. The problem is that non-physiological pressure levels are created within the duodenum because you close the duodenum on both sides. And then there is the question of whether there is a role of bacterial transmigration and bacterial infections happening in these patients. It's not used very commonly. It has been described, has been used initially, but then most people stopped using it. There's an antegrade pancreatic duct perfusion model. It's reliable, it's reproducible, but you need larger animals to be able to do this. It's difficult to do with small animals. You can assess potential therapeutic agents again using the antegrade pancreatic duct perfusion model. The other models are the biliopancreatic duct injection model, probably not very relevant in the sense that it doesn't replicate a human condition very similarly. And there's the vascular induced models, which can be microcirculatory disturbance, pancreatic artery occlusion, or pancreatic venous occlusion. These are relatively inexpensive, but they cause an unequal severity of acute pancreatitis in the same experiment in different groups of animals. Again, you need large animals, and the surgical procedures are more time consuming, and therefore again not very popular. We used the duct ligated opossum or possum model, and we didn't have access to these animals, and therefore we didn't use this either. So in the invasive groups, we've used the cerulin, the L-arginine, and in the invasive group, in the non-invasive, the cerulin and the L-arginine, and the invasive group, the duct ligation models. Now, these studies have been going on for about 15 odd years. In the period 2009 to 2013, we used largely the non-invasive models. And from 2014 to 23, when some of our MCH residents started doing these studies as well, we started using both the invasive as well as the non-invasive models, because it was easier for them to perform these surgical procedures on these animals. So amongst the first study that we did was to study the difference in severity of pancreatitis in 3 different models. And essentially what we were trying to see was which was the model which would suit us best in the studies as we went ahead. And we used Prague daddy rats, severe acute pancreatitis models we created. Ligation of the common duct was one model. Infusion of saline was the second, and infusion of sodium taurocholate, which was a reasonably popular model with our non-surgical colleagues, was something else that we used. The attempt was to see whether there was a difference between these three models and which one suited us the best. So the duct was cannulated. Sodium taurocholate infusion showed, following the sodium taurocholate infusion, you can see the blue arrow showing gastric ileus, the red arrow showing an inflamed edematous pancreas, and the yellow arrow shows the duodenum. In the duct ligation model, the blue arrow shows you the hemorrhagic pancreas, and the red arrow shows you the liver above that. If you looked at pancreatic injury scores in these groups of patients, or in these groups of animals, so all these experiments were done with one sham group, and depending upon what agents were being used, we also used a vehicle sham model as well, where we used the substance that was being injected but didn't use the acute pancreatitis model to see whether any of these changes tended to occur in these patients. We looked at the duct ligation, sodium taurocholate, and saline infusion models and found that the pancreatic inflammation and combined injury scores were significantly higher in the intervention group compared to the sham groups. There was not much difference between the pancreatic inflammation and the combined scores in the duct ligation or the infusion models. And there was no significant difference in the grade of inflammation in the kidneys and the lungs that was seen at that time. So we found that basically the duct ligation model as well as the infusion model seemed to work equally well. And subsequently, we tended to use amongst the infusion models, preferred to use the duct ligation model rather than the infusion model. As a part of this study itself, a second part was to look at the effect of anti-cytokine therapy on severity of experimental acute pancreatitis in rats, both in the duct ligation as well as in the infusion models. The three sets of photomicrographs shown here. The upper two are the pancreas and the lung, and the lower one is the kidney. The left-hand ones are without the use of thalidomide, while the right-hand parts of these are with the use of thalidomide. And essentially, when these were looked at various scores, they all seem to be similar without much difference. The pancreatic scores were similar in both models and after treatment with thalidomide. In the lung, in addition to everything else, looking at the histology, we looked at the MPO and the kidney, urea, and creatinine in the histology, and they were all similar in all the four groups. The third study, and these are not necessarily done in sequence, but the third study that I thought I'd talk about was a study which was presented at the 13th IHBA World Congress in Geneva by Shruti. This was her dissertation while she was doing her MCH. Effect of dexamethasone and infliximab on the severity of L-arginine-induced experimental acute pancreatitis. So for her study, we did not use the duct ligation model. And essentially, there were these studies at that time which were suggesting that tumor necrosis factor alpha and infliximab use could give you some favorable outcomes. There was obviously subsets of patients, but the question was, would it work in all patients? You obviously couldn't go and give infliximab or TNF alpha to a patient straight off without doing some studies, and hence we decided to go ahead and do these animal models. So took mice here, 20 to 30 grams in weight, and 9% L-arginine, 2 doses, intraperitoneal injections were given. And these animals were then sacrificed at 72 hours. We used dexamethasone and infliximab in appropriate doses for the animals. We gave them in a group prophylactically, that means 30 minutes pre-induction of the model of acute pancreatitis, while we gave it therapeutically in another group at 24 hours post-induction and assessed what was the effect of these. So the study design essentially looked at an L-arginine model, a control group in where we use saline alone and no L-arginine, an L-arginine group which was sacrificed at 24 hours and 72 hours, and the treatment group we had an infliximab prophylactic group which was at 0 hours, an infliximab therapeutic group which was at 24 hours, dexamethasone prophylactic group at 0 hours, and dexamethasone therapeutic group at 24 hours. The results showed that we got about an equal number of mild and severe acute pancreatitis, and we had an equal number of mice with prophylactic and therapeutic dexamethasone, and an equal number in the prophylactic and therapeutic infliximab group. The mortality was almost the same, 1, 2 in each group. We didn't get any exceptional mortality in any one of these groups. So these were the histological pictures, the control pancreas, the necrotizing acute pancreatitis after L-arginine, and the control lungs, and the congestion and alveolar hemorrhage in the lung after the administration of L-arginine. We now looked at the groups in which we'd used dexamethasone, and we looked at the pancreatic histology and the plasma amylase levels, and found no difference between the control and the prophylactic and the therapeutic dexamethasone groups, neither in the histopathology scores nor in the amylase levels. Then looked at the lung histopathology and the MPO levels, and again did not find any difference in either one of these groups in the dexamethasone arm. We measured the TNF alpha, the IL-6 and the IL-10 levels in these three groups, and again found non-significant difference in the three groups. The results of the infliximab arm were very similar in the pancreatic histopathology and the plasma amylase levels. You do not see any difference in the histopathology scores across these three groups, nor in the amylase levels. Interestingly, in the lung histopathology, we found that the scores were lower in the therapeutic infliximab group. The lung MPO levels were, however, the same, and therefore we're not sure whether we should have seen some decrease in the lung MPO levels here, but we didn't see any, and we're not sure whether the changes that we were seeing here were because of infliximab or not. Possibly were. We also look at the plasma cytokines, and interestingly, we don't know why this difference. Our control group, in fact, had a lower TNF alpha and IL-6 levels compared to the groups which received prophylactic infliximab or therapeutic infliximab. We have no explanation for this. The lung injury was not severe in this particular model, and there was a paradoxical increase in the TNF alpha levels in infliximab treatment groups, which you could not explain. A similar increase in TNF alpha levels was seen in the infliximab drug control group as well. So what we did conclude from this was that both dexamethasone and infliximab used prophylactically or therapeutically in the L-arginine-induced acute pancreatitis model did not seem to benefit these animals in decreasing the severity of acute pancreatitis. This was our next study, and this was presented by Manpreet. It was her dissertation for MCH. And this was presented at the EHPBA Congress. This was on the effect of methylprednisolone and infliximab in organ dysfunction. So now we've moved away from looking at just histopathological and laboratory parameters to actually trying to assess organ dysfunction. We needed an animal model where we could assess organ dysfunction. Now, organ dysfunction can be assessed after you sacrifice the animal by looking at what's happened to the end organs. But here we tried to create a dynamic model where we could assess the organ function dynamically in these animals. So the first objective was to establish a rat model of acute pancreatitis with organ failure induced by the ligation of the main pancreatic duct. So we did not here ligate the biliopancreatic duct, only the main pancreatic duct. They evaluated the blood pressure, which is difficult to do in these rats. So needed a cannulation of the carotid artery, arterial blood gas analysis, renal liver function test, bronchoalveolar lavage, and the serum amylase levels. As a second part, after we'd done the organ dysfunction, sure that we could assess organ dysfunction, we did a therapeutic administration of methylpred and infliximab in these animals. So we established the model in adult male Vista rats, ligated the pancreatic duct, had a control group of sham operated rats, and assessed clinical parameters and histopathological scores after sacrificing the animals at 48 hours. We tested the drugs. We did the same thing, except we did intraperitoneal administration of methylpred 1 hour and 24 hours following the pancreatic duct ligation, and intraperitoneal administration of infliximab. Biosimilar was used because it was cheaper to use, 1 hour following pancreatic duct ligation. In the control groups, we administered normal saline 1 hour following pancreatic duct ligation, so no drug. And again, assessed clinical parameters and histopathological scores 48 hours later. So essentially, we had 4 groups. Group 1 was the zero control, which was sham surgery and 1 ml of saline. Group 2 was a vehicle control where we induced acute pancreatitis and gave 1 ml of saline. The drug testing arm was methylprednisolone test group, where after the induction of acute pancreatitis, we gave methylprednisolone, and the infliximab test group, where induction of acute pancreatitis and administration of infliximab. So the comparison largely in the first few slides is between group 1 and group 2, where we are trying to show that we were actually able to establish organ failure or measure and assess organ failure in patients in the animals with who had undergone bile duct ligation, and do it dynamically. And in the second half of the slides, you'll see a comparison between groups 2, 3, and 4, which is the vehicle control, the methylpred, and the infliximab test group. So that's the picture on the left top of the screen shows the carotid artery being hooked around, and into this was placed a cannula, which was put at the back of the neck of the animal so that the animal would not scratch it out. We did measure baseline parameters, induced acute pancreatitis, or did sham surgery, depending on whether it is a control or a test group, administered the test drug or a vehicle, which is saline, and then measured organ failure parameters at 4 hours and bronchoalveolar albumin levels, and sacrificed the animals. If you note here, the ligation was of the pancreatic duct and not the bile duct. And the attempt was to try and avoid the occurrence of cholangitis, which could have confounded the results, and therefore only a pancreatic duct ligation was done in this particular model. Serum amylase, mean blood pressure, heart rate, arterial blood gases, blood lactate levels, renal function test, liver function test, and a bronchoalveolar lavage at 48 hours only. Clinical parameters were at 0 and 48 hours. And histopathological scores of the pancreatic tissue, lung tissue, and kidney tissue. After the clinical parameters had been analyzed, the animals were sacrificed and these tissues were obtained. So look, establishment of the animal model studies, if you look at these groups, this is group 1 and this is group 2, and the same thing goes along in all the graphs. And you see that there is local injury occurring to the pancreas in these animals. There is minimal change in the cardiovascular injury as well between groups 1 and groups 2. The same is true for heart rate and blood pressure. In the respiratory parameters, oxygen saturation as well as PO2 levels were significantly different between group 1 and group 2, suggesting a type 1 respiratory failure. The serum lactate levels are also significantly different pre and post intervention, and but the pH, the PCO2, the bicarb, the base access, the bronchoalveolar lavage albumin levels, the renal functions and the liver functions, there were no significant differences. The histopathological injury scores showed that the lung total score, neutrophils in the interstitial space score, the kidney score, and the tubular injury score were all significantly different between groups 1 and 2. We then gave these animals methylprednisolone and infliximab. So, because it's a biosimilar, we used infimab, and the local injury to the pancreas seemed to be reflected in the serum amylase as well as in the pancreas total score pre and post intervention, and these were significantly different. The cardiovascular parameters, the mean blood pressure and the heart rate again were different pre and post intervention, the blue and the greens. The respiratory parameters, the oxygen saturation and the PO2 levels on the blood gases. The blood parameters and the histopathological injury. So there was no significant difference in the histopathological scores of the lung and the kidney, but the lactate levels were. So compared to previous studies, this had some unique features. We were looking at the effect on the pancreatic and organ histology following sacrifice, but we were measuring dynamic changes in clinical parameters without sacrificing the rats. Therefore, what we were observing the rats could be actually translated directly to clinical studies. The changes in the clinical parameters correlated with the extent of organ injury, and these were findings which were similar to a pancreatic duct ligation mouse model by Samuel and Mehols, where they found similar findings. The liver function, as I said, we did not tie off the bile duct, so the liver function was not affected in our model. The therapeutic administration of the drugs in these groups of animals emulated the actual scenario for drug administration in these patients, and the clinical parameters of systemic organ failure that were monitored are parameters that one would monitor in patients, and these showed improvement. The local injury and histopathological organ injury persisted, and that didn't change with the administration of methylprednisolone or infliximab. So the intent of using these drugs was to reduce the systemic inflammation and not the local injury, which we seem to have achieved. So we concluded that methylprednisolone and infliximab reduce the systemic inflammation as shown by improvement in blood pressure and increase in the oxygen saturation. These were relevant to the human clinical scenario to reduce systemic inflammation in patients with severe acute pancreatitis and organ dysfunction. We then went on to do another study which looked at the effect of prophylactic low molecular weight and unfractionated heparin on a surgical model of experimental acute pancreatitis to see if these would decrease the disease severity. Essentially, we were looking at whether we could prevent microthrombosis and hence improve the microcirculation in the pancreatic microvasculature and other organs, thereby decreasing the severity of acute pancreatitis. We did not find that there was any change in the severity of pancreatitis in those who received low molecular weight heparin and unfractionated heparin. We simultaneously had a few PhD students doing some work on these animals, and we looked at effect of anti-TNF therapy on the severity of experimental acute pancreatitis and pancreatic regeneration subsequently in a cerulean-induced acute pancreatitis model. Looked at autophagy in experimental acute pancreatitis with reference to inflammation and cell death. And this was again in a cerulean-induced model. More recently started using these animal models in creation of chronic pancreatitis and studying chronic pancreatitis as well. Acute pancreatitis, it seems, may be moving towards precision medicine. There have been attempts to target systemic inflammation. There have been prior clinical attempts at using various drugs to try and see if we could reverse the pathophysiological processes happening in patients with acute pancreatitis, but these haven't succeeded. There's a shift in attention now to looking at pancreatic enzymes to cytokines, and from the ancinar cells to inflammatory cells. We have good animal models of organ failure. We could possibly identify targets and develop inhibitors to these processes. Some of the promising ongoing trials which have been started and are ongoing currently is one on TNF alpha antagonists, which is ongoing in the UK. Two trials, one in the United States on the use of steroids. Cytosorb, extracorporeal removal of cytokines, a trial going on in Germany. And tocilizumab in patients with predicted severe acute pancreatitis, again ongoing at the moment. So in summary, we've got animal models for acute pancreatitis established and standardized, invasive as well as non-invasive, and we've also been able to establish a model where we could actually assess organ failure. We've used various targeted therapies in these animal models, and some of this work, based on our studies as well as other published literature, is being now translated to clinical trials that are ongoing. We hope at some point in time there will be some target and some inhibitor that we'll be able to find by using these animal models. I acknowledge my MCH students who did their dissertations. Vipin IS was the first one who started off. I think we sent him to Dr. Deepak Govil to learn the technique of bile duct ligation because he'd many years ago developed a model and he discouraged him thoroughly and said, go back to Dr. Piyushani and tell him that you're not going to do this. So he came back and told me that I'm not going to do this. And I said, you're please going to do this and this only. Pradeep Kumar, Ashish George, Kriti, Manpreet, and Sudhir Kumar. We've had PhD students in the Department of Anatomy who worked on these models. I'm grateful to my former colleagues in the Department of GI Surgery who tolerated these moods of mine where we insisted on somebody doing a study on an animal model. Tony Jacob, who's in the Department of Anatomy, a professor now, and he initiated some of this work with his PhD work. And from there, we went on to do all these studies. And I hope that these will continue to happen even after I've left the department. Finally, a big thank you to Pramod Garg in the Department of Gastroenterology, who kept prodding us on and saying, sir, please, ek aur ladke ko de do na, jo ki karega animal model study. And he would come up with another question to try and answer. Thank you very much.
Really wonderful work. Proud for you to have taken on such a difficult job. It's obviously a condition which affects young people and devastating, and somebody to study it and come to a cure for this, or at least prevent the severity. And I hope this work is carried on by others so that the initial part of pancreatitis, where all the damage happens, can be taken. We're really proud that you've delivered this oration.
May I request the President, Dr. Subhash Gupta and Dr. Khandelwal here to kindly honor the orator with a plaque. The plaque? Can we have the plaque, please? There is a small order of the day. Dr. Pradeep, can you please, sir? Would you like to? There is a course curriculum which was designed and after consultation with a lot of experts of our field, which was finally given a formal shape by Professor Anand Krishnan. Maybe Dr. Piyush would like to introduce that, announce a formal release of the same.
So the curriculum was developed over a few meetings, largely supported by AIG, and Pradeep was, along with GV, instrumental in getting us all together to discuss and develop this. Dr. Anand Krishnan, who played a crucial role in giving its a final kind of shape. This is a competency-based curriculum which doesn't move away from the traditional curriculum. Has very clearly defined EPAs, industrial professional activities at different levels. But we kept both elements because most of the people who were present at these meetings were not comfortable shifting over totally to the curriculum, to the competency-based curriculum in surgical gastroenterology. This curriculum has been around for some time, but Dr. Anand Krishnan felt that we as an association need to take ownership, and therefore a small booklet should be made and circulated. This booklet is here, and the same curriculum will be published as a chapter in the forthcoming GI surgery annual, and you would then have access to it there as well. If there are members who don't want the GI surgery annual but want the copy of the curriculum and a hard copy, you can let us know and we'll send you one. And it'll be put on the website of the IASG, the soft copy, so anybody can download it, download a PDF version of it.
May I request Professor Khandelwal and Dr. Subhash Gupta to kindly inaugurate the booklet and release it to the members.
Thanks to all the chairpersons. Thank you, Dr. Piyush Saini, sir, for insightful talk on pathophysiology of acute pancreatitis and for shedding light on key findings from animal models. Next will be session 5, award videos. I would like to invite judges, Dr. T.D. Yadav, sir. Dr. T.D. Yadav, sir. Dr. Amarjit Kumar, sir. Amarjit, sir. Amarjit, sir. Next, Dr. Saurabh Galoda, sir. Dr. Saurabh Galoda, sir, please. Okay, sir. The first presenter will be Dr. Sai Krishna. Dr. Sai Krishna. The video will be robotic pancreaticoduodenectomy for large solid pseudopapillary neoplasm of pancreas.
You can start, please.
Good morning, sir. My video presentation on robotic pancreaticoduodenectomy for large solid pseudopapillary neoplasm of pancreas. My patient, 16-year-old female, presented with complaints of abdominal pain. On examination, she had a large epigastric lump of 6 by 7 centimeters. On further evaluation with CT scan, it showed large, well-defined, heterogeneously enhancing lesion in the head of the pancreas with both solid and cystic lesions. These are the 4 standard robotic ports we place. R3 is the infraumbilical port used for camera, and we place assistant port between R3 and R4. The procedure started by entering into the lesser sac through the gastrocolic ligament. And this is the superior right colic vein draining into the SMV through the gastrocolic trunk, which was clipped and divided. Further dissection carried out, and we can see the gastrocolic trunk draining into the SMV, which was clipped and divided. Further, right gastroepiploic vessels and right gastric vessels were divided. And stomach was divided using robotic staplers. Patient 8A lymph node was dissected to delineate the common hepatic artery, and GDA was identified. After clamping GDA, confirming the flow in the proper hepatic artery, it was double clipped and ligated and divided. Further, Kellogg's triangle was dissected and cystic artery was divided, and common hepatic duct was dissected and isolated. Retropancreatic tunnel was created, and pancreatic neck was looped using umbilical tape. Complete cauterization was performed. And we can see here anterior AIPDV was draining into the SMV, which was divided. And further dissection carried out along the ligament of Treves, and jejunum was divided using robotic staplers and brought to supracolic compartment. Further unsnare dissection was done using the help of harmonic from assistant, and here we can see the IPDA arising from the SMA, which was clipped and divided. Neck of pancreas was transected using monopolar curved scissors, and good hemostasis was achieved. Here we can see PSPDV draining into the main portal vein and was clipped and divided. Further, common hepatic duct was divided just above the cystic duct junction, and specimen was placed in a bag. Here we can see the MPD diameter of only 1 mm admitting a vein flaw of 3 French. A stay suture was taken anteriorly through the pancreatic duct. Further, jejunum was brought to supracolic compartment. After taking an anchoring stitch, the posterior layer of anastomosis was performed between posterior pancreatic capsule and seromuscular layer of jejunum using barbed 4-O sutures in a continuous manner. We performed duct to mucosa anastomosis. We placed around 6 sutures. Because of the stable 3D vision, we can see the duct clearly, and because of the endo wrist movement of the robotic arms, these sutures are placed easily and correct angle placement was done. And the anterior layer of anastomosis was done between anterior pancreatic capsule and jejunum using barbed sutures in a continuous manner. Hepaticojejunostomy was performed using absorbable monofilament 4-0 sutures, and intermittent sutures were taken because the duct size was around 6 mm. And because of the lack of haptic feedback, one should be careful while approximating these sutures to ensure watertight anastomosis. Finally, gastrojejunostomy was performed in a side-to-side manner using robotic staples, and common enterotomy was closed using Crevo Barboot sutures. And specimen was extracted by extension of the assistant port, and patient has uneventful recovery and was discharged on post-op day 6. At 6 months of follow-up, patient was remain asymptomatic and was doing well. To conclude, large lesions in the head of the pancreas are a technical challenge for resection minimal invasively. Systematic vascular control can reduce the bleeding and decrease the conversion rates, and robotic platform has an advantage. Thank you, sir.
Thank you. Thank you, Sai Krishna. Very nice video. So, can you compare this outcome with the laparoscopic cholecystectomy? Sorry, lap PD.
Yes, sir. In
How it is different from lab?
Yes,
What
sir.
are the main features that makes you procedure superior?
So mainly one is the suturing, which is very easy in the robotic platform compared to the laparoscopically. And another is the operative time also comparatively it was less in robotic PD compared to the laparoscopic one.
Is it?
Yes, sir.
People say robotic takes more time.
Compared to laparoscopic, it was low in our institute.
You have done any comparison study?
No, sir, not a comparative study. We usually have the cases both in robotic and lab.
Which anastomosis actually you're saying better with robotic as compared to laparoscopy?
Ductal mucosal anastomosis.
Is it the PJ which is easier or is it the HJ which is easier? Like you have experience from both as you are saying.
Yes, sir.
So which anastomosis do you think is easier when you're using the robotic?
PJ is more easier, and even also HJ it was easier with the robotics.
As far as ergonomics is concerned, HJ becomes a little more difficult when you're doing laparoscopy as compared to PJ, because PJ you're still doing on side on.
Yes, sir.
Probably HJ is
More
much
difficult
easier
in
when you're doing robotic as compared to laparoscopy. Although experience matters. Experienced people can do both.
So, any comments and questions from the audience, please? Yes, Dr. Vikram.
I saw you going to the infracolic compartment to divide the jejunum. So do you do it in all your cases? Because we find it a little difficult to go into the infracolic compartment. One of the limitation of robotic platform is to change the quadrants. So any tips and tricks which you can tell us?
For all the cases, we used to go to infracolic compartment, and we didn't feel much difficulty with the port position of ours. It was not much difficult, sir.
But most of the centers would follow the same port placement. So we find it slightly difficult to do that jejunal transaction from the going to the infracolic compartment, particularly for that reason. Tips to do that? Because
So we have a proper assistant port in the between the R3 and R4, which helps in retracting the colon and momentum superiorly. So it was easier a little bit compared to with the other.
Would you like to justify your approach in this particular patient? Because I think this is a very good indication for robotic people. Young patient, female, probably unmarried. When is one of the classic indication to offer MIS, particularly robotic. Thank you.
Thank you.
Good
so much.
video.
Thank you, Dr. Saikis. Thank you.
Dr. Sri Hari Priya, present the next, which is right modified extended hepatectomy with portal vein reconstruction after right portal vein embolization for locally advanced carcinoma gallbladder.
Good morning, everyone. Greetings from AIMS Bhubaneswar. I'm going to present right modified extended hepatectomy with portal vein reconstruction after portal vein embolization for locally advanced carcinoma bladder. Our patient is a 56-year-old female with no comorbidities, presented with obstructive jaundice for 2 months, diagnosed with CAGB neck with type 3A block. Left PTBD was done for biliary drainage. The CT was showing GB neck mass that is infiltrating the hilum. Right hepatic artery was involved. MPV infiltration for length of 1 centimeter was present. The steps that we follow for liver resection in malignant hilar block include target bilirubin for less than 3 milligram, FLR of 27% in this patient. So we did PET CT and staging lab. There was no metastasis. Right portal vein embolization was done. FLR improved to 39%. So we proceeded for definitive surgery. After tumor board discussion, staging lab showed no metastasis. After cauterization, the 16B1 lymph node dissection was done. It was negative for malignancy. The pylorus and the hepatic flexure were adherent to the GB mass, so distal gastrectomy and hepatic flexure was resected with linear GI staplers. The D1 was looped and then divided with endo-GI stapler distal to the adhesion with the GB. We proceeded with the lymphatic dissection. Station 8 was dissected and common hepatic artery was looped. Station 12, a lymphatic dissection was done. The GDA was then delineated and looped. Further, the proper hepatic artery was looped and the lymphatics were dissected. After dissection near the hilum, the right hepatic artery was looped close to its origin. We have secured it with a vicryl tie and a liga clip and then cut the right hepatic artery. The distal CBD was looped and it was clipped and then divided. The distal end of the distal CBD was cut and sent for frozen, which was free of tumor. The PTBD, which was in situ, was then withdrawn. The main portal vein was then looped distally, and the lymphatics to the right of the main portal vein were divided, and the segment 4 artery is now being looped. We then proceed with the right lobe mobilization. After dividing the triangular ligament and proceeding downwards, we ligate the short hepatic veins between vicryl ties and clips and divide them. Meticulous dissection was done to separate from IVC. The demarcation line was then marked with a cautery. The capsule was divided with a cautery. The parenchymal dissection was done with CUSA. Small pedicles were cauterized and larger ones were divided between clips and hemologs. The segment 4 pedicle being divided between liga clips. After further parenchymal transection with CUSA, we encounter the segment 5 tributary of the middle hepatic vein, which was meticulously delineated and divided between hemolog clips. Proceeding cephalad with parenchymal transection with CUSA, we encounter the segment 8 vein, which was then divided between liga clips. We proceed further, delineating the right hepatic vein, which was looped, and then it was divided with a vascular stapler. After which the posterior Glisson's capsule was divided with cautery. The left portal vein was then looped. The left hepatic duct was looped and divided after giving an adequate margin. We proceed with the portal vein last approach in cases where portal vein is involved or with portal vein embolization performed prior. The left portal vein and the main portal vein were cut after clamping. The cut edges of the remnant left and main portal vein were flushed with hepsaline, and before the anastomosis they were bled out. Portal vein reconstruction was done with proline 6-0, taking continuous sutures. The posterior layer is now being done. After which we proceed with the anterior layer. Before tying the final knot, we bled the vein, and then the final knot was tied after giving adequate growth factor. The caudate hilar sheath was then secured with PDS60 sutures to prevent leak from small caudate ducts. Roux-en-Y hepaticojejunostomy end to side was done between the caudate and the left ducts in a single hedge with all knots outside technique. Gastrojejunostomy and jejunojejunostomy was done with endo-GI staplers, and colocolic anastomosis was done. The remnant liver is fixed to the anterior abdominal wall with intermittent proline sutures. This is the resected specimen. Histopathology was adenocarcinoma, which was poorly differentiated grade 3. All margins were free of tumor. 1 out of 17 lymph nodes were positive. LVR PNI was present. It was PT4N1 with MX. Thank you.
Thank you, Priya. My question is, did you give the neoadjuvant to this patient?
Sir, this patient, we could not get the biopsy from the GB neck mass, so we could not give neoadjuvant to the patient. After we achieved adequate FLR, we directly proceeded with surgery.
Okay.
So what is the outcome in a patient of carcinoma gallbladder with vascular resection?
Sir, compared to no surgery, in patients where vascular resection was done, it is better. But the overall prognosis is slightly poor.
No, it's it's very subjective. Which data you are quoting? How many patients survived 1 year, 2 year?
In patients with CAGB with jaundice and hilar block,
I'm asking, just listen please. I'm asking, when you are doing there is a difference between carcinoma gallbladder, obstructive jaundice vis-a-vis hilar cholangiocarcinoma biologically.
Yes,
So I'm asking, if you are doing a vascular resection combining to a patient of hilar cholangiocarcinoma, what is the outcome?
I'm not sure regarding the survival in these patients.
And segment 1 was not resected, it seems. So do you think there can be any negative impact of that?
Sir, this patient is carcinoma gallbladder, mostly infiltrating to the right duct. So we have done partial caudate resection, but in cases of hilar cancer, we have to do caudate dissection.
Yes, sir.
So how long since you have done the surgery?
So the surgery was performed recently only. So in the past 2 months, the patient is still under follow-up.
And any previous experience in the
Yes.
same center?
Sir, we have operated around 3 patients till now, sir, who underwent portal vein embolization as well as hepatic vein embolization also to augment the FLR. In the past 6 to 8 months, they are still under follow-up, sir,
All of them
receiving
alive?
adjuvant chemotherapy.
All of them are alive.
Yes, sir. Like recently only we have done the surgery since.
No recurrence in all 3 of them.
No, sir. As of now.
Okay.
Any comment and question from the house? Yes, Dr. Subhas.
No gallstones.
Images that you showed me.
Now they have the histopathology.
The histopathology between
Maybe-
cholangiocarcinoma and who can differentiate? Now, the important point is you could probably, if you reconstructed the right hepatic artery, you would not have needed to do left hepatectomy. You would not have had to do a pre-operative decompression. You could have done, and I've seen previous presentations say that upfront surgery always gives much better results.
So the duodenal and colonic involvement? So there is involvement of duodenum and colon also?
They resected
both the duodenum
Yes, sir.
and
It was just
colon.
adherent to the.
That is from radicality, but from the images it wasn't there.
Yeah, but like
You may do what
intraoperatively it
you-
looks like
but
a
to call
gallbladder.
this gallbladder cancer without gallstones, I'm reluctant to take on face value.
Okay, thank you. Thank you.
Thank you, sir.
May I call upon Dr. Surya K. to present robotic Iver-Lewis esophagectomy.
Good afternoon all. Presenting a case of robotic Iver-Lewis esophagectomy. We had a 43-year-old female who presented with progressive dysphagia for 2 months. Upper GI endoscopy was done, which showed Sievert's type 2 biopsy-proven adenocarcinoma. CECT showed locally advanced disease following 4 cycles of chemotherapy with flawed regimen, which showed a partial response. She was proceeded with the robotic Iver-Lewis esophagectomy. This was the robotic port placement. 4 robotic ports and 2 assistant ports were placed. And after ruling out peritoneal metastasis, the dissection was proceeded. Pars flaccida was opened, following which division of the phrenoesophageal ligaments was done, and the right crura was separated from the esophagus. To ensure easy visualization of the proximal stomach, the left lobe of liver was retracted by taking a suture around the falciform ligament, following which the gastrocolic omentum was opened by dividing along the greater omentum. preserving the gastroepiploic arcade. The dissection was proceeded along the greater curvature of stomach and division of the short gastric vessels was done, following which the left phrenoesophageal ligament was identified and it was divided. Following the division of the phrenoesophageal ligaments, the posterior wall of the stomach was separated from the body of the pancreas. To ensure proper mobilization, the dissection was carried along the greater curvature towards the hepatic flexure. Cauterization was done, separating the second part of the duodenum to ensure easy mobilization of the gastric conduit. So this shows the second part of the duodenum being separated from the peritoneal reflections till we were able to visualize the inferior vena cava. Following which the dissection was proceeded along the lesser curvature of the stomach, and then we identified the right gastric artery and they were ligated using hemalogs and divided in between. Then we proceeded with the ligation of the left gastric vein, following which the lymph node dissection, the abdominal face was done. All the lymphatic tissue around the celiac axis, the proper hepatic artery as well as the left gastric artery were identified and the lymphatic tissue was separately removed. Following which the left gastric artery was identified and it was delineated from the surrounding structures, hooked out using hooks, and they were ligated. And they were divided using hemalogs and they were, following which the dissection was proceeded towards the hiatus. All the tissues between the diaphragmatic attachments were removed. Transhiatal dissection was proceeded and the paracardial lymph nodes were removed along with them. For easy mobilization, using umbilical tape, the esophagus was retracted downwards and the dissection was continued. The gastric conduit was created by using endo-GI stapler and the suture ends were buried using 3-0 hemolog continuous sutures to ensure adequate hemostasis, and the gastric conduit was stacked to the specimen. Following which the patient was proceeded with the thoracic face with 3 robotic ports and a single assistant port targeting at the level of azygous vein. The thoracic face was started with the division of the inferior pulmonary ligament. The mediastinal pleura was separated and the dissection was started. We entered into the mediastinum and the distal esophagus was dissected away from the mediastinal pleura and the pericardium. All the fibrofatty tissue and the mesoesophagus was separated along with the specimen. The dissection was continued till the hilum and all the lymphatic tissues were taken along with the specimen. Following which, with 10 centimeter proximal margin, the esophagus was transected and the transected end was buried. Following which the dissection was started above the level of azygous vein and to help in proper mobilization of the proximal esophagus to help in tension-free anastomosis. The dissection was continued proximally the azygous vein, the level of upper esophagus, and the upper esophagus was mobilized all around. The gastric conduit was delivered through the hiatus to the thorax. And after ensuring proper alignment, anastomosis was done, side-to-side anastomosis using endo-GI stapler by making enterotomy After anastomosis, a Ryle's tube was placed across the anastomotic site, and after achieving hemostasis, the suture site, the enterotomy was closed using 3-0 sutures, following which the specimen was delivered by making an utility incision through the assistant port, thoracotomy port, and the left ICD was placed. The postoperative histopathology showed T2N0, moderately differentiated adenocarcinoma. The patient had no Complication postop.
Thank you, Dr. Surya, for this video. And so, what was your extent of lymphadenectomy in for as abdominal part is concerned? So, which group of lymph node you have removed in this case? Generally, you remove in CAG junction.
Sir, we have removed the lymph nodes along the left gastric, proximal splenic, and along the celiac axis. Sir.
Okay.
Have we given new adjuvant?
Yes, sir. She underwent a neoadjuvant therapy, sir.
Which?
4 cycles of lot regimen was given.
So, thank you because your time is up. Thank you.
Thank you, sir.
Thank you. Next, Dr. Abhi C. to present modified Cattle's technique for pancreatic jejunostomy.
Good afternoon all. This video demonstrates modified Cattle's pancreatic jejunostomy, our Achilles heel. This is the worldwide data of pancreatic duodenectomy associated complications. There is 5% of overall incidence of mortality, 50% of perioperative complications, 25% of incidence of postoperative pancreatic fistula, and 26% of postoperative pancreatic fistula related mortality. The institutional sample of 94 cases of pancreatic duodenectomy, that is visible surgery done for a de novo pancreatic cancer from October 2013 to August 2024, demonstrating the technique, operative duration, and assessing the challenges. Postoperatively measuring the postoperative pancreatic fistula formation and postoperative pancreatic hemorrhage and delayed gastric emptying. So after the sharp transection of the pancreas using a surgical knife, you can see the bleeding points are tackled using individually with 4 or 6 polypropylene sutures. The bilimb of jejunum is taken to the supracholic compartment. At the antimesenteric anastomotic site, a seromuscular cut is made using a surgical knife, and this seromuscular ridge is lifted with the 2 Babcock's forceps with a gentle traction. The mucosa is separated from the seromuscular ridge, and the seromuscular tissue is removed. So the raw area is created such a way that it is almost similar to the size of the transected pancreas. On the either side, the seromuscular ridge is removed. The gentle traction using a surgical gauze. So bleeding points from the raw surface is generally coagulated without making any enterotomy. Subcorner sutures are taken from the seromuscular ridge to the capsule. Initially, the posterior sutures with 4 polydaxilon sutures. These knots are tied, hand-tied, and knots are facing away from the anastomosis. Subsequently, further serocapsular sutures are taken, posterior sutures are taken, which are intertwined and hand-tied. This is the last suture. Next, the pancreatic duct is cannulated to see the patency of the duct, and according to the size of the pancreatic duct, the sutures are taken. This is a 4 mm duct. We have taken 6 sutures, that is 2 posterior, 2 corner, and 2 anterior sutures with the double arm 60 polydaxilon sutures, which are pre-placed. You can see the pre-placed 60 polydaxilon sutures, and the enterotomy is made exactly opposite the opening of pancreatic duct, almost as small as possible. Now the enterotomy is performed. Then the 2 posterior sutures are taken inside out. This is the first suture is taken inside out. This is the second posterior sutures. which are hand tied and the nodes are facing away from the anastomosis. Later, from two corner and two anterior sutures are taken. These are the corner sutures. And the anterior sutures. They are subsequently hand tied. Then cut. Next, anterior serocapsular sutures are taken with the 4 seropolydaxan sutures, which are interpreted and hand tied. This completes the pancreaticojejunostomy and it demonstrates the modified Cattell's pancreaticojejunostomy. So we have faced difficulty with the double duct, posterior place, small duct. With same technique, we can complete the pancreaticojejunostomy and our outcomes are good. So this is a double duct. We have cannulated and did the same technique. The postoperative data, although we have a 20% incidence of postoperative pancreatic fistula, majority of grade A, that is biochemical leak, and a 30% incidence of delayed gastric emptying, and we have 1% incidence of post-pancreatic hemorrhage. And with the as you can see with the ear, comparing with the ear, we have initially the maximum difficulty of complications, and coming to the year of 2021 to 2025, the complications are decreasing. Comparing with the worldwide data, we have 4% of mortality, 45% of complication, 2% of incidence of grade B and grade C leak, and 0.7% incidence of mortality. Thank you.
Okay. Thank you, Dr. Avi. So, this is a technique you have followed. The 20% is the pancreatic fistula.
Yes, sir.
So, is it different from other literature where ductal mucosa normal anastomosis is done?
No, sir. So almost the leak rates are same, sir.
So, you change to this technique for any reason?
We have practicing the same technique since we don't change any techniques, sir.
Okay. So, you do only this one?
Yes, sir.
Okay.
Yeah.
For how long have you been? So please, you can ask.
Yeah, can you describe this Cattell's technique in pancreaticojejunostomy and what is your modification?
The seromuscular ridge is removing. That is a modification what you are facing, sir.
What was the original Cattell's?
They won't remove the seromuscular ridge, sir.
So that was the conventional pancreaticojejunal anastomosis.
Yes, sir.
Without just duct to mucosa.
Yeah, yes,
so
sir.
how basically what was Cattell as a different technique compared to the regular pancreaticojejunostomy duct to mucosa technique?
Yes, sir.
You got my point. I mean, what was Cattell's original technique of duct to mucosa different than the other conventional pancreaticojejunostomy? Or duct to mucosa itself is Cattell's technique?
Yes, sir.
Can I ask a question?
Yeah, please.
Right. So, although it looks very good, my only concern is the reproducibility of this procedure. You've removed the seromuscular layer, only the mucosa. How many people will be able to do the proper duct to mucosa anastomosis there? You're going to tear up the mucosa and then more often end up with a modified buccal kind of anastomosis in the end. So I'm worried about the reproducibility of this.
There is a chance of enterotomy while removing the seromuscular ridge. That is true, sir. Your concern is genuine, and I'm not sure what is the reproducibility, but till now we don't encountered with any enterotomy while removing the seromuscular ridge, sir. But with a general technique, we can reproduce what I feel, sir.
Avi, what was your fistula rate at your center before adopting this technique? At your center, not the literature.
Sir,
because the most of your patients are coming from the area which there is a high incidence of chronic pancreatitis. So I assume that might be the fistula rate is already low at your center, even before this technique.
Sir, I'm not.
Okay. Thank you.
Thank you, sir.
Thank you. I'd like to call Dr. Bikash Nepal, present parenchymal preserving surgery for SPEN pancreas, laparoscopic assisted central pancreatectomy.
Good afternoon, everyone. I'm presenting a central pancreatectomy for Spain in our patients. She's 22 years female. She had a history of pain abdomen, and we underwent an investigation that was essentially normal. And CT showed a mass, hypodense mass in the body of the pancreas. Then we started with the surgery, laparoscopic assisted pancreatectomy by opening the lesser gastrocolic omentum, and we entered the lesser sac with the help of harmonic. And after continuing with the opening the lesser sac, we went on to dissect the to find out the SMB, and by identifying the right gastroepiploic vein, and we are descending along the inferior border of pancreas. We can see the tumor at this area. Then continue with the dissection. We are going to find out the SMB now, and continue with the dissection on the inferior border of the pancreas. Here we can find the right gastroepiploic vein joining into the SMB. With the help of Hemolog, we are ligating the right gastroepiploic vein. So we can find the plane between the pancreas and the SMB. That is being dissected with sharp and blunt dissections. And a vascular plane is created behind the pancreas, and the tunnel is created with the help of dissection with the scissors. We can find the easy plane between the pancreas and the SMB. Nathan retractor is used to expose the suprapancreatic area. Here we can find the lymph node at this common hepatic artery. By removing the lymph node, we can see the common hepatic artery as well as gastroduodenal artery in the suprapancreatic area. And we are continuing with the dissection in the over the suprapancreatic area. So we can see we are trying to find out the gastroduodenal artery because tumor is in close proximity with the GDA. Further continuing with the dissection on the suprapancreatic part, we are going to, so GDA is being isolated with the forceps, and we can see the complete hooking around the GDA, and GDA has been ligated here. And any tissues on the superior border of pancreas has been divided. One vessels, tributaries from the pancreas going into the portal vein has been divided, and we are creating a plane above this splenic vein and splenic artery, and we are using the golden finger to hook the pancreas above, and it is easily being dissected up from the splenic vein and splenic artery. So a stapler, induced stapler is being used with the graded compression to divide the pancreas, and we are dividing the superior border of the pancreas with the harmonic. Fibrous tissue that is being removed. We can see the tumor medially and with adequate margins. So continue with the dissection of the superior fibrous tissue with the harmonic. We are trying to lift the pancreas from the vessels, splenic vessels and splenic artery. Plane is being created, fibrous tissue is being there. There is no dense adhesion or difficult dissection around the behind the pancreas. Pancreas is being lifted. We make sure that we do not do more dissection over the below the pancreas to save the preserve the vessels, segmental vessels. So lesion is completely separated from the pancreas and it is being lifted up. So we are trying to find out the resection, transection line early. We take a hemostatic suture at this stage to prevent the bleeding, stage sutures. Then we continue transecting the pancreas with the help of harmonic. hemostasis is quite good with the harmonic at this stage. Tumor is being removed from the area. When we prepare this distal stump for pancreatic geniostomy, so we can see the duct there, we can identify the duct. We take the rule loop from the jejunum, by dividing, creating the rule loop with the harmonic, and this jejunum is being transected with the endostapler, and we take a stay suture to do the jejunostomy. We did a side-to-side staple jejunostomy, and the opening being closed by the by the sutures, intracorporeal suturing. So after completion of the JJ, we do upper midline incision. We delivered the specimen and completed the Hansen PJ. Patient was had full recovery and discharge on post-op day 8, and histopathology was solid pseudopapillary neoplasm T2N0.
Thank you, Vikas. So my question is, do you divide GDA in all patients in central pancreatectomy?
No, we do not divide. At this, in this patient, we found a tumor and lymph node at quite close proximity with the GDA. So we have to ligate to get the negative margin over the tumor.
Okay. And the other question is what you showed in the video, the mobilization of the distal pancreas was not, it looks like very small, 1 centimeter or 1.5 centimeter hardly. And you have, I suppose you have done dunking.
Yes.
In PJ. This mobilization was, did it mobilize, not shown in the video?
Not shown in the video. We have mobilized at least 2 to 3 centimeters and lifted the pancreas distally to do the anastomosis.
Okay.
By open technique.
So how many patients have you done for SPEN?
We do not have the series of the patients, and we do.
You just started it.
Yes, 5 to 10 patients per year.
5 to 10 patients. So what is the leak rate for that?
We have around a biochemical leak of around 20%, and we do not have significant clinical fistula rate in our patients.
So how much pancreas should be left behind for you to consider that this patient I will take up for central pancreatectomy?
At least 5 centimeter distal pancreas should be preserved.
So small spens usually. Thank you.
Question and comments, please, from the house.
What is your opinion about PG in the central pancreatectomy, especially to keep that reverse, jejunal loop is difficult and doing anastomosis is difficult. If it is the distal pancreas, if you dunk into the stomach, it will be easy, na? Pancreatic or gastro.
Yes, I agree. But our institute practice is to do a PJ. We have standardized that technique, so we follow the PJ in all cases.
Any other comment or question? Then no. If no, then thank you, Dr. Vikas. Thank you. So last presentation is Dr. Ramesh Natarajan. He is going to talk about supracarinal lymphadenectomy for esophageal cancer.
Good morning, chairpersons and delegates. This is a patient underwent McEwen cesophaectomy. We usually do McEwen cesophaectomy in semi-prone position. And these are all the port positions. Actually, we go for the 4-port technique. Middle port comes in 7th intercostal space, and right hand working port in 3rd intercostal space, and left hand working port in 9th. One more accessory port we go in 11th intercostal space. So this is the
So surgeon stand in the middle and a cameraman on the left side of the surgeon and the nurse in the right side and one more accessory port, the opposite, the one more surgeon stand. Then as you go inside, you try to cut the parietal pleura anteriorly and posteriorly with the hook, and that is the esophagus. So when you create space between the anterior and posterior part of the esophagus, you try to loop the esophagus. You create space to loop the esophagus, and then you create space between the inferior part and superior part of the azygos vein. So you carry the incision down towards the hiatus, and so that you allow the air to go inside, the carbon dioxide to go inside. You can dissect all around the azygos and try to clip the azygos with Hemlock clip, both distally and proximally, and then cut in between so that you get access to the esophagus for dissection. So that is the right bronchus, what you see there. That is the mesoesophagus between the descending thoracic aorta and the arch of aorta. It is a membrane between the aorta and the esophagus. It otherwise called as aortoesophageal ligament. So you try to dissect that and cut that. So you need to loop the esophagus so that you further proceed the dissection. So while you cut the vagus at the opposite side, it's better you cut well below the left bronchus so that you save the pulmonary branches. After looping the esophagus, you further proceed with the dissection. That is the mesoesophagus, what I cut there towards the, which is attached towards the esophagus there. And you create space all around and go supracarinally, go up to the inlet, and then space between the trachea and the esophagus is created. So further dissection proceeded. So that is the mesoesophagus which is present supracarinally. So this is bilamellar fascia that is proceeding from the alar fascia down towards the thoracic esophagus, that is between the left subclavian artery and the esophagus. And when you cut the medial layer, you just open the space for left recurrent laryngeal node dissection. So that is the mesoesophagus in the supracarinal part, and that is the thoracic duct which is going towards the other side. So that is also the, so you continue further, dissecting further, create the space supracarinally because you need space to dissect both sides of recurrent laryngeal node. You have, of course, you have to complete down, go up to the hiatus. That is the growth what you see there. Now come to the right recurrent laryngeal node dissection of lymph nodes. So trace the vagus, go up to the subclavian artery, that where there loops the recurrent laryngeal nerve, and remove all the fibrofatty tissue along with the paratracheal nodes. So now you need to loop the esophagus superiorly, that supracarinally, creates more space, and sometimes you use left hand so that you dissect well. So this is how we loop the esophagus so that you can approach the other side of esophagus, that is left recurrent laryngeal space. While doing left side lymph nodal dissection, we should not hold the nerve. We have to use blunt dissection or bipolar to dissect the nodes along the left recurrent laryngeal nerve, and should not, that is the left recurrent laryngeal nerve. All the nodal tissue along the nerve should be dissected up to the arch of the aorta, and you have to apply lit bus. Diathermy should be very less and should not damage the nerve there. So after completing both sides, you go and dissect the infracranial node. So here also you should not disturb the pulmonary nerves, which is branching from the vagus there. So both sides, it is better you cut the vagus well below the right and left bronchus. So the trachea and the left bronchus there. After completing, you can very well appreciate the left recurrent laryngeal node arching from the aorta going to the groove there, and that is the right recurrent laryngeal nerve. And of course, the dissection is completed. So further is the abdominal part.
You have to stop. Go to the conclusion, please. You have to stop. Your time is up.
So I conclude that understanding the mesoesophagus both infracranially and supracranially helps you to dissect the esophagus and do a functional esophageal dissection. Thank you.
Thank you. So, any problem which you can encounter during this dissection?
So postoperative morbidity like atelectasis and pneumonitis is more because initially when we are doing more damage to the pulmonary branches of the vagus was there. So then after doing more surgeries, we avoided that, and now the patient is morbidity is reduced.
So any one of your patient had any type of neuropraxia in the postoperative period?
Only one patient in this past 1 year, and that patient recovered after 3 months.
So, question and comments from the house, please.
Thank you, sir.
Thank you.
So this closes the session, and thanks a lot for your kind attention and a very nice video presentation by all the presenters. So thank you all for your participation.
Thank you, sir. Now I would like to request you all to kindly join us for the lunch. Thank you.
We are back from lunch now, and we'll begin with the next session. That is the sixth session today. That is, and the topic for the next session is
Topic for next session is weight regain after sleeve gastrectomy for morbid obesity. Speaker is Mahendra Narvaria sir from Ahmedabad. And for chairing the session, I would like to call Dr. Madhusudan from Hyderabad, Gaurav Singh from Bangalore, Sandeep Verma from Lucknow, Dr. Nadeem from IJIMS Patna, and Dr. Ashok Kumar, who from SGPJ.
Good afternoon, everybody. First of all, I want to thank ISG Organized Committee and organizers from Patna for giving me this opportunity, inviting here for this talk. Everybody knows that sleeve is the most common procedure done worldwide, but today we are talking about failure of sleeve. We don't have any consensus to define what is a failure in any bariatric surgery. But broader category includes inadequate weight loss, weight regain, and inadequate comorbid resolution after bariatric surgery. What is the definition of successful sleeve? At least 50% of excess weight loss to be achieved within 18-24 months after the bariatric surgery, and resolution of comorbidities or improvement of comorbidities associated with morbid obesity. Weight recidivism is a problem. Weight regain after initial weight loss is another problem. An increase of 10 kg from nadir weight is considered as a failure, and BMI rise of more than 5 from nadir BMI is considered a failure, and regain of 25% of extra BMI loss from the lowest weight person has achieved is also considered as a failure. If we think about this definition and we try to look at the scenarios, we have weight loss of 120 to 80 kg and subsequent weight regain even to 95 kg is considered as sleeve failure. BMI which has reduced from 45 to 32 BMI and eventually come back at 38 BMI is considered as a failure, and BMI more than 50 which is come down to 40, that is a loss of about 10 BMI, and if it comes back with even 43 BMI is considered failure of the sleeve. What has been changed in last so many years? Yes, there is volume of bariatric surgery has increased, experience of surgeon has changed a lot, and expectation of patient has also changed in last few years. More and more number of people are seeking for revision bariatric surgery due to weight regain or complications like reflux and other problems after sleeve gastrectomy. Before we embark on revision, we need to understand why the surgery has failed. We need to understand the regions of failure, whether it is due to anatomical changes, that is keeping a residual fundus which getting enlarged over a period of time. Compliance of patient whose are sweet eaters may regain weight, and people with behavioral modifications and sometimes psychological issues along with bariatric surgery. We need to set a realistic goal both for the patient and surgeon. We need to know the expected weight loss for the patient, increase risk of the complications due to revision surgery, and we should achieve a long-term outcome in these patients. To understand anatomy, the most common and most important tool is previous operative notes. We do radiological investigation like gastrographin study or gastrochondral study or CT volumetry to see the size of the sleeve, endoscopy to rule out the reflux disease, GRD, and a large pouch of the fundus which is responsible for weight regain. And preoperative counseling by nutrition psychologists and multidisciplinary is more important, which will rule out eating malpractices, exercise program, whether they are adhering to it or not, or pair modifications. And with all of these, we need to know that what is our limitations. We need to have evaluation of the weight regain by multidisciplinary assessment. We need to know the initial weight, BMI and comorbidities, compliance of patient on diet and exercise after surgery, how much weight patient has lost, factor leading to weight regain, whether it is emotional eating, binge eating, or liquid intake like carb carbonated drinks, alcohol, and other high-calorie foods, or in reasons like post-pregnancy weight gain, limited activity due to osteoarthritis, and hormonal causes, or maybe few of regions like during COVID, people have received a lot of steroid, which is responsible for weight regain. We need to evaluate these persons. We need to take a detailed dietary history, what they eat throughout the day. And most of our Indian patients are having high carb diet and low protein diet. We need to assess the compliance of these patients to need set a realistic goal. Person who's failed one procedure is always have another chance of failing the second procedure. So we need to choose these persons very carefully. We need to know the volume of food they eat, the frequency of meal they eat, and type of food they eat, and symptoms of reflux. Many times the people eat just to relieve the symptoms of reflux, because after sleep, when they develop reflux, they may try to eat to relieve the symptoms of reflux. And psychological evaluation to rule out the stress-induced eating habits. So problem with sleeve gastrectomy is because this is the most common procedure, but it can cause inadequate weight loss, especially in morbidly obese person with more than 50 BMI. Chances of weight regain are very high and has a large standard deviation in the sense many patients do very well with sleeve gastrectomy, but many of them may not do so well with sleeve gastrectomy. Why it fails? The cases done during our learning curve, initial phases, we don't know the adequate sleeve, how to do it. Use of inappropriate size of bougie, more than 40 bougie size itself is responsible for weight regain. High BMI at the beginning of the many time surgeon tried to do a stage procedure because of high BMI. He is not comfortable doing gastric bypass or OAGB, and they do sleeve gastrectomy, which is again responsible for inadequate weight loss, and they come back with weight regain. Same for the high BMI. Incomplete removal of the fundus, dilatation of the sleeve, and sometimes even dilate the G junction. So the sleeve and esophagus remain a single unit, and people can eat more food, and that leads to. So this is how there is a uniform dilatation, and we can have dilatation of the G junction, which can lead to even reflux as well as weight regain. This is a study which is published with different posters at. So if you look at the sleeve gastrectomy, which falls close to 50 to 60% extra weight loss at 2 years compared to Roux-en-Y and glutenal switch. So, and this is a study which is published on more than 1,000 patients with a follow-up of 8 years. So extra weight loss after 8 years is close to 52%. Another published study in SWORD looked at the long-term studies of more than 7 years of duration, and conclude that 28% of these patients do not achieve greater than 50% of weight loss at 7 years. That means these patients fail, and almost means that almost 30% people who get a sleeve gastrectomy will have unsatisfied weight loss, and these people are especially chronically considering sleeve gastrectomy is now the most common procedure world over. This is another study which is published in SWORD, that is surgery for obesity and disease. And here they found that failure is in large group of patients, close to 30% at 5 years and 51% at 7 years. They also found the failure was related to high BMI, and this means that up to 50% of all sleeve will fail in future. And looking at this data, this is another study which is published and showing that almost in 2016 there were about 125,000 sleeves which were done all over the world. This means after 7 years, 35,000 patients will come back with unsatisfied weight loss. That means these patients may need sleeve revision at a point of time. Now, how to approach these patients? We have a conservative approach. Putting these patients again on liquid diet, just like a postoperative phase, and gradually changing their lifestyle is one option which has high chances of failure, and it needs a strict compliance, which is usually lacking in these patients. We have anti-obesity medicines, the newer medicines which are being more considered as a promising are GLP-1 analogs, and in surgical option we have re-sleeve, bend the sleeve, conversion to gastric bypass, BPD or SADI. Anti-obesity medicines are being used in more than 6 decades, but currently only 6 medicines are FDA approved for weight loss for the long term, and of which one of them is as a device, but used as a medicine. And there are two drugs which are used for short-term use, and most of results are from studies after primary use of medicine, not after the bariatric surgery, because we have limited data on using these medicine after the bariatric surgery. So these are few publications. Here there is, this is the non-absorbent hydrogel, which is used as a space occupying thing, which is considered as a device, but it is used as a medicine, has some weight loss, and most of time the weight loss in this person is 5 to 8%. Very only in semaglutide it has gone to 12.4%, and the combination of sema, GLP-1 and GIP, it is 17.8%. That is Monjaro. Saxenda was being used since last more than 10 years. It is a GLP-1 analog. The mechanism of this medicine is it reduces the appetite, hunger, and reduces the emptying of the stomach, that is delaying the gastric emptying. There are two trials showing about 8% weight loss compared to the placebo, and in another trial it is 6% compared to the 2% with the placebo. Wegovy is being used, the injectable in worldwide, except in India we don't have injectable semaglutide in our country. There are different strengths which are available, and their mechanism is same like Saxenda, but results are better than the Saxenda. We have few trials. There are few off-label medicine which are being used for these patients, which includes even metformin, buprenorphine, and naloxone. We have other topiramide, which is anti-epileptic medicine, which is used as a appetite suppressant medicine, zonisamide, metrolaptine, and many such drugs. And few which are coming are retatrutide, which is a triple agonist of GLP-1, GIP, and glucagon, which is having close to 24% weight loss in almost all patients, though it is still in under clinical trial, and we may get this medicine in another year or two. Other medicine, which is a combination of semaglutide with called CagriSema, which is about to come in market in next year, which is supposed to have about 15% weight loss, and few such medicines. But we need to understand that most of these medicines are used as a primary medicines. We don't have much data with the surgery, and many medicines which are having oral formulations, they may not get absorbed because of the malabsorption process we have done in these patients. So the injectable drugs are the most important, having a better result than the oral medicines. There are studies showing that we should not wait for these medicines to be started when they start regaining, but when they reach the plateau or they're not reaching the target, we should start these medicines to have a significant weight loss after the surgery. So we have many such studies. These are the few studies which may take a lot of time, but if we talk about only revision after sleeve gastrectomy, we have multiple options. We have re-sleeving the stomach and putting a band on it. We can do MGB or Roux-en-Y gastric bypass, or we can do duodenal switch as a loop, single anastomosis or double anastomosis. Re-sleeve has a longer operative time, high chance of intraoperative and postoperative complications, and extra weight loss is significantly very low. Duodenal switch is again easily performed procedure as a loop anastomosis, single anastomosis, which can be used, and we can discharge this patient much faster. This is a consensus guideline of duodenal switch, which was published, showing that these patients who get primary sleeve gastrectomy without reflex can opt for duodenal switch. In India, we don't do duodenal switch as a procedure of choice. We have single anastomosis gastric bypass as a procedure. We have MGB as a procedure after the sleeve gastrectomy. And similarly, if you look at the different combinations, we have re-sleeve, ring with the sleeve, Roux-en-Y, and omega loop gastric bypass. Omega loop gastric bypass, that is one OAGB is having better result, and BPDS as the base, but it has significant malabsorption, so we don't offer to these patients. We have many such publications on revision after sleeve gastrectomy. This is a survey done by my friend Kamal Mahawar from US, by about more than 460 surgeons all over the world. And here most of people, they prefer to do Roux-en-Y gastric bypass as a procedure of choice after revision to these patients. OAGB is almost 42% of patients. Re-sleeve is almost 22%. SADI-S and others are few of them which have be done. So Just a small video if the time permit. This is a revision after sleeve gastrectomy. You can see the dilated sleeve, and this patient had even a hiatus hernia and severe reflux. The quality of life was very bad. So this is surgery done almost 3 days back. And luckily there are lace adhesions in upper part of the abdomen. Momentum is divided from the sleeve. Posterior dissection done. You can look at the hiatus, which is having significant widening. Now the challenge with the sleeve gastrectomy that there is no fundus available to do fundoplication. So this is a new technique which I usually do after sleeve gastrectomy, wherein we dissect the esophagus, bring it to the abdomen, and then create a sling using the falciparum ligament. This is falciparum ligament which is separated. The sling is prepared using this device, this falciparum ligament, and this is taken up and used to wrap around the stomach. This is a hiatus which is sutured using a suture. The bougie is placed inside this esophagus, so don't have so much of narrowing. Now this falciparum ligament is wrapped around. Why I am showing this process is because you might, being a GI surgeon, you might get such patients coming to you with reflux and you don't have anything to be offered to these patients because there is no fundus there. So there is a LINX device which is available, which is a foreign body. I don't have any experience, and it is very expensive also. But this is alternative to it. You can fix this sling completely, so it will not allow the esophagus to migrate inside the chest. And then you can perform the gastric bypass below this. So I'm just suturing it all around so that it will do not slip. Then this pouch is resized, dividing after the first branch from the left gastric, and then it is further reduced by putting a bougie. You can see the size of pouch is significant when it is dilated. So you revise it, then do a Roux-en-Y reconstruction using 100 centimeter of BP limb and 125 centimeter of Roux limb, and then taking this Roux limb up just to, and we always put a marker here to differentiate the proximal and distal end. This is jejunal which is done at 125 centimeter below the Roux limb. Enterotomy is closed using stapler, and then this loop is taken up. I usually prefer 2-layer anastomosis, avoid leak in these patients. Otherwise, revision surgery patients has high risk of leak compared to the primary surgery. The anastomosis should be 2.5 centimeter and not more than that. Otherwise, this will act as a large pouch and they may not have weight loss you desire to achieve. I always prefer to suture this enterotomy from one angle to the middle, from both the angles, so that chances of leak are negligible. I don't put any drain, and most of these patients, they go home after 48 hours. So in revision surgery, the technical tips are do adhesiolysis properly and to clear the anatomy very well. Approved choice of gastric staple in this patient because the wall thickness is very high. So usually I use the green cartridge here. Sometimes you use the black cartridge because of edematous stomach. Forcing a staple line and using an intraoperative leak test is must, and surgeon's interpretive decision is most important and important factor to have a good outcome, and extra operative time should be allotted to these patients, should not be done in hurry. Set realistic expectation both for the patient and surgeon. Be surgically equipped, should have everything available in your operation theater, and should mentally equipped to do revision surgery, and we should know your limitations. With this, I complete my talk, and I invite all of you, those who are interested in obesity, for our national conference in Ahmedabad on 13th, 14th, 15th of December, wherein we will have all the experts dealing with obesity will be there, medical, surgical, endocrinologists, and all. Thank you.
Thank you, Dr. Narvaria. That was an excellent and elaborative presentation. I have one question. What, with the current trend in explosive trend of medical tourism, when patients just fly in from different cities or different even countries for the bariatric surgery and then leave away immediately after surgery, what would you recommend choice of surgery between sleeve versus bypass, with possibility of regain of weight in sleeve and a possibility of severe malnutrition in bypass?
I don't do sleeve alone as a standalone process in last 15 years because they have high chance of regain, and I don't want failures. So what I do is I do decompress sleeve. Sleeve is joined with a loop at 150 centimeters so that the sleeve is decompressed. It will not dilate over a period of time. There is no risk of reflux. That is called sleeve plus procedure. We have both modification. We can have a loop or we can have Roux-en-Y reconstruction with sleeve, which will reduce. So you have the duodenum as a passage available, as well as the food is going to jejunum also directly, and it will behave like OAGB or MGB, but technically it is sleeve plus procedure. So that is what my procedure of choice in last more than 3 years, and I'm very happy. Chance of weight regain or having repeated endoscopy for marginal ulcers are negligible, which is otherwise more common in OAGB. Weight loss wise, I think OAGB is the best procedure which has significant weight loss. So all super obese person who is more than 50 BMI, I prefer to do OAGB as a procedure of choice. So they have better weight loss and they can maintain weight for a significant period of time. Anybody who is more than 60 BMI, I always tell them that they may need a second surgery because you can't achieve everything in a single procedure, and they may come back for the second surgery if they're mentally prepared. So you should, as a surgeon, you should tell them what they expect from this procedure, and this is what is the outcome.
One more thing is, what do you recommend patients who are not adjusted for diet, who have binge eating behaviors and all that? Do we still recommend surgeries? Because weight regain is definitely an issue.
See, I think these patients, the insulin resistance is playing major role. So once they lose weight, they may change, a significant change, their hormonal changes get changed, and they may maintain. So we should give one chance to these patients with the proper psychological evaluation and all. And once they lose weight, usually they prefer to maintain it. And 90% people they maintain, 10% may regain weight, which is their fat, can't help.
Thank you.
You already tell there is two reasons. One is anatomical and second is compliance. So anatomical is look like a primary failure is inadequate surgery. So what precaution you take and tell the audience and the people are doing the bariatric surgery to avoid any regain because of the anatomical region?
I think one is the proper training, and it should be a proctor training. Whenever you're doing first few cases, you should have a proctor available in your operation theater who can guide you properly. So who will observe how you do it. Sleeve should be having a lateral staple line without any zigzag, and you should have complete excision of the fundus. The last staple should be about 0.5 to 1 centimeter away from the G junction, should not be close to G junction to avoid future leak. Leak is the most common complication after sleeve gastrectomy. I also had leak in my first 100 cases, but after that I never had leak in any of my patients. Gastric bypass and OAGB, I don't have a single leak in my life. So I try to reproduce the same process every day so that we can have a better result.
Second thing, what is your experience regarding the non-surgical kind of treatment? You described so many drugs.
We do
decreasing-
everything. We do gastric balloon, we do medical management, we do gastric plication, we do everything except the endoscopic gastroplasty is the one which I don't want to do, because I published a randomized clinical trial comparing sleeve gastrectomy with gastric plication, and wherein the plication was much inferior than sleeve gastrectomy. So I am not happy with gastric plication, whether endoscopy or surgically. So we don't do it. Otherwise, rest everything. I think new GLP-1 molecule which are available will have 10 to 15 kg weight loss, but we should not expect more than that. If you want to add, we can have balloon and GLP-1 analogs together to achieve
So
maybe
what
about
approach we should have? So approach these patients regain the weight after the bariatric surgery. How we
See,
decide
those-
ourselves
these-
to start the medical treatment or some kind of the surgical treatment, and different kind of option also surgically.
See, super obese patients who are not fit for surgery should be advised medical treatment first till they become a fit for surgery, and then we do surgery. Those patients who are super obese or BMI more than 50, I usually add medical treatment at early phase before even reach their target or a nadir weight, so that they lose more weight. So metformin is the most common drug which I usually prefer to use in first 3 months. We start metformin and glucose because these patients, they develop a craving for carbs and they can have more weight regain or inadequate weight loss.
Thank you, sir. Uncovered and very important topic.
Thank you
for the
so much.
sir.
Thank you. I have flights to, and so I'm leaving. Thank you so much, everybody.
Any
Thank you.
questions? Okay, thank you, sir.
Thank you.
I invite our next speaker.
Next, I would like to call upon Dr. Ramesh from GEM Hospitals for giving his talk on metabolic surgery current status.
Good morning. On behalf of Dr. Praveen from GEM, I am just delivering the lecture. And I am more comfortable with the esophageal surgery rather than metabolic surgery. Just I will read out the thing what he has given to me. And regarding the discussion part, I think chairpersons and others can take over the thing. So way back in 1954, developed the bariatric surgery where they have removed part of the intestine and anastomosed set, and the weight loss was there. And obesity, is it really a disease or it is because of high intake of food or low expenditure? It is a complex disease actually because of neural signals or gut hormones to deal with the gut microbiota now. So bariatric surgery principles depends on the restriction surgery or a malabsorption surgery that produces anorexia and energy expenditure by modifying the hormones like ghrelin, peptide YY, leptin, and other hormones. So the ghrelin, you know very well that it is a appetite hormone produced in the fundus of the stomach. Leptin is a satiety factor produced in the fat cells. And what happens in obese patients is patient have a leptin resistance that gets regulated by obesity surgery. And peptide YY, anorectic hormone produced in the terminal ileum, that's dysregulated in obesity. Then by doing laparoscopic sleeve gastrectomy or RYGB, the level rises or regulation starts when we do surgery. So who would you thought that operation will give remission to the diabetes mellitus? So for that we need to understand about the incretin effect. So incretin effect, or the incretins, are the hormones which are produced by the intestine cells because of the glucose intake. So what they did, they gave IV glucose and oral glucose. When they give oral glucose, the hemostasis was good, the insulin secretion was good. Then they found out that there are some of the hormones which are produced in the intestine because of the glucose stimulation when they take orally, and that produced a glucose hemostasis very nicely. That is GIP and GLP. So GIP is produced initially, and that is glucose dependent insulinotropic peptide. there comes the foregut hypothesis. That is, in type 2 diabetes, what happens? The incretins levels are very less and the anti-incretin factors are more. So that produced, because of these anti-incretin factors, the delayed insulin response was there and the impaired insulin action was there. That produces hyperinsulinemia. So where the anti-incretin factors are produced? They are produced in the duodenum and the proximal jejunum. So what happens if you do a bypass? If you do a bypass, this anti-incretin factors are not produced, and instead the incretins are produced more. That is, GLP is more, improves the insulin response and action, that normalizes the plasma insulin and glucose level. So that is hindgut hypothesis there, where you get the ileal cells or ileum, the cells from the ileum are stimulated and GLP-1 is produced, and there comes the hindgut hypothesis, and the secretion is impaired in type 2 diabetes. The insulin increases the insulin secretion, reduces the glucagon secretion, reduces the hepatic glucose output, reduces the gastric emptying and traffic to the B cells. So what happens if you do RYGP or laparoscopic sleeve gastrectomy? This produces supraphysiological values of GLP-1. So that normalizes the thing. So is laparoscopic Roux-en gastric bypass still the gold standard for gold standard procedure for the Indians? Yes, when we compare the BMI, you can very well appreciate that it has come from 40 to 28 in first year and 29 in third year, and long-term result is 31. And of course, the HbA1c comes down from 8.6 to 5.9 in 1 year and 6.2 in 3 years, and long-term result 6.4. And it regulates the cholesterol level, triglyceridemia level, and LDL level. So thereby, long-term benefit. And some other paper that is 10 years also, you can very well appreciate that it has come from 51 to 34, 37 and 39 and 10 years follow. So the surgery reduces, bariatric surgery reduces the weight by regulating the hormonal level, and also treat the type 2 diabetes, and RYGP improves the metabolic outcome for at least 5 years in patient with class 1 obesity. So this supports the decision of over 50 medical societies to include metabolic surgery within their type 2 treatment algorithm. So is there any concept of diabetes cure? How do you define the cure of diabetes? So prolonged remission is complete remission that lasts for more than 5 years and might operationally be considered as a cure. So the Stampede trial, we can appreciate that when we compare glycosylated hemoglobin with the months, the medical therapy is in the top level, that is still it is in the higher level, whereas sleeve gastrectomy and gastric bypass gives a very good control in 5 years. So the available evidence suggests better remission and lower risk of microvascular and macrovascular disease and mortality in the surgery group as compared to non-surgical treatment group in type 2 diabetes in 5 years follow. So metabolic surgery is a choice or option when the BMI is more than 30. So it reduces the weight, treats the diabetes, and also in our own study, we did a biopsy and we followed up with the patient. Study presents with the histological evidence of significant improvement of NAFLD after surgically induced weight loss by sleeve gastrectomy and Roux-en-Y gastric bypass. So of course, newer advances, as previous speaker was talking about, the endoscopic sleeve gastropexy we do in our department, that is done by endoscopic colleagues, and that too, it is also by suggests that it's a cost-effective treatment option for people living with obesity and should be considered in commercial health plans. So in large real-world cohort study of patients with United States data signal that the use of pharmacotherapy at the appropriate time, patient can achieve optimal results. So we do have a balloon gastric balloon, and combining multiple balloons or with medical and balloon in 3 months, 6 months, 12 months reports and multiple balloons gives a good result. And this is endo barrier, which we same concept of surgery. You just place through the endoscopy. You prevent the absorption from the proximal intestine and the duodenum, and the bile and other thing mix and the distal part. And whenever the results, you get the results, then you remove it endoscopically. So whatever may be regarding obesity or metabolic disease treatment, the lifestyle intervention remains the base, and of course, the next level is the medical therapy. The surgery comes the last in the pyramid. In conclude, the intestine is the largest endocrine organ of the body. Metabolic syndrome is a result of complex interaction of intestine, adipose tissue, and pancreas. Bariatric surgery is not just about restriction of food intake. Manipulation of small intestine can produce beneficial metabolic effects. The metabolic surgery. Thank you.
Thank you, sir. That was a excellent presentation. The hall is open for questions.
So what is the actual here from the chairperson? Yeah, I'm here. Yeah, this side.
Sorry, sir.
So there was the surgery. So many the procedure described you already have done, said, and there's new advance. You tell about the new advance method. So what is the current status of these advancement in the bariatric patient for purpose of metabolic responses?
Now at present, what we have started using only past 1 year, we are doing this gastropexy, and these barriers balloon we are not using, only 1 or 2 cases we have used. Still further studies we have to make, and then only we can comment about that. Till now, we are doing more of surgical work rather than endoscopic work.
So still we should be on the corrective kind of restrictive and bypass kind of surgery should be the most advanced right now. It still is advanced current status of the surgery.
I don't get you.
Yeah.
Of now, surgery is the only method which gives sustainable weight loss, and newer and current treatments are still way far from being evaluated and put for a standard thing. I think any more questions from the audience? Thank you, sir.
Thank you very much.
Thank you, sir. For the next talk on early gastric cancer advances in treatment, we have Dr. Chetan Kantaria, and he's joining us online.
Is my screen visible? Hello? Hello? Hello, am I audible?
Yes, sir, you are audible.
Okay, so I start now. So, respected chairpersons, seniors, and colleagues, the topic of my today's presentation is early gastric cancer advances in treatment. So when we speak of early gastric cancer, it means T1A lesion involving the mucosa and T1B lesion that is involving the submucosa. And the recommended treatment for this is endoscopic resection, be it either endoscopic mucosal resection or endoscopic submucosal dissection. Apart from the important prerequisites or indications which dictates endoscopic resection, lymph node metastasis, that there should be no lymph node metastasis, is one of the most important caveat apart from the other prerequisites. As seen here, that apart from lymph node metastasis, the horizontal margin as well as vertical margins, they also play a very key role in deciding the completeness of treatment, otherwise which will require addition of surgery following endoscopic resection. Interestingly, in a study carried out on specimens where gastrectomy was done following endoscopic resection, it was seen both for differentiated tumors with tumor more than 3 centimeters in size and undifferentiated tumors less than 2 centimeters size, that there occurred lymph node metastasis in as high as 3 to around 8%. In yet another study, it has been shown again on studies done on specimens of stomach which has been resected following endoscopic resection, the lymph node metastasis was as high as 26%. So in spite of the best of the modality where you decide upon endoscopic resection, we find that there occurs lymph node presence which requires subsequent surgery. Of course, we do have today chromoendoscopy, narrowband endoscopy, and magnifying endoscopy, which helps us to determine that the prerequisite for endoscopic resection is met with. But this does not take into account the endoscopist skill level, the fatigue factor on part of the endoscopist, because they usually do more than 10 endoscopies per day and reading very precise images during a relatively short endoscopic procedure. All these which may lead to error and doing an endoscopic procedure in a patient who otherwise would warrant a surgery. So it is here where the recent advances of artificial intelligence comes into play, because as far as early gastric cancer is concerned, it helps to assist with endoscopy reading and interpreting the images. It predicts the horizontal boundary of the lesion and also predicts the depth of the invasion or the vertical margin, what we call it today. Now, artificial intelligence is a concept where it is believed that the computers imitate human knowledge and experience, and based upon it, you act, reason, and make decisions with intelligence similar to humans. It makes use of algorithms which helps to learn and draw conclusions based on the vast data which is pooled in. So it is nothing but machine learning, which comprises of neural networks which mimics how the brain interprets informations and draws conclusion. And today we have trained neural networks which derives most appropriate result by combining and analyzing various factors, including symptoms, risk factors, and experimental results, which helps us to draw conclusion. So as far as the early gastric cancer is concerned, the neural technology which is used is either deep learning or convolutional neural network, where deep learning excels at capturing complex and intricate correlations, while convolution neural network is designed for visual image analysis, which is inspired by human optic nerve. So convolutional neural network extracts features such as line, color, contrast, shape of image, and converts them into values which reflect as a non-linear activation functions such as ReLU, sigmoid, and theta. This then undergoes a subsampling process such as pooling, which is followed by a selective process such as reducing. And subsequently, each step is linked and classified into the most appropriate value using the softmax function. So this is the pictorial view of how a source image then undergoes a process of pooling and finally gives you a result. So based on this, the algorithms are developed to detect and classify various gastric lesions under different diagnostic conditions of white light endoscopy, microendoscopy, narrowband imaging, and chromoendoscopy. So if one sees the domain under which the various endoscopic procedures function, it comprises of pre-procedure assessment, completeness of process, identification of pathology, management of pathology, complications, and post-procedure formalities. So what does AI do? As far as AI is concerned, it acts on completeness of procedure, where it helps you to inspect the GI mucosa and will tell you whether adequate documentation has occurred or not. Identification of pathology, it helps you to determine whether this pathology is malignant or not. And management of pathology, where it tells you whether this lesion is amenable to endoscopic resection or not. As far as the application of AI in diagnosis of early gastric cancer is concerned, there are various studies which have carried out in recent times with an aim to predict lymph node metastasis, occult peritoneal metastasis, to subtype MSI, and all have shown accuracy of as high as 80 to 90%. Besides this, studies showing the application of AI in detecting early gastric cancer is in identifying the lesions have shown that these studies have been useful in most of them, and in fact outperformed their task in 2 of the 5 studies which have been mentioned. In studies which have shown application in detecting the margins, again, these studies have shown that these have outperformed their task, and they are in fact better than best of the endoscopic technology can be used. Again, in studies which show the depth of the invasion, again, all these are recent studies. They have found that these studies have outperformed and give with great accuracy the depth of the invasion, telling you whether you should be doing submucosal dissection or this patient is better managed by gastrectomy. So as far as the application in the treatment decision is concerned, again, you see that it helps him to delineate the resection margin, to predict the response, to predict the prognosis. Again, the results have been showing an accuracy rate of more than 90%. Besides this, as of today, there are various clinical trials which are ongoing and registered with the clinical registry, and these are further going to validate the application of AI in management of early gastric cancers. So if I were to say what is the use of AI in early gastric cancer, it is helpful in screening, where it identifies precancerous disease and supports the detection of early cancer. It helps to confirm the diagnosis by determining the TNM staging, depth of invasion, and also help with histopathological and molecular subtyping, and help me to decide what treatment is ideal for it. Should it go endoscopic? Should it be undergoing endoscopic resection, or does it require a formal surgery? So this is what application of AI is. So if I have to summarize, today, cancer biology, surgical technology, medical therapy, and AI technology is advancing at a very rapid pace. We surgeons today operate at an intersection of clinical outcome, scientific discovery, and technological advancement. And as far as early gastric cancer is concerned, artificial intelligence has helped us to provide a definite diagnosis and thereby help us to give a specific, appropriate, and curative treatment for the patients of early gastric cancer. Thank you very much. And at the end, I would like to thank the organizers for facilitating me to give this talk online. I am absolutely very sorry that I couldn't be there present in person because I had to rush in for an emergency. And I would like to commend Dr. Khandelwal, Dr. Mandal, Dr. Sanjay, and Dr. For providing such a wonderful conference. It was really one of the finest conferences that I attended on day one. Thank you very much.
Thank you, sir. That was an insightful presentation about advances in early gastric cancer treatment and diagnosis. For the benefit of younger audience, can you please tell us the interface, hardware or software needed to incorporate these tools in practice? What are these what tools are available? Are they available or
So
not?
these are definitely available. They are available in our country as well. There are various softwares. If you have seen, the radionomics is one of the commonest software which is used to detect the lesion and to determine the depth of the lesion and the horizontal margin as well. So there are 2 to 3 common platforms which are being used, which I have mentioned in my presentation, and they are there very much in our country as well. And I'm sure many centers, including AIG, are using this technology for their endoscopic procedures.
Thank you, sir. Any questions from audience?
So thank
Thank you, sir, for the excellent
very much.
presentation.
Thanks.
Thank you very much.
Thank you, sir. And thank you all the chairpersons. So the next talk is by Dr. Mohammad Ibrarullah from Bhubaneswar, and he's going to talk about reconstructions after total gastrectomy, techniques and tips.
Good afternoon, everybody. So the basic goal of reconstruction after total gastrectomy is to restore GI continuity so that the patient is able to eat normally, normal food, to restore GI physiology so that the digestion and the food that he takes is digested adequately, and to provide reservoir for food so that he takes he takes food adequately, that there is no nutritional imbalance in the long run. You will be surprised to know that there are 70 reconstructive techniques of esophagojejunostomy, that is after gastrectomy, the replacement surgery, that is esophagojejunostomy. There are 70 odd techniques described in the literature. In different configurations, you can see the anastomosis happening from one limb to another and all that. But suffice it to say that no single procedure is better than the other. The long-term consequences in terms of nutritional and quality of life is same irrespective of the procedure. So what really matters when you are doing a reconstructive surgery is the technical simplicity and the technique which should minimize the bile reflux to the esophagus. So these two factors are most important when you are designing or you are planning a reconstructive surgery after total gastrectomy. These are the 3 most commonly performed techniques, that is loop esophagojejunostomy, the Roux-en-Y esophagojejunostomy with or without pouch, and jejunal interposition esophagoduodenostomy. Of these 3, the first 2 are my preferred techniques because of, again, I said the simplicity and their effectiveness. So first about the loop esophagojejunostomy, this particularly I'll consider if it is a thin-built patient. The esophageal stump is not very deep. That means it's accessible for taking the sutures for an anastomosis. And the mesentery is not too bulky to restrict the jejunum from coming up. And then you should see that the jejunal loop is freely reaching the site of anastomosis. So then here one thing is important. You have to do a lateral jejunostomy, as you can see here, to allow the passage of the bile. And this would also minimize the reflux of the bile to the esophagus. But then this does not really completely stop the bile from refluxing. So there is some amount of reflux associated with this. That is why this is not considered a very optimal or an adequate procedure or the ideal procedure for reconstruction. So particularly in patients who have a limited life expectancy, like when I'm doing a total gastrectomy as a palliative measure, I'll consider doing a loop esophagojejunostomy rather than going to a more elaborate procedure. And this esophagojejunostomy Roux-en-Y is the procedure of choice that I'll do in most of my cases because this Roux-en-Y ensures an adequate jejunal limb for a high tension free anastomosis. In fact, a vertical Roux loop can reach as far, as high as up the lower chest for an anastomosis. And if done properly, there is no bile reflux. Besides, the Roux loop has a tendency for a slow transit, so that gives a sense of satiety to the patient, even if he's taking a small amount of food. So there are basically 3 components to it. for doing a proper esophagojejunostomy Roux-en-Y. That is preparation of the esophageal stump, preparation of an adequate rulum, and then anastomosis. Regarding esophageal stump, you should make sure that at least 4 to 5 centimeter of the esophagus is available transabdominally or abdominally for an anastomosis. But then in the process of retaining a good amount of a stump, you should not compromise on the tumor-free margin. So point is, how do you achieve such a good length of the esophagus? For that, you have to encircle the esophagus, dissect it circumferentially in the hiatus way up into the thorax. So that itself would release at least 4 to 5 centimeters of the esophagus into the abdomen for a, so as to give you a good stump. But then if adequate tumor-free stump is not available abdominally, do not hesitate to open the chest because that way, instead of struggling with a small stump abdominally, it's better to open the chest and do a good, comfortable esophagojejunostomy. And for that, if you think, if you anticipate this kind of problem during surgery that you may not be able to have a good stump, then prepare this patient pre-operatively. That means like you position this patient, paint and drape the chest so as to prepare him for an anterolateral thoracotomy if there is any requirement. And also you should have a chest retractor ready just in case you require a thoracotomy, because without chest retractor or that phenocitor retractor, you just cannot enter the chest or you can't do anything inside the chest. Now, having created a good, mobilize the esophagus, then it's a esophageal transection. So for that, you apply 2 stay sutures, as you can see, seromuscular sutures on either side of the esophagus. And the Satinski's clamp is a very useful clamp. Apply it as high as possible to the, near the esophageal hiatus, so as to give stability to this esophageal stump that it does not retract into the thorax once you divide it. And when you're dividing the esophagus, divide the muscle layer first. Then the mucosal layer, divide at least 1 to 2 millimeter beyond this muscle layer. Otherwise, this mucosa retracts so that you don't have a full thickness available for anastomosis. So divide the mucosa at least 1 to 2 millimeters beyond the margin of the muscle what you have divided. So that then gives you an ideal stump for anastomosis. And as regards Roux loop, this is also equally important. Identify the fixed segment. This is the DJ flexure. Inferior mesenteric vein could be a guide to this. Then just hold this loop against the light so as to see the vasculature. That is very important. You need to decide where to divide or which pedicle to divide and how to have a good vascularized pedicle and a long pedicle available for surgery, for anastomosis. Now, if you see this against transillumination, you can clearly see this 3 main feeding vessels and this continuity of the arcade. So if you want a very good limb, you can sacrifice these 2 pedicles so that you have a loop available based on this pedicle and based on this arcade. So you get a very good vertical limb of the jejunum for anastomosis. This can reach as high as up to the thorax, as I mentioned earlier. But if you want a smaller limb, you might as well retain one of the vessels. You can divide this and divide the loop here so that you have a Roux loop of an adequate length to do an abdominal anastomosis. Now, regarding this Roux loop, you should have at least 40 to 60 centimeters of the vertical limb of the Roux loop available for anastomosis. It should be tension-free, well vascularized. And if the colon is not too bulky or the mesentery is not too bulky, you can't take it anticolic. You can take it in an anticolic manner. Otherwise, you can take it in a retrocolic through the retrocolic window. That saves some length on the jejunum. Regarding the anastomosis, my preference is a single layer interrupted suture using 2O silk or Vicryl. 2-layer anastomosis is rather difficult here because once you take a seromuscular layer, then the jejunum and esophagus gets approximated. So taking the second layer becomes very difficult in the depth of the abdomen. Therefore, what I do is I always insist on a single layer anastomosis, pre-place this posterior sutures one after another. Having placed all the posterior layer of sutures, then you slide it up, like what you call it, railroading this jejunal loop into the esophagus. Having taken it there, then you tie the posterior layer, all the knots. And during tying the knots, make sure that the gap between two sutures is adequate, like it should not be more than 2 millimeters between two sutures. So having done the posterior layer, pass a Riles tube across the anastomosis into the jejunum for about 20 to 30 centimeters. And the Riles tube across the anastomosis makes the anterior layer, the suturing the anterior layer becomes easier. Then you approximate the anterior layer again using interrupted sutures with the knots outside. It's my practice always to place a drain and add a feeding jejunostomy to this anastomosis. That is what I do for all esophagojejunostomies. I very rarely use stapler, but if you have to, then you have to at least consider these 2 points. One, you should have an adequate esophageal stump available in the abdomen. And secondly, use an adequate size stapler, means it should not be too big. For esophagus and of an Indian patient, a 25 size circular stapler is good enough. If you take a larger size stapler, then there is a possibility that that might cause a tear, which may be difficult to repair. And if this tear again extends into the thoracic esophagus, then it becomes a mess. Then you are left with no choice but to do a thoracotomy and then repair this, for which you may not be prepared at that point in time. Therefore, use a proper size stapler, and I have found this 25 size to be adequate. Then insert the stapler through this short limb of the vertical of the jejunum. Do anastomosis or do a stapler firing in the usual manner. There's nothing much to mention there. And as I said, be careful about not creating an inadvertent tear in the esophagus. So that's all about the tips and tricks of the esophagojejunostomy. Thank you very much.
Very informative kind of presentation you have given, the technical issues to tackle all well. Do you have any experience of doing the side-by-side stapler anastomosis? Because I am doing the laparoscopically, so I am just more in favor of doing the side-by-side linear stapler anastomosis, because its anastomosis are always provide the linear kind of the anastomosis flap, like the gap, the communication between the stomach and the bowel. And I think it's also can decrease the chances of the reflex. It's very good, I think. And it's all very important to prepare the 4 centimeter of esophagus stump, keep the loop lax so that it could not cause the tension on the anastomosis. Good technical presentation you have given. That's very informative for us. Thank you.
Thank you.
Any question from audience?
A few words about jejunal pouch, because that's a very important topic to be discussed in exams, for especially for MCH DNB exams. So we would like to mention a few words about usage of pouch.
No, this particular end to side esophagojejunostomy can be converted to a pouch using the stapler, like with this U limb. You join them with a side, we call this linear cutter, and that becomes a pouch. For that, you have to take a little longer side limb, or that short limb has to be a little longer, 10 to 12 centimeters at least. So that is regarding J pouch, esophagojejunal anastomosis. But if you are taking an interposition, then you have to take adequate stump. The principle remains same. You have to basically configure it into configure J shape and then apply it linear cutter and convert it into a stapler and then do the anastomosis. There's nothing much. But then long-term effect, nutritionally and alkaline reflux and all that, there is not much difference between any of these procedures mentioned.
Okay, sir. Thank you. That was a very nice presentation, and yeah, that closes the session, I think.
To all the chairpersons, and thank you, sir. Next, we'll be starting with the panel discussion, and the first panel discussion that we are having is on obscure GI bleed. It's a case-based panel discussion, and for that I would like to welcome on stage Dr. Venkat Rami Reddy from Tirupati. And for panelists, I'd like to welcome Dr. Ashok Kumar from SGPGI, Dr. Venu Madhav from Hyderabad, Dr. Vinay Mahala from Jaipur, and Dr. Sudhir Kumar from AIMS Patna. Please take the chairs.
Good afternoon, everyone. At the outset, I would like to thank the organizing committee for the opportunity for us. And we have been asked to discuss upon the panel on the obscure GI bleed, case-based discussions. And with me, I have three of my surgical colleagues, Dr. Ashok Kumar from SGPGI, and Dr. Venu Madhav is a professor from Nizam Institute of Medical Sciences from Hyderabad. And then I have Vinay from associate professor from Mahatma Gandhi University of Medical Sciences from Jaipur. And then we have our medical gastro colleague, Dr. Sudhir. He's an assistant professor from AIMS Patna, medical gastro. Okay, so we'll be directly going with the cases. So this is a 77-year-old lady who was admitted elsewhere. The history of melena and sometimes hematochezia since 5 days. She had general weakness and fatigability, and otherwise no other past history she had, no comers, no previous surgeries. Otherwise, she had pallor, her vitals were relatively okay, pulse 108, blood pressure of 102/54, and this abdominal examination was remarkably normal, and perrectal melena was there in the stools, otherwise no growth felt. And initially this patient was evaluated outside, and her hemoglobin was 2.9 initially. But then they had to transfuse about 4 units of blood. Axles were transfused, and then it was 9.1. And then other investigations were relatively normal. So naturally, this patient underwent ultrasound abdomen, which was normal. Upper GI scopy was normal, except for some mild antral gastritis. And then she had total colonoscopy also done, which was normal. So now I'd like to ask my medical colleague, like, how do you define this bleed as? What do you think it is? Like, we have various definitions for the bleed: upper GI, lower GI, obscure, small bowel, all this. So can you just enlighten us what exactly is this bleed and how do you like describe these bleeds?
So there are three main terms used for GI bleed. One is overt, another is occult, and one is obscure GI bleed. So overt bleed is one which is visible. So if patient having GI bleed and having visible blood loss, it is overt bleed. And occult bleed we are considering when patient has no visible blood loss. So bleeding bleeding is there. Patient may have anemia, history of iron deficiency anemia, and fecal occult blood positive, but there may not be any visible blood. That is called as occult GI bleed. So in terms of terminology, obscure GI bleeding, definition of obscure GI bleeding has been evolved. Before 2015, it was defined and blood was considered as obscure GI bleed when upper GI endoscopy and colonoscopy reports comes normal after the initial evaluation. But ACG has redefined this obscure GI bleed after 2015, and we are considering now obscure GI bleed when evaluation of upper GI endoscopy, lower GI endoscopy, and capsule endoscopy in form of pan GI endoscopy is negative. So now at present, when upper GI, lower GI, and small intestinal evaluation has been fully done and patient has identified as no source of GI bleed, then it is considered as obscure GI bleed.
Yeah, so that is now obscure is really obscure. Like earlier it was, now it's actually taken a small bowel bleed than obscure GI bleed actually. So that is like actually obscure GI bleed actually they represent around 10 to 20% of all GI bleeds, and 5% of them actually remain recurrent and obscure. Like this 10 to 20%, like majority of them are there in the small bowel up to 75%. And the remaining are actually those which are missed on the endoscopy and colonoscopy. Okay. Dr. Venu, can you just say what is the common etiology that you'll be looking for when a patient presents to you with a small bowel bleed?
So we have to divide basically into young and old. So if it's under 40 years and over 40 years and patient with comorbidity, the etiologies are different.
Yes.
If you take younger patients, mostly it's inflammatory bowel disease and of course polyposis syndromes. Very young Meckel's diverticulum also should be considered with ectopic gastric mucosa
Yes,
with source
yeah.
of bleed. The other lesions like dulophies and neoplasias are always there, but polyposis also, if family history there, is important. And coming to elder age, it's mostly vascular lesions. Of course, NSAIDs and neoplasias there, especially patient with comorbidities like chronic renal failure, aortic stenosis. In them, these patients tend to have most of angiodysplasias and cause
Yes.
bleeding. Of course, there are some rarer causes also, but these are the more common causes in young and old.
Yeah, I think as a surgeon, we should also be very careful about this, the pancreas and also the bilirubin, all that also we should be looking at. So these are the causes. And Dr. Ashok, what are the diagnostic options that you have? If you look at, there are so many diagnostic options that are being given. Okay, so as a surgeon, like what exactly you look at the most important, the diagnostic options that you have?
So mostly obscure bleed, you already have done the bidirectional endoscopy.
Yeah, that is completed.
Upper GI endoscopy, you've done the lower GI endoscopy. Sometimes the endoscopy may be inadequate. Maybe the patient have unprepared, may have a loss of blood during the endoscopy, may not be the true obscure bleed. And upper GI bleed or endoscopy also have a problem. If you have a lesion in the very proximal part of the intestine, duodenum, proximal jejunum, you rapidly pass out through the way and you miss the lesion. Sometimes you already have healed, you already have stopped. So that's why this is very important to get the whether you are dealing with the true obscure bleed or just miss the bleed in the upper or lower GI.
Yeah.
We have an option. We have nowadays where there may be the different view on the approaching, which is the first initial should be the investigation according to the Japanese guideline. The more people doing the CT scan preferably
Yeah,
as an initial.
that I'll just come, we have some more on that. Just as a surgeon, you'll be looking at the most of these things. One is the enteroscopy that you have, then CT or MR enterography. Then we have CT angio, and then conventional angios that you have, the nuclear scan. And finally, I think it's intraoperative enteroscopy that is the last thing that you'll be opting. So this is like basically we choose investigation based on the pattern of the bleed, whether it's occult or overt, and then hemodynamic stability.
Yeah.
And the next thing is the availability of all the modalities, whether it's there or not. That's the most important thing. And again, Dr. Vinay, what do you think again regarding the repeat upper GI scope and colonoscopy? I think Dr. Ashok was telling a little bit on that. So what do you think of doing a repeat scopy? When a patient comes to you, do you repeat always, or you have any particular situations where you'll be repeating the UGI and colono?
Actually, if that previous endoscopy and colonoscopy has been done by an expert with the adequate preparation, then there is no need for the repeat upper GI and colonoscopy. Okay. But as Dr. Ashok has rightly said that sometimes the investigation has been compromised in terms of the patient factor as well as the doctor's factor, then definitely second look endoscopy is a good investigation of choice rather than directly jumping on further investigations.
Yeah, especially we have about 25% of the cases where they would have missed actually in that 10% of obscure bleeds, especially these are AV malformations, sometimes we can miss. That's the one. Okay. And how do you proceed with, Dr. Sudhir, now how will you proceed with this patient? What investigation will you choose and how do you go ahead with this patient, this particular patient?
So patient is hemodynamically stable.
Yeah.
Has history of severe GI bleeds, has history of severe anemia, and gone through recurrent transfusion. So patient having his upper GI endoscopy and lower GI endoscopy has already been done. So next investigation should be done in form of a small GI in evaluation, and it can be easily done with video capsule endoscopy. So next investigation should be a small intestinal evaluation with video capsule endoscopy.
Yeah, that is the guidelines actually both American College and European, both they recommend actually video capsule endoscopy as the first investigation of choice in a stable patient with a GI bleed. But this is regarding the, but do you have any, like if you look at the diagnostic yield, it's very high actually, it's very high, especially
Diagnostic yield depends upon many situations also. Means GI bleed frequently occurs intermittently. So what is the last time when patient has GI bleed? That also depends how much yield we can have with the video capsule endoscopy. Like if patient have history of GI bleed 48 to 72 2 hour back, then yield of video capsule endoscopy is very much high. And type of lesion can also define what will be the yield. So if patient having submucosal lesion, a small lesion and proximal part of lesion in the proximal part of the jejunum, that can be missed frequently with video capsule endoscopy. But ulcerated lesion, large lesion and lesion with active bleeding can be appreciated very frequently and have high yield with video capsule endoscopy.
So that's basically non-invasive one. That's why I think they have advised as the first investigation. And definitely what you said, doing it early will have a better yield. And the one is submucosal lesions may be missed in this. And of course, we have certain contraindications like any suspected obstruction. We don't usually go ahead with capsule endoscopy. Okay, apart from capsule endoscopy, suppose if it's not available or something it's normal, then how do you go ahead like next?
For evaluation of a small intestine, next investigation we can do enteroscopy. Enteroscopy in form of either post enteroscopy or device assisted enteroscopy. So device assisted enteroscopy comes with single balloon, double balloon and a spiral enteroscopy. So enteroscopy can be a next choice if video capsule endoscopy is not available.
Okay. So if you look at the yield, diagnostic yield, I think both are same. Like the video capsule endoscopy, one is non-invasive, other is invasive.
Yes.
And one is like you can do a therapeutic intervention, whereas capsule endoscopy you don't have option for any therapeutic
Absolutely
intervention.
right.
And that's why it's like if you have any patient having anything positive on there, then you go ahead with the second one. So it's also been said that the diagnostic yield is same. And these patients who have, that's why video capsule endoscopy is advised first is like if you have a positive finding on video capsule endoscopy, then your enteroscopy is likely to have more positive findings. So the diagnostic yield is similar, and because non-invasive, that has been the technique of choice. And what is CT enterography? When do you go for the CT enterography? When you want to take that CT enterography, because I think we use more than CT enterography along with this thing.
CT enterography is definitely useful investigations. Actually, as sir suggested, it is advised before even capsule endoscopy by some groups also. There are some specific advantages. We have a roadmap from which site is bleeding, if it's bleeding significantly. Second thing, we can find tumors like GIST which are identified by CT enterography, and other lesion like aneurysms can also. So CT enterography is definitely a map, but in slow bleeds, especially capsule endoscopy can be advised early because it picks up the lesion earlier, and especially in this lady, we are suspecting some vascular region, so endoscopy is close. Once endoscopy doesn't show any source or patient is continuously bleeding, then next investigation of choice is CT enterography, and especially patient in hemodynamically stable.
Yeah.
So we have to go for CT enterography, and then CT enterography gives a picture of what is the probable site of bleeding and what's the actual site of bleeding. That is a very useful investigation.
Yeah, especially if you look at these studies, they have shown that the submucosal tumors, there usually our video capsule endoscopy does not show anything, and these are the cases where CT enterography will actually help you. So, but otherwise, like diagnostic yield of CT enterography is less when compared to the other things, but it's helpful when you have suspected tumors. Okay. And this is one comparative table that has been there in the recent advances by Professor Sastry. This is the video capsule endoscopy is about more than 90%, but it's like contraindicated in obstruction. The deep enteroscopy, it's almost same, and CT enterography is 34%, and in cases of obstruction you can do that. The scintigraphy and operative endoscopy, they are a little rarely used, but in case of Meckel's diverticulum, it can be used. Okay, this case actually, the small bowel enteroscopy was done for this patient as the video capsule endoscopy was not available. So this patient underwent small bowel enteroscopy, and you have described about the enteroscopy, and this was the finding in that small bowel enteroscopy in this patient. There was enlarged submucosal blood vessel of 20 mm with a platelet plugs, and this lesion was located 10 centimeters from DJ flexure. And they said it's probably enteric AV malformation or angiodysplasia. So, what do you think you can do with this? Yeah, Dr. Sudhir.
So this is a large lesion with a stigmata of recent hemorrhage, SRH. So we have to manage this actively, and if we are doing enteroscopy, we can plant endoscopic intervention. So large lesion can be managed with hemoclip. So we need a large hemoclip for the large lesions. Usually the small hemoclip has may cover the diameter of 8 mm. Larger hemoclip can cover a diameter of 11 mm, and we have another hemoclip over the scope clips. So over the scope clips can cover the diameter up to 14 to 15 mm. Large lesion can be covered, and if the lesion are larger so that we cannot cover with the hemoclip, we can try sclerotherapy or glue therapy.
Okay. So actually, so these are the options that we have: APC, cautery, then hemoclips, then glue injection, all that. This patient had a glue injection done, and of course, once they injected, there was a aggressive bleed, and they had to inject 2 more ml into this patient. So how do you grade like this patient? How do you follow up? Do you think the treatment is done and this is likely to be successful? This patient.
So patient having SRH and actively oozing blood at the time of intervention have most of the time they rebleed and have high chance of rebleed. Always they have to monitor closely, and we have to look whether intervention has sufficient enough to for stopping the bleed, or there is a recurrent episode of bleed.
Yeah. Do you like do anything to follow up these patients except, I mean, apart from observation? So you know that there's a big vessel in this patient, likely almost this it's quite a big vessel.
If we have identified any abnormal vessels, we have to do CT angiography to look whether there is any abnormal vessels, any arteriovessel malformation, and any other lesion that can have some.
So especially these patients, like AV formations, if you look at the literature, the incidence of rebleed is very high. So this patient actually, day 2 of glue injection is had a recurrent bleed. Again, hemoglobin was 6.22, and then 2 more patches were transfused. And now this patient was referred to JS surgery unit. And Dr. Venu, what is your approach for this patient now that patient is referred to us?
Now that adequate endoscopic therapy is done, then of course CT is done, which shows a vascular structure in the proximal lumen. So there are 2 options. One is angiography, and then embolization is one of the option. But the problem is these patients may develop gangrene and perforation, which is to be closed. Depending on the condition of the patient, if patient is stable and fit for surgery, surgery is also a good option for these patients because it is localized, well localized in the proximal jejunum. And
yeah, Ashok, you want to say something?
Yeah. I want to say that this look like a big vascular lesion, more chance of the rebleed, and second thing is very situated in very proximal part of the bowel, and if the complication occur, may have a very significant kind of morbidity, and even the extreme kind of a morbidity. So I am a surgeon. I would prefer to take a patient for under vision enteroscopy guided some kind of
No, what do you want to do? Enteroscopy?
operative.
Okay, enteroscopy guided. Okay, fine.
Enteroscopy guided.
So this patient actually, we did diagnostic lab, and then we found that there was a lesion in the proximal intestine, like you can see that. And this patient underwent a small bore resection. The final histopathology was angiodysplasia. Okay. So this is next case, 70 years gentleman, is a non-diabetic, hypertensive, smoker. He had some surgeries before. This guy had it's a very long history of intermittent melena this guy had, otherwise no other symptoms. He was evaluated elsewhere with many times he underwent ultrasound, endoscopy, upper GScopy, colonoscopy, and then multiple transfusions were there. So last evaluation was ultrasound was normal. Upper GScopy had grade B reflux esophagitis and mild gastritis. Colonoscopy had internal hemorrhoids grade 2. So he was treated conservatively and the symptoms subsided. But again, it's recurred after 3 months, and like this, he kept on having recurrent bleed. So this guy also underwent video capsule endoscopy. So, and the video capsule endoscopy was normal. So, but he is continuing to bleed. So, what is your next option, like Vinay?
Yeah, actually, as the patient's age is more than 70 years, so I think radiological imaging is a better investigation of choice to look after for some lesion which is having the recurrent bleed.
Yeah. So this is, of course, there is no point in going for any further endoscopy because video capsule endoscopy was normal because the yield is going to be less even if we do something else. So naturally, this patient underwent CT angiography with angio. So if you look at that, can you see something there?
Yeah.
So that is.
Could it be a submucosal lesion likely to be the gist?
Yeah, it's a submucosal. So it's a more of.
That's why video endoscopy is normal.
Yeah, the capsule endoscopy, video capsule endoscopy are normal. So this is. So that is a problem with video capsule endoscopy. You can miss actually the submucosal lesions. So this guy had an exophytic, well-defined soft tissue lesion, and it was probably a gist. And this is just what it looks. And naturally, this patient underwent diagnostic lab, and there was resection of this small bowel resection was done, and this was histopathology was given as a gist. Okay, and this is next 25-year gentleman who was pain upper abdomen and melena on and off since 2 years. He was a chronic ethanolic smoker, otherwise no comorbid, no past surgeries, and he was again evaluated extensively before requiring multiple transfusions. And 2 months back, he was evaluated. His hemoglobin was 7.3, ultrasound abdomen liver was normal. His pancreas was bulky with small fluid collection near tail of pancreas. And upper GScopy, he had small isolated gastric varices. Otherwise, there was no active bleed. Colonoscopy was normal. So, and by the time he came to us, he also had an endoscopic ultrasound, which showed that there is some peripancreatic collection near tail of the pancreas. It's about 3 centimeters, and it shows some gastric varices and perigastric collaterals, no aneurysm. And CT also was done, which was like GB sludge with some necrotic area near the tail of the pancreas and minimal fluid. But this guy, everything is normal. There was nothing obvious for the GI bleed, but this guy continues to have recurrent episodes of GI bleed. So, like, how do you proceed? Where do you like to see? But this ultrasound and CT had some amount of the pancreas issue is there in this patient. Yes.
Endoscopy does shows gastric varices, but when it was done during the episode of bleed or all, because that is one of the source. Recently, it is not there. That we have to see.
Yeah.
Second thing, especially in pancreatitis, pseudoaneurysms are common and it can be missed in imaging also. During the episode of bleed, if you repeat angiography, then it may give a clue because the significant bleeding, it has to be either from aneurysm or from gastric varices.
This guy also had angiogram done. That was also normal. So he was.
So sometimes timing is also important because sometimes during if the angiogram is done a little bit later, sometimes or the vessel goes into spasm. That is the time when it may not show the vessel.
Yeah.
But these two again repeating imaging as required based on the patient condition. We have to keep on close follow up.
Yeah, sometimes even your angio may not show when it's not actively bleeding. So that is very important to investigate this patient exact at the time of the bleed. But when he came to us, with this melanic stools, his hemoglobin 4 when he came to us. Then we transfused and post-transfused it was 8. Then at this time actually we again, this is the evaluation. And then we did endoscopy again. We thought, okay, this guy was bleeding at that time. We did endoscopy, then we found there were fundal varices that were not actually bleeding. And duodenum near that ampulla, we could see some blood staining was there. So what do you think this can be like with the previous history and all that?
So it's a case of hemosuccus pancreaticus only. Definitely blood is seen near the ampulla. So
Yeah.
so next step would be again a CT with CT angio.
Yeah,
towards
this,
the left
yeah,
side.
we did a CT with CT angio. So can you take Ashok, can you just see what it is? This CT with angio was done in this patient. Okay. So,
I like to see the papilla side wing endoscopy is confirmed whether it's
yeah, side wing endoscopy, there was nothing at the ampulla except for some small area of some blood staining was there. Even that was also not actively bleeding. So basically, we thought it may be hemosuccus pancreaticus with the background history of pancreatitis. So we did a CT scan, and this is CT is actually showing. If you look at the tail of the pancreas, there is a small collection there.
It's collection, but it's not look very
Yeah.
hyperdense kind of collection.
Yeah, that
If
is
it's
something
look
was there
like a
with some
hyperdense, I
hyperdense foci inside it was. Okay, and also like you can see the splenic vein was partially thrombosed if you look at splenic vein, and there are a lot of perigastric
very-
collaterals that was seen.
Definitely.
Yeah. So with this, probably we thought it may be a hemosuccus pancreaticus. Okay, with that, what the history, that background history, with all other imaging that was normal, the small ball, everything, video capsule endoscopy. So what will you do next, Dr. Vinay? Anything? For this patient, how do you treat this patient?
This is very difficult to take a decision for upfront surgery, think that this is the blood coming from the papilla and do the surgery, resect the pancreas. Even we can do if we all fail to diagnose and still we have on the more on the hemosuccus pancreaticus, then definitely we'll go for the surgery and the
Yeah, Dr.
treatment
Vinay,
for the
you want to say something on this? How do you go about this case? Like this guy has multiple bleeds.
Actually, in these kinds of situations, our IR people can help us. Rather than directly jumping on the surgery, we should at least consult those
So
IR people. Whether
what
they can,
IR procedures are you like?
might be some vessels or pseudoaneurysms which we are missing on even in these conventional cholangiograms. If they will picked up by doing that thing and they can embolize that thing, sometimes it used to be helpful.
What about left-sided portal hypertension? He has fundal varices.
Yeah, but it's not like directly for the every left-sided portal hypertension we are supposed to do the surgery.
So any intervention that can take care of both, Dr. Venu, you want to say something on this?
Yeah, depending if angio facility is available, definitely I would do angio again and do some part of super selective catheterization and then see for source of bleed. If it's not there, then some people do blind embolization of splenic artery also, but because the source probably is that because there's some enhancement there. Or surgery is one of the option because that can tackle because it's symptomatic for pseudocyst and varices.
Yeah.
Surgery is.
So you have to be very calculative. You just look for your patient fitness, whether you can
Yeah.
achieve, you can have a feasibility of the surgery with a all good outcome. And if you justify yourself, I think you can go for
No, this guy had hemosuccus pancreatitis with the cerebral portal hypertension. So we thought we'll go ahead with surgery with a long history this guy had. So we went and did distal pancreatectomy. Once we went inside, we opened the pseudocyst. There were a lot of clots in that. And even we found that there was communication with the main pancreatic duct. Okay. So I think it was, we did distal pancreatic splenectomy was done for this patient. And he's okay after that. And I'll go to the next case. This is a 50-year old gentleman. It's a diabetic, ethanolic. He presented with history of hematochezia since of 2 days duration with a mild abdominal distension and right upper abdominal pain. Otherwise, no jaundice, clinically no jaundice, no fever. This guy, if you look at the history, he had lab converted to open cholecystectomy with a drain placed, and post of day 1, there was a bile leak. They found 300 ml of bile that was coming. And obviously, this patient was sent for ERCP. They did stenting. When they did, there was a contrast leak from cystic duct stump and a stent was placed. And following ERCP, I mean, it was this thing, and it stopped, and they removed the drain. Now this guy has come to us with a severe bleed, like hematochezia he had, and the pulse was like he has tachycardia, blood pressure was on the lower side, and he had severe pallor. Up down there was a mild tenderness in the epigastrium and right epichondrium. So, Dr. Venu, what do you think you have to suspect in these patients now?
Following laparoscopic cholecystectomy and then now J bleed, we have to think about any hepatic artery injury and causing aneurysms, and hemophilia is one of the suspicion. So, but this patient should follow the regular course. He should be resuscitated and then do an endoscopy.
Yeah.
And
So, do you want to do endoscopy for this patient?
yeah, as part of this one, because,
Yeah,
if the patient is stable.
Yeah.
Yeah.
But
Protein
if you look at his counts of 34,000, then his LFT was altered. It's something like 2.8, then his alkaline fall was 331. Okay. So this ultrasound showed some irregular collections. So definitely we thought it is probably something like a hemophilia. Okay, following cholecystectomy, that is what we were in our mind. So we researched this patient, and this hemophilia is like we expect more common in following these pseudoaneurysms after the cholecystectomy. So what is the ideal investigation that you would prefer now in this patient?
Yeah, CT scan would have been an ideal non-invasive investigation. Then it will show whether any aneurysm is there. It also gives information about the collections and post-biliary complications. So
Yeah.
a good investigation.
So we didn't do any scopies in this patient. Then when we did CT, we found that there were a lot of collections, intraperitoneal, and there was a pseudoaneurysm in the right hepatic artery. If you look at, there was small pseudoaneurysm that was bleeding, and the treatment option is like embolization naturally. So we went ahead and did this. Is embolization was done for this patient.
Definitely in the background of the bile duct injury, and if the surgeon or somebody has given the history of blood loss during the surgery, hypotension, blood transfusion, I always have a suspicion of that kind of the injury, pseudoaneurysm. And best thing to initially to go for the CT angiography, and second, I think DSA and intervention required in form of gel foam or a stenting, anything kind of.
So just to rush through this, I'll just read myself. This is a hematochezia, hematemesis. This guy had ultrasound of cholelithiasis, multiple gastric erosions. This was upper GScopy was done before coming to us. Then this guy continues to bleed. His hemoglobin was 6.6 when he came. Otherwise, other investigations were normal. So naturally, this guy was actively bleeding, and upper GScopy was normal with hematochezia. We went ahead and did CT angio, and CT angio showed actually there was a lesion in the duodenum, which was I mean it couldn't be picked up on upper GScopy, but there was a lesion in the second part of the duodenum with a gastroduodenal artery that was supplying, and this is angio. It showed that there was a lesion in the second part of the duodenum with active bleed that was there, and this was embolization was done for this patient. Okay, and retrospectively, then we saw like there is obviously CT was showing something in the second part of the duodenum. Then we went ahead and then when we did endoscopy, then we found out that there was a lesion. So this is probably there was some bleed during that time when he did a upper GI endoscopy, and this lesion was missed. And even that is the reason why we went ahead directly with the CT angio, and then we found that there was a lesion in the duodenum. When we did endoscopy, then we found that there was a lesion like this. It was CT was more suggestive, more like a gist. And then we did something like initially we planned for Whipple's, but then we on table we did because in the lateral wall of the duodenum a local resection was done, and the biopsy came as gist. Okay, this is basically some algorithm on that. It's a massive what this CT angio. You can go ahead with obstruction. If there is subacute and intermittent obstruction, it is CT angiography. If there is no obstruction, it is a video capsule endoscopy and then enteroscopy. And sometimes in 5 to 10% of the cases, even after all this, the bleeding still remains to be obscure, and you need to decide whether to further investigate these patients or not. And it depends on whether the patient is elderly, comorbidly ill, then slow bleeding. So in these cases, we can stop evaluation. We can just treat with the replacement of blood and iron. And young patients, we may need to go for intraoperative enteroscopy. And I think this is my last slide. Okay, anything, panelists, anything you want to say, anything, or any questions, anything?
So it was a very nice case discussion, and we have discussed all type of cases that can be come as a obscure GI bleed. So I like to add one or 2 points that means decision of repeat upper GI endoscopy and colonoscopy should be taken at the time when patient comes with GI bleed, and it depends how adequate the previous investigation was. And second, the bleed can be intermittent, and patient might have not having bleeding at the time of previous investigation. So patient may need repeat upper GI endoscopy or colonoscopy if we suspect that patient bleed intermittently, and lesion might be missed if there was no bleeding at the time of investigation.
So these vascular lesions can have intermittent bleeding and they may stop by their own. Sometimes that is also one thing we should keep in mind. And recurrent bleeding, as I said, we can stop evaluation after if slow bleeding and just there's no overt bleeding. We can, especially elderly, we can stop and continue on follow-up. And sometimes really these patients are associated with coagulation defects also. So sometimes we try everything, but we don't find anything. So we have to keep the hematologist in pursuit also to identify any underlying coagulation disorders also.
Any questions from the floor? Anything? Okay. If there are no questions, I think we'll conclude the session. Thank you all the panelists. Thank you everyone.
The next session is today's last session, and it is on the panel discussion on ACS, abdominal compartment syndrome. And for this, I would like to welcome Dr. Mahesh Thomre from Pune. And on the panel, I'd like to welcome Dr. Sharvari Pujari from Mumbai, Dr. Saurabh Galoda from Delhi, Dr. Kailash Kurdia from Delhi, and Dr. Nikhil Gupta from Delhi.
Good afternoon. There is some change in the panel. So I will call Dr. P.D. Yadav, Dr. Harjit Singh, Dr. Kailash Kurdia, and Dr. Nikhil Gupta. Please be on the dais. There is World Society on Abdominal Compartment Syndrome, or WSACS, and it has defined abdominal compartment syndrome in which two or more anatomic compartments of the abdomen have pressure more than 20 millimeters of mercury, with or without abdominal perfusion pressure, which is less than 60 millimeters of mercury, and most important is it is associated with organ dysfunction or failure. What is the importance of abdominal compartment syndrome? That you have to always suspect it, and if it is untreated, it can be fatal. Physical examination is not really sensitive. There are no reliable biomarkers. The only marker is failing renal function test renal function in a patient who is adequately resuscitated, and you have to sensitize the probably ICU persons, even the surgeons and physicians, to know the risk factor and its associated treatment. The normal abdominal pressure is 5 to 7 millimeters of mercury, and it is called intra-abdominal hypertension when the pressure is more than 12 and less than 20 millimeters of mercury. Now, the best way is to always keep suspecting in a patient who is prone for developing abdominal compartment syndrome. So, any patient who is admitted in, critically in ICU can be a potential patient of abdominal compartment syndrome. Clinically, the patient's abdomen is distended, is tense, and there is also associated on clinical as well as metabolic instability. Now, we normally see abdominal compartment syndrome in patients who undergoes liver transplantation or following damage control surgery after trauma, patients after abdominal aortic aneurysms, or patients who have got large abdominal hernia, or it can be classified in various ways: primary abdominal compartment syndrome or secondary syndromes, depending on the organ of pathology which has caused the syndrome. It can be abdominal pressure can be chronically elevated in patients who have got cirrhosis or obese, or they have got intra-abdominal malignancy, patients undergoing dialysis. Now, higher the body mass index, higher is the baseline abdominal pressure, almost to the tune of 9 to 14 millimeters of mercury, due to the restrictive effect of adipose tissue. The independent risk factors for abdominal compartment syndrome is massive transfusion, usually more than 10 red blood cell transfusions within a short span of 24 hours. Patients who are obese with BMI more than 30, those who have got hypothermia, acidosis, and have been infused with 5000 ml of crystalloids in 24 hours. Now, it can be primary, secondary, or tertiary. Tertiary means after you are treated, again there is recurrence, or it can be classified as acute, chronic, and recurrent. Now, this is the case to the panelists: 57-year-old male who has come with complaints of epigastric pain, upper back pain, which is severe in nature, also vomiting of last 3 days duration. His pulse is 104, BP is 104/64, respiratory rate is 24. Abdomen is distended, there is tenderness all over the abdomen. Working diagnosis is acute pancreatitis. Patient has been admitted directly to the ICU. His WBC count is 18,000, CRP is elevated, amylase and lipase are also elevated more than 3 times the normal. Urea is 65, creatine is 1.4. He has been kept NBM because there is ileus. He has been given IV fluids, and initially in the first 24 hours, he required around 6.8 liters of crystalloid. He has a urine output of 1200 ml at the end of 24 hours. His CVP, which was initially 6 centimeters, has gone to 8. When within the first 24 to 48 hours, this patient appeared to be improving, but on day 3, he has a drop in urine output, which is to the tune of 10 to 15 ml per hour. He has tachycardia, hypotension, tachypnea, CVP is 13 centimeter. Abdomen is still distended. His counts are gone up, CRP has also gone up. There is no change in creatinine. So my first question to the panelist is, what is your suspicion in this patient of acute pancreatitis who is deteriorating on day 3?
So I would like to answer with that. Then my junior colleagues will be giving their opinion. Though this, Dr. Mahesh, this thing was happening earlier when we were very aggressively resuscitating acute patients of acute severe pancreatitis, and the moment patient comes, the fluid which was we are supposed to give 5 to 6 liters of fluid in 24 hours, and then this is what we are talking about in the first week of the admission of acute severe pancreatitis. So what happened that we did one thesis also on acute pancreatitis. What happened that when you are resuscitating patient over enthusiastically, and now there is a change, very sudden change, and now recommended fluid is more than half of the earlier recommendation, and it is said that the optimum fluid level has to be maintained, meaning thereby you have to maintain the CBP, you have to maintain the urine output, and see that by doing intraoperative bedside ultrasound, seeing the IVC diameter, you should not be resuscitating more aggressively.
Dr. Adav will come to how to treat this, but what you suspect?
So I am saying what is suspicion is because of the same thing. The suspicion is because this patient has, within 3 days, after initial improvement, the first thing to go is urine output decrease, blood pressure has decreased, and there is a tachycardia has increased.
So you agree with my the title of the topic, you are suspecting abdominal compartment syndrome.
As I said, we have already published in acute severe pancreatitis since our volume is very high. So we suspect at this stage and try every patient of us in liver trauma as well as in acute pancreatitis. When all other things are going in a normal way and suddenly we find this type thing, we immediately, our agent will go and we start monitoring this intra-abdominal pressure. Because that may be one of the factors for the emergency, which is neglected, which is usually neglected in our armamentarium of the surgical management.
And Dr. Kailash, you agree? Okay. Anyone who is having different suspicion?
Hello. Yes, sir. So, if a acute pancreatitis patient in first week of illness having some rapidly deterioration even after adequate resuscitation, then we always suspect there may be increased intra-abdominal pressure, and we look for that.
Okay. So what are the pointers to raise intra-abdominal pressure in a given patient who is in ICU? Dr. Nikhil?
So one is the clinical parameter. As we said, the patient had a fall in BP. There is a fall in urine output patient can have. Despite having the adequate CVP, patient has low urine output. Second, on examination, you can have a distended abdomen. And if you suspect, then measure the intravesical pressure. If the intravesical pressure is high, then these all raise the suspicion of abdominal compartment syndrome.
So this patient, normally we don't do CT scan usually in the first 7 days of the diagnosis of acute pancreatitis, unless your diagnosis is in question. But this patient did had CT scan, and you have a look at the CT scan and tell me what are the indicators in this CT scan which probably indicate that this patient is having acute compartment syndrome.
So I think what we can see is there is a massive ascites. There is a lot of fluid in the abdomen. We can see some bowel thickening, and a pointer is showing the compressed IVC, and there is a herniation which is spouting out of the. I think these all are indicator that there is an increase in intra-abdominal pressure.
So though it is not a very classical way of investigating or diagnosing intra-abdominal pressure, if there is a CT scan, it can shows or indirectly suggest you that this patient might be having abdominal compartment syndrome. The first thing is showing jejunal thickening. The second picture in the top layer shows a slit-like IVC. The second row, that is lower row, it shows that patient has diastasis and that the linear elbow is also being pushed forward. Then this patient is incidentally also having hernia, and that is fluid filled. And the sagittal section does show there is also downward displacement of pelvic diaphragm. So all these are indicators that there is increased intra-abdominal pressure which is trying to get a space by pushing its boundaries. So what is the gold standard for measuring intra-abdominal pressure and then obviously classifying it as hypertension or a syndrome? So what is the, how do you measure the intra-abdominal pressure?
Sir,
yeah.
Actually,
we can't say there's a gold standard to measuring intra-abdominal pressure, but we have various bedside maneuvers which we usually perform. Most commonly, what we do is using a Foley's catheter instilled into the urinary bladder, and then we use a manometer and see what is the pressure inside the bladder. So that's an indirect measurement of an intra-abdominal pressure and not a direct measurement. And then we have other maneuvers also. But the most commonly that is employed is this only.
Because it can be done bedside and very simple. Most of these patients will have Foley's catheter in situ for urinary monitoring. And I think position is equally important. The patient has to be completely in horizontal position, supine position, and not in propped up position. So the position of the patient is equally important. And it should be end expiratory pressure, and it should be a steady state pressure. In the sense, you have to take repeated measurements also, maybe every 4 to 6 hourly in a patient in which you suspect.
Yes, but it's more or less a rough gauge of what exact intra-abdominal pressure.
Because the other methods are a bit complicated, we'll come to that afterwards. Are there any contraindications to measure intravesical pressure, or the conditions where you have measured it but it is not reliable?
Any pelvic pathology will actually kind of preclude measuring intra-abdominal pressure through the Foley's. So any pelvic tumor, obviously, it will preclude or it will not give you the right measurement per se. So any fractures, hematoma, or whatever you're suspecting, if you're suspecting a pelvic pathology, obviously this will be a wrong way of measuring intra-abdominal pressure, and we have to rely on other methods.
So, Dr. Kailash, what are the other alternatives to measure intra-abdominal pressure?
We can use the measure the intragastric pressure by using Riles tube, or maybe IVC diameter C by ultrasound. And sometimes if the patient, post-operative patient, if have drain, then may also use these things to measure the pressure.
So, in acute pancreatitis patients, these are the 4 categories by which these patients, they have abdominal compartment syndrome. That is, they have diminished abdominal wall compliance, they have got increased intra-abdominal volume, there is also increased extraluminal abdominal volume, and there is capillary leak because of probably excess use of resuscitation or resuscitating fluids, mainly crystalloids. Now, what is the importance? Why do you measure abdominal pressure? What is its importance? Of course, in patients with suspected acute pancreatitis.
It is important because it is it's required for a prognostication. If you can diagnose this problem early, you can manage it early, and the outcome is better.
So the importance is basically this patient. There is first thing is an ICU patients. Even if you take overall ICU admissions, the incidence of increased abdominal pressure is quite high. Of course, only few of them will have really compartment syndrome, and it is associated with increased mortality, as also associated with increased morbidity, and the treatment of which is also having high morbidity. Now, the incidence of compartment syndrome in severe acute pancreatitis is to the tune of 30%. The mortality is up to 50 to 75%. Now, how you grade intra-abdominal pressures or intra-abdominal hypertension? There is a classification by World Society of ACS that has classified intra-abdominal hypertension into 4 grades. Can you please tell us what are those 4 grades?
As you already mentioned, up to 5 to 7 millimeter mercury is the normal, and in some obese patient maybe up to 10 is the normal. But grade 1 intra-abdominal hypertension is 12 to 15 millimeter of mercury, and grade 2 is 16 to 20, and grade 3 is more than 21 to 25, and grade 4 is more than 25 millimeter of mercury. So these are the grading of intra-abdominal hypertension. And abdominal compartment syndrome, we say if the pressure is more than 20 associated with the new onset of organ failure, worsening of organ failure, then that is the abdominal compartment syndrome.
Now, there is also a concept of intra-abdominal perfusion pressure. So, what is this importance and how it is arrived at? Dr. Nikhil?
So the problem with actually the problem of abdominal compartment syndrome is the lack of perfusion of all the organs in the abdomen because of raised intra-abdominal pressure. So the abdominal perfusion pressure that we're talking about is the mean arterial pressure and then subtracting the intra-abdominal pressure from it. We usually have to keep it more than 60 so that all the organs are getting adequately perfused. If that intra-abdominal pressure rises, obviously the abdominal perfusion pressure will fall. And that means that there is less perfusion of the end organs, and that will lead to organ injury and eventually lead to multi-organ dysfunction syndrome. So that's why we have to measure it, basically.
So, this abdominal compartment syndrome will affect almost all important system, the pulmonary system, cardiovascular system, GI system, even it can affect the brain. Now, this slide shows what are the effects and the way the effects happen. So, Dr. Harjeet, can you tell what are the end results of abdominal compartment syndrome on these various systems?
So, like in the pulmonary system, it can cause the hypoxia, and if there is a compromise in the renal system, that can patient can have a decreased urine output. Or in GI system, if there will be an intra-abdominal hypertension, that can cause maybe a splanchnic compromise in the blood flow, which ultimately may lead to a bowel ischemia or maybe a translocation or bacteremia. And even in CNS, it has been reported that there is an increased ICP raised.
So, are there any real biomarkers?
So just Dr. Mahesh, just
Yeah.
before proceeding to that, lots of our younger generation are sitting. So apart from all the theory system of enumerating all the organs, the most important and preventable at that particular stage is the kidney function test. Deteriorating kidney function test, which will be first in the decreasing urine output, and then you exclude other causes. Then in presence of the clinical parameter of over-distended abdomen, tense abdomen, then one must suspect. And you take care that time, then multiple things which are going to ischemia, intestinal ischemia, all those things can be prevented. So I think for the message is most important is kidney, and first organ which is affected is kidney. So we should keep an eye on the kidney and then proceed further.
Are there any biomarkers, like some special test to know that this patient will go into compartment syndrome? People have does evaluated CD4 T lymphocytes on day 137 and found they are significantly lower in compartment syndrome and in patients with plain intra-abdominal hypertension. But none of these is very widely used. Now they are being very much validated, and there are no real biomarkers. I think the suspicion is most important. Now, the next question is obviously your diagnosed compartment syndrome. How will you manage it? So, Dr. Nikhil, how will you manage it?
He's Saurabh.
Oh, sorry.
Okay, sir. The primary is usually conservative. We have to avoid over aggressive resuscitation that we usually follow in these patients. So that is one. So you have to have a goal-directed therapy in these patients. That is the fluid resuscitation has to be balanced with what are the input-output monitoring. So that is your conservative manage initially, because you can't suddenly jump into an intervention for all these patients. So you can see that majority of these patients will initially can respond to your conservative management, adequate monitoring, proper ICU support, because the primary presentation of these patients will be that pulmonary, where actually it requires oxygen support, renal, which usually if you change your resuscitation management, you can help with that. So initial will be conservative. We have to focus on what you already told is the abdominal perfusion pressure. And if nothing helps, then only we go for an intervention which can be percutaneous if there are collections. Like after we done an imaging and you showed there is so much of fluid, so we can actually initially drain this fluid. So we can go for drainage, which will reduce the intra-abdominal pressure. and then take a stepwise approach, as we already profess that a step-up approach is the best approach in a patient of acute pancreatitis. If nothing helps, then only we can go for a surgical intervention.
So I will come to some specific questions related to acute pancreatitis. So we have covered this where resuscitation, after resuscitation phase should be optimistic and just adequate and not continue the aggressive resuscitation beyond the 48 hours or when the endpoints are achieved. And nutrition, this point obviously everyone knows the enteral is better than parenteral, but in sometimes in patients with acute compartment syndrome, there comes a time when decompression is required, and then you might have to stop the enteral nutrition and probably give the patient a total parenteral nutrition. Antibiotics again not routinely advocated in the initial management of acute pancreatitis, but if there is a diagnosis of acute compartment syndrome or this patient is undergoing percutaneous drainage, probably these are the patients which need antibiotics because compartment syndrome is known to demonstrate transmigration of bacteria and sepsis. So you need to take care of that. Some people do advocate routine use of acute fluid collections. Now, what is your opinion, the panel, whether you will, even if there is no compartment syndrome or only hypertension is there and you need to whether drain these acute fluid collections? I think the medical gastroenterologists are much in preference for draining this fluid collection even before the pseudocystis form. What is the panelist opinion?
So if there is no development of compartment syndrome, just only grade 1 or grade 2 abdominal hypertension, then we should wait and manage conservatively like goal directed fluid therapy, good pain relief, because this is the there are multiple pathophysiology involvement. Patient, because of pain, patient have decreased abdominal compliance, so it also lead the increase the abdominal pressure. So we give good analgesics, adequate fluid resuscitation, all these things.
So these are the five principles, and these are called Hecker's 5 columns. These are the basically to decrease the abdominal pressure. So one is evacuate the luminal contents. Another is evacuate the abdominal contents. Then improve the abdominal wall compliance. Then have optimal fluid management and have optimal tissue perfusion. So who will evacuate luminal contents? Any one of the panelists, Doctors Kailash?
We will use the nasogastric tube for decompression, and sometimes if there is colonic dilatation, so then we can also use the flattest tube, and sometimes an endoscopic decompression of the colon.
Yes. Also, sometimes people have used prokinetics and also neostigmine in patients with colonic ileus, but obviously patient is in ICU setting, so using neostigmine is not much of a problem. And sometimes you have to induce diuresis. So what is the choice of drug for diuresis? Yeah, Dr. Harjit.
We can use furosemide.
Yeah, it has been shown that furosemide also decreases intestinal wall edema, and you have to use in adequate dosage so as to the diuresis is induced in these patients. Now, to evacuate the abdominal contents, either you can use percutaneous drain or you do surgical drainage. Now, how you can improve abdominal wall compliance in these patients? Dr. T.D. Yadav?
So, our experience in acute pancreatitis is that only if you drain only fluid, and usually there is no much effect on the abdominal compartment pressure because there is lots of intestinal edema. The edema in the bowel is the one of the very responsible factors for the increased pressure in abdomen. And there have been reports that if you put a multiple 3-4 drains, there may be little bit of difference in the abdominal pressure, but usually not a significant difference. Then comes the surgery, and surgical part is very controversial. But usually it is that you do a laparostomy, open the abdomen, and all these small things don't work at all. to open the abdomen, and then we in PGI used to use Bogota. So rarely you have been forced to do that, but you used to Bogota so that you give you a total compliance to the abdominal contents, and then other parameters what we discussed in the beginning, and this is what if at all it works, it is the only thing which works especially in acute severe pancreatitis.
Dr. Harjit, when you decide that this patient now needs surgery and medical treatment is now on the background?
So I think we should plan laparoscopy, means a big incision from epigastrium to pubic symphysis. And
No, when you will decide that's the enough of medical treatment and now needs surgery.
when it should be a last resort, because when all our conservative Meyer failed, we tried everything. We did a decompression. We optimize the fluid resuscitation, and even if there is ascites, we drain that ascites, and still there is a organ dysfunction or there is a deterioration in patient, then we can plan surgical intervention.
I want to add one thing. There is a study shown कि if there is you put the PCD and even after 1 liter of drainage of fluid, patient pressure does not fall 9 mm of Hg, then we should go early for surgery in these patients. Otherwise, these patients not benefit.
Yes, obviously when everything fails or when at the beginning initial only the pressure is very high and this patient has got progressive organ dysfunction. So there is no time for trying those non-surgical methods in one patient, then you can straightway also can go to surgery. But the most important here is you have to correct the coagulopathy these patients have, because occasionally after the reperfusion syndrome, this patient can have spontaneous onset of hemorrhage and hemorrhagic shock, and that is most important. So you keep this in mind that you have to correct coagulopathy in these patients. Now surgery, obviously you do emergency laparotomy, and there is also something called as reperfusion syndrome. So please explain what is reperfusion syndrome and whether you can avoid this reperfusion syndrome and what is the etiology.
So reperfusion syndrome is that once you release the compartment, there is a increased perfusion, suddenly increased perfusion. It leads to multiple biochemical changes, and these leads to the kidney injury and its a side effect.
So it's basically perfusion or reabsorption of the metabolites of anaerobic metabolism, and you can probably avoid this by preloading the patient with IV fluids. Now, when you do surgery, it has to be incision from zipisternum to pubic symphysis, and one has to assess the viability of the intestines. If there is a source of bleeding, control the source, evacuate any fluid collections and septic complications, and minimum is to obtain swabs for bacterial or fungal culture. So this is the minimum that one can do. If there is obviously ischemic bowel, you need to resect it. You might have to do ileostomy in these patients. Now you have done laparotomy, you have evacuated the fluid collections and done actions. So how you close this abdomen? Because you will find it difficult to close, and doing it under tension will defeat the whole purpose of it. So Dr. Harjit, tell me how you will close this abdomen. One, Dr. TD has already told the Bogota, which is available to probably each and every surgeon, because every hospital has got sterile Eurosacs available to them. So other methods?
So yeah, what we do routinely is a Bogota closure, but there are other methods, like there are vac dressing available like Apthra, which can be used, but definitely they are associated with the high cost.
So basically, it is contemplation. You are taking the patient, and if the patient needs Apthera, you need to probably call that Apthera in the OT beforehand, because probably on the spot you won't have negative pressure, though there is Indian methods or Jugaad methods by which you can do this. So this is Bogota, which is applied to the wound, and there is also special equipments like Whitman's patch and other things. Here you can have your own imagination The Whitman's patch is basically a Velcro patch with hooks and loops. So every time you open, you might also progressively tighten it so as to prevent the facial migration laterally, so as to have proper healing of this patient and prevent hernias. Now this is abdominal zipper that probably everyone has used in the past, but the problem is again suturing. It is not waterproof or leak proof, and you need to close it and really don't know whether it lasts. If it only anchored properly to the abdominal musculature, then only it is going to act. Now another is upsides, which is very common. You can also use absorbable mesh, that is Vicryl, or a PTFE patch. This is another good cover for the abdomen because it is non-sticky, but it is very costly. Initially, it used to come into 15 by 50 centimeter patch, but for a laparotomy of this, you probably require 2 to 3. And the advantage is there are no adhesions because Aptera, when you use, you need to change it every 72 hours to prevent the granulation tissue ingrowth and so as to be able to remove that polyurethane foam and redo it. Now, again, this is the follow-up action. You are done. The patient has you have given temporary closure, but also you need to see these patients in the ICU. So, what are the follow-up methods so as to keep the pressure low in the abdominal cavity? Yes.
So, Dr. Mahesh, I think you summarize because we have already crossed. So you can summarize the slide and then close this thing. No?
Okay. So, when you achieve temporary abdominal closure with the abdominal fascia, the closure rate reaches up to 72%. If you use VAC, that increases this closure rate to 90%. If you are at the end of 5 to 7 days not being able to close the abdomen, then you will have to use a mesh, probably the absorbable mesh with skin graft over the granulation tissue. But the problem for this patient is not over. This is not the time for complications, because if the complications are going to occur, they probably occur at the end of 3 to 4 weeks. So probably you also need to go again into the abdomen for these patients. And you don't hurry up the final closure, because it has been seen if you try to hurry the closure, say at the end of 4 months, then these patients do have recurrence of abdominal compartment syndromes. So let at least 6 to 12 months pass by from the last operation. After then you take a call. That time you might require a final closure with the help of abdominal wall reconstruction. And this is the last slide, which shows the multiple series. So usually when the time to intervention is in most of the series is usually the first week of presentation of acute pancreatitis, and with a high mortality which is up to 75%, which is being shown. Rest of the other parameters I won't discuss here. I have not discussed other conditions because it can occur in other conditions, but I won't talk about this. But here the numerator can be anything. It could be acute pancreatitis, or it could be trauma, it could be hemorrhage, it could be ulcerative colitis, it could be perforation, septicemia. But the denominator is increased abdominal pressure. So most of the conditions, the treatment remains the same. The only component which will change is probably the need for surgery and the type of the surgery which is required for that particular condition. So the medical component usually remains the same. So the denominator is almost same for abdominal compartment syndrome from any etiology. So thank you. I thank my panelists for giving me answers. I also thank iasgcon organizing committee for giving me opportunity to be in front of you. Thank you. Thank you very much.
brings us to the end of the program. Next, we'll have prize distribution soon. And there's an announcement that the bags will be available on the ground floor after the valedictory function. So you can collect them from the registration counter after the function.
Hello.
I request all of you to take your seats. Very shortly, we'll start with validity function. Within 5 minutes, we'll start with our closing ceremony, validity function. I request everybody to take their seats. I request all the company people to be seated.
We are soon going to begin with the valedictory function, and I would like to call upon the stage Dr. Subhash Gupta, President, iasgcon, Dr. T.D. Yadav, President-elect, Dr. Rajneesh, Secretary, Dr. C. Khandelwal, Organizing Chairman, and Dr. Manish Mandal, Organizing Secretary.
We come to the conclusion of a very successful and very beneficial annual conference of iasgcon 2024. And I'm really grateful to one, of course, the people who came from all over the country, spared their time for learning, for teaching, and two, and more importantly, and most importantly, to Dr. Manish Mandal and his team of really excellent people. I think they deserve a round of applause. To be honest, Manish, we have shared this thought with you earlier. We didn't expect that you would do such a brilliant job. We know that you do a good job, but this is actually excellent. I haven't seen a conference till date, and this is a very small experience, a very small life, which hasn't fallen short on one or other account. Either the video fails or the audio drops or some hall has some light shortening or something. I think you guys were brilliant in managing the halls. Your audiovisual team was excellent. And of course, you as a leader have done a fantastic job. Thank you so much. And of course, acknowledge the overbearing presence of Dr. Khandelwal, who's really been a father figure to your team. And actually, I'm sure that the light has been shown by him and his experience in this society as to how things are to be done. So again, acknowledge the presence of Dr. Khandelwal and his experience in guiding this team. Thank you so much. At this point in time, we have got some awards to distribute. May I request Dr. Pradeep Rabela to kindly announce, as the convener of the scientific committee, to kindly announce the first three award medallions.
This year, we have received more than 250 abstracts for evaluation, and I should thank all the people who have submitted the abstracts, and also all the reviewers with a short span of time were able to review these and select these abstracts. So the first category is the award oral presentations, podium presentations. It goes to Dr. Advait Deb from KGMU Lucknow. So the award consists of rupees 10,000, a medallion, and a certificate of appreciation.
Is he here? Or anybody from his team would like to collect? Yeah, please.
Congratulations, Advait. So in the meantime, I request the President to award the medal and the medallion. The next category is the special mention poster. Dr. Sanjam Singh, AIMS Jodhpur. So the award consists of rupees 7,500, the medallion and the certificate of appreciation. Dr. Sanjam Singh, please. Sanjam Singh, yeah. So I request the President-elect, Professor T.D. Yadav. The next category is the award video. Dr. Ramesh Natarajan from JAM, Coimbatore. Is Dr. Ramesh there? Anybody from JAM? Is it Ramesh Natarajan? Okay, on behalf of Ramesh, I think the secretary, Rajneesh, or Dr. Kandelwal, Dr. Kandelwal to hand over the check for rupees 6,000 and the medallion on behalf of Ramesh Natarajan to the colleague. Now the next category is free poster. Free oral presentation. We'll read out the names and you can collect the certificates from the organizing committee. So for the esophagus category is Meet Desai from Medanta, Gurgaon. From the stomach, Niaz Ahmad from Madurai Medical College. In the category of liver, Santosh Kumar DP from Seth GS Medical College. And the biliary category, Makrand Lahange from IGMS Patna. And in the colorectal category, Alok Pandey from Indraprastha Apollo Hospital. Small bowel, Pradeep MS from SGPJ Lucknow. And from pancreas, Kripa Tiwari from Medanta, Gurgaon. And from oral video podium presentation, the awardees were from the esophagus categories Ravi Babu Murugesan from Madurai Medical College. And in the stomach category, Heman Yes from Madurai Medical College. And the biliary category, Amit Mohanty from IGIMS. And the liver category, Ankit Anand from Jipmar. The pancreas, Kush Parekh from SGPGI. Colorectal, Utkarsh Anand from PGIMR Chandigarh. And small bowel, Ravi Voleti from Meenakshi Mission Hospital. I think you can collect your certificates from the organizing committee. And coming to the e-videos and e-posters, I think the results will be put up on the website, IASG website, and you can collect your certificates from the organizing committee, or you can download the certificates from all the e-videos and posters. Thank you.
Thank you so much, sir. We conclude a very successful iasgcon. Can I request Dr. Subhash, sir? Sorry. Okay. To give its concluding remarks.
I think we've had a wonderful meeting. The venue has been excellent. Scientific content, very, very appealing. And I hope our next meeting in Chennai be even better. And as I take on the presidentship of this vibrant society, of which, in fact, I don't recall being so old now. I think still remember my days with Dr. Piyush Sani in All India Institute of Surgical Gastroenterology. I think so much time has passed. But I think there is I was talking to a lot of people, and I think there's some changes we need to introduce. And I think there was a good suggestion that we should have a vanguard section. The younger people, their work can be recognized and they can be part of multi-center studies. And I think we proposed in the last meeting where we were in Delhi, not the gastroenterologist, Dr. Rajneesh Singh was there, and we were thinking of forming a chapter. We thought we'll not call it a registry. We'll not registry, not a, so that we can common conditions from different centers can be put together, and so that we can have a joint publication out of it. And I was also hoping that some of the money, which is enormous money, amount of money which is lying with the society, could be used to allow students, residents and fellows to go abroad or for a fellowship training or something, rather than allowing that money to just lie there. And so these are the things that I have in mind, and I hope I'm able to carry out some of these things in the year that I have. Thank you.
Thank you, sir. And may I request Professor Khandelwal and then Dr. Manish to conclude the.
Actually, whole credit goes to Dr. Manish and colleagues from IGMS, but being the senior person of ISG, I am the organizing chairman. And I remember the days when the ISG was formed. I was the founder member in Banaras in 1988. And thereafter, once earlier we had held this iasgcon in Patna in 2000. Hardly 200 delegates were there. But today it is sea-level change. This time it is certainly different, and the best thing, everyone appreciating, those who know me for many years, they just come to tell me a wonderful experience. So it is not me, it is you who is saying, and that gives us full satisfaction that the effort of me and my colleagues for months, and in fact for almost 2 years, at least 1 year full time, so many discussions, we are now satisfied that our result, our effort have been appreciated, and that gives us very much satisfaction. And now I request Dr. Manish, Professor Manish, to come, and thank you for coming here in large number from all part of the country, and good deliberation, timely punctuality was maintained. Everything, in fact, all parameters, this conference seems to me, as I told you earlier, I have been attending so many iasgcon, as told by Dr. Rajneesh Singh also. This is one of the good experience, not because I am here, I am telling on basis of my experience of so many years. Thank you everyone for participating and allowing us to organize this meeting.
मंच पे बैठे हम सबके प्रिय डॉक्टर सुभाष गुप्ता सर, मंच पे बैठे हमारे बड़े भाई और सरकारी तंत्र में बहुत अच्छे शिक्षक और प्रशिक्षक डॉक्टर टी.डी. यादव, मंच पे बैठे डॉक्टर रजनीश कुमार सिंह, जो SGPGI नहीं पूरे बिहार को एक नई दिशा और देश को नई दिशा दिए इस कॉन्फ्रेंस के माध्यम से, और ऐसे भी IASG की तरफ से। मंच पे बैठे हमारे अभिभावक डॉक्टर प्रोफेसर खंडेलवाल सर, मैं सबसे पहले इन लोग का धन्यवाद देता हूं कि मुझे मौका दिया इस क्षण को जीने का, इस गौरवमय इतिहास को बनाने का, जो आज IASGCon में हम लोगों ने किया। मुझे दिल से खुशी हुई जब ये कोलकाता में 2022 में बिहार को ये दिया गया सौभाग्य कि IASGCon 34वां हम यहाँ कर सके, और तब से अब तक हर पल मैं और मेरी पूरी टीम, डॉक्टर साकेत, डॉक्टर राकेश, डॉक्टर संजय, डॉक्टर अमरजीत और मेरे जितने भी MCA स्टूडेंट्स हैं, दिन रात हम लोगों ने प्लानिंग की और मेटिकुलसली छोटी छोटी चीज़ों को और बड़ी चीज़ों को सबको देखा। और हम लोग जितने भी कॉन्फ्रेंस में गए, पहले तो हम लोगों ने उसको कोशिश की, उसको नोट डाउन करके हमें प्रॉब्लम क्या क्या आया, एयरपोर्ट से निकलने तक और एयरपोर्ट पहुंचने तक और वेन्यू से पहुंचने तक जो भी कठिनाइयां आई, हम लोग खुद को उसको मैंने पहले नोट डाउन किया, और उसमें कोई व्यवधान ना आए इसकी पूरी कोशिश की हमारी टीम ने, और मैं धन्यवाद देता हूं पूरी मेरी टीम को जिन्होंने इस कार्य को बहुत सुचारू रूप से किया। मुझे नहीं लगता किसी को भी कोई प्रॉब्लम हुआ होगा अपने गंतव्य स्थान से निकल के संस्थान और इस कन्वेंशन सेंटर तक पहुंचने में। उसके बाद बारी जो सबसे थी कि फाइनेंस की, फाइनेंस कैसे इकट्ठा किया जाए। आजकल के एनएमसी के इतनी कड़ी गाइडलाइन के अनुरूप हमें काम करना था। इस कार्य को पूरी टीम ने मुझे पर्सनली उत्साहित किया, और विशेष तौर पर मैं डॉक्टर संजय और डॉक्टर साकेत को धन्यवाद देता हूं कि मुझे लगातार पोक करते रहा कि कैसे फाइनेंस जुगाड़ करना है, और हर दिन मुझे टारगेट दिया जाता था कि सर आज ये करना है, सर आज ये करना है। राकेश पूरा साइंटिफिक प्रोग्राम देख रहा था, तो राकेश का काम था साइंटिफिक प्रोग्राम कैसे आए, उसमें मुझे बहुत दिक्कतें आई। डॉक्टर रबेला सर से निरंतर हम लोगों ने प्रयास किया कि मिले, और 15 दिन मुझे लगा, लास्ट 15 डेज में मुझे मिला साइंटिफिक प्रोग्राम। तो ये बहुत कम समय था मेरे लिए इस साइंटिफिक प्रोग्राम को सब तक पहुंचाना, ईमेल के माध्यम से, व्हाट्सएप के माध्यम से, फोन के माध्यम से, और हमने पूरी कोशिश की कि ये हर व्यक्ति तक किस टाइम पे कहां क्या करना है उसका पहुंच जाए। और मैं धन्यवाद देता हूं अपनी टीम के मेंबर्स को, स्पेशली डॉक्टर साकेत और राकेश को, कि मेटिकुलसली हर तक ईमेल के माध्यम से पहुंचाया। जिसके पास नहीं पहुंचा उसको मैंने पर्सनली फोन करके पर्सनली फोन किया, तो किसी का कोई ईमेल में डॉट छूट गया या कोई वर्ड छूट गया, या वर्ड नहीं, उसका अल्फाबेट छूटने के कारण नहीं मिला था, उसको त्रुटि को भी हमने कोशिश की करने की। मैं धन्यवाद देना चाहूंगा मेरे जितने भी स्पॉन्सर्स हैं उनको। एक एक स्पॉन्सर ने बड़ी मेहनत से किया, क्योंकि हमें समय कम मिला अंत में, क्योंकि एनएमसी की गाइडलाइन के अनुरूप काम करना है। तो जैसा सब कॉन्फ्रेंस में होता है वैसा हमारे यहाँ भी था कि प्रॉब्लम्स आई, लेकिन उस प्रॉब्लम्स को हम लोगों ने ओवरकम किया। और ये प्रोग्राम तभी हुआ जब हमारे जितने स्पॉन्सर्स थे उन्होंने निरंतर हम लोग के साथ तालमेल बैठाया, अपने वरीय अधिकारियों से बात किया, उस बात को करके क्रियान्वित किया। मैं धन्यवाद देना चाहूंगा जितने भी मेरे फैकल्टीज आए हैं। मुझे नहीं लगता है कि इंडिया के किसी पार्ट से कोई नहीं आया हो, हर स्टेट से कोई ना कोई आया हो, जम्मू कश्मीर से लेके पौंडीचेरी तक, इधर गुजरात से लेके आसाम तक, सब जगह से लोग आए हैं, और सब तरफ से मुझे पॉजिटिव फीडबैक डायरेक्टली या इनडायरेक्टली मिला। मैं धन्यवाद देना चाहूंगा मेरे जितने डेलीगेट्स आए हैं, जितने पीजी स्टूडेंट्स आए हैं उनका, जो कि लगातार यहाँ बैठे रहे और हम लोग के साथ समन्वय बना के सारे चीजों को अटेंड किया। मैं धन्यवाद देना चाहूंगा इस हॉल में जितने भी लोग मौजूद हैं, और जो लोग नहीं भी मौजूद हैं उनको, तो यहाँ आज इस प्रोग्राम को सक्सेसफुल बनाने में हमारा साथ दिए। मैं धन्यवाद देना चाहूंगा मीटिंग इन मोर के लोगों को, जो लगातार पिछले 1 महीने से लगातार हम लोग के साथ काम कर रहे हैं। स्पेशली अवनीश जी को मैं रिक्वेस्ट करूंगा, अवनीश जी से, कि वो स्टेज पे आए, मैं उनको सम्मानित करना चाहूंगा। और हमारे जो प्रेसिडेंट हैं डॉक्टर सुभाष गुप्ता सर, उसको उनको सम्मानित करेंगे। मैं डॉक्टर विरूति से रिक्वेस्ट करूंगा कि वो शॉल दें और शॉल से सम्मानित करें अवनीश जी को, अविनाश जी को मीटिंग मोड से। विरूति प्लीज। और मैं डॉक्टर टीवी से रिक्वेस्ट करूंगा कि वो मेमेंटो दें। अविनाश जी आगे आ जाइए आप। शॉल देंगे सुभाष गुप्ता सर और मेमेंटो देंगे टीवी यादव सर। और टीम 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 आ जाए, इसकी टीम है यहाँ पे कोई? मानस चालू प्लीज आ जाइए, एक ग्रुप फोटो हो जाएगा इनके साथ, प्लीज जल्दी फटाफट। सर 1 मिनट, ग्रुप फोटो इनके साथ हो जाएगा। और जो सबसे बड़ा दिक्कत मुझे आया वो ये आया कि 2 तारीख को गांधी जयंती थी और उस दिन जो हमारा ग्राउंड फ्लोर था उसमें सरस मेला लगा हुआ था और सरस मेला में मेरा बुकिंग 2 अक्टूबर था, लेकिन वो लोग जबरदस्ती वहां कब्जा किए हुए थे। अब ये हुआ कि अगर वो हॉल खाली नहीं होगा तो मेरा स्टॉल कैसे लगेगा, और जब तक खाली नहीं होगा स्टॉल लग नहीं सकता। तो 7 बजे सुबह मुझे खबर मिला ऐसी बात है, उन्होंने खाली करने से मना कर दिया है। 8 बजे से मैं प्लानिंग किया, 9 बजे मेरी जितनी पैरवी थी मैंने अपनी जान लगा दी, 10 बजे यहां मैं पहुंच गया और 1 बजे सारा खाली करा लिया। 100 स्टॉल, 100 स्टॉल तो खाली कराया, और खाली कराने के बाद 1 बजे से रात के 1 बजे तक 2 व्यक्ति खड़े रहे और लगातार स्टॉल को खड़ा करते। 2 बजे रात में से हैंडओवर मुझे किया गया। फ्रॉम 1 PM on 2nd October to 1 AM on 3rd October तक सारा स्टॉल में रेडी था, और इसका पूरा श्रेय जाता है एक ही आदमी को, वो है तेजिंदर पाल सिंह। आई रिक्वेस्ट तेजिंदर पाल, वेयर इज ही? तेजिंदर पाल is not there? Please come. He is a very young chap, bright chap. He was there relentlessly, working day and night. और 12 घंटे में सर 50 स्टॉल खड़ा, सफाई करना, खड़ा करने का काम यही एक कर सकता है, दूसरा कोई नहीं कर सकता। रिक्वेस्ट करूंगा सर, डॉक्टर टीवी यादव सर आप शॉल पहनाइए। डॉक्टर रजनीश सर आप उसको मेमेंटो दीजिए। तो 12 घंटे में सर इसने करके दिखा दिया, और जितने में मेरे दूसरे एडवाइजर्स थे किसी को ये विश्वास नहीं था कि 12 घंटे में खड़ा हो सकता है, और उसने खड़ा करके दिखा दिया, और सारे स्टॉल्स मेरे सुचारू रूप से 3rd अक्टूबर को रेडी थे। थैंक यू तेजिंदर, फ्रॉम कोर ऑफ माई हार्ट, यू हैव डन ग्रेट थिंग फॉर मी। इज्जत बचा ली तुमने मेरी। अब बारी है ऑडियो विजुअल की। आई रिक्वेस्ट यू टू कम ऑन स्टेज। आप लोगों ने खुद कहा सर कि ऑडियो विजुअल वाज फैंटास्टिक, देयर वाज नो इंटरफेरेंस इन बिटवीन, द ऑनलाइन thing was totally clear, sound was clear, audio visual clear, and it goes to him. Vijay ji is there with me. Thank you. A big hand to him. A big hand to him. Rajesh sir. अब बारी आती है मेरे बैकहैंड की, जो मेरे पीछे काम कर रहे हैं। देने के लिए तो मुझे अभी उनके पास कुछ बहुत नहीं है, उनको अलग से मैं सम्मानित करूंगा, लेकिन मैं चाहता हूं कि स्टेज पे वो आए और हम लोग स्टैंडिंग ओवेशन दें, क्योंकि वो लोग जो हैं वो मेरे पीछे काम कर रहे हैं। मिसेस श्वेता, प्लीज कम ऑन स्टेज, इज माय पीए इन डिपार्टमेंट, प्लीज कम ऑन स्टेज। सुमित, वेयर इज सुमित? सुमित आ जाओ। राकेश, इज माय पर्सनल स्टाफ इन द डिपार्टमेंट। राकेश कहाँ है? राकेश आ जाओ। पवन, माय सिक्योरिटी गार्ड, वेयर इज पवन? पवन जी आइए। और मेरे जितने रेजिडेंट्स हैं, प्लीज कम ऑन स्टेज, माय रेजिडेंट्स, और रेजिडेंट्स। ये 4 लोग लगातार मुझे घर से निकलने तक, घर पहुंचने तक लगातार मेरे साथ रहे हैं और काम करते रहे। तो बिग हैंड टू देम फ्रॉम ऑल ऑफ अस। इनको मैं अलग से पार्टी दूंगा क्योंकि लगातार ये रहे। सब प्लीज आ जाइए फोटो। मैं प्रेस और मीडिया को धन्यवाद देना चाहूंगा जो हमारी बातों को जन जन तक पहुंचा रहे हैं लगातार, और कल फिर पहुंचाएंगे। जो आज डिस्कशंस हुए हैं उनको कल फिर पहुंचाएंगे। और इस हॉल में जो सारा कार्यक्रम हो रहा है, इसमें गवर्नमेंट ऑफ बिहार, डिपार्टमेंट ऑफ टूरिज्म, डिपार्टमेंट ऑफ आर्ट एंड कल्चर, डिपार्टमेंट ऑफ जनरल एडमिनिस्ट्रेशन, तीनों ने मुझे मदद किया है और पूरी तरह से मदद किया है। मुझे ये बताया गया था कि जो मेरा बुकिंग है वो कभी भी कैंसिल हो सकता है, बिकॉज गवर्नमेंट की कोई फंक्शन में कभी दे हैव राइट दैट दे कैन कैंसिल एनी टाइम माई बुकिंग। तो अंत तक मुझे डर लगा हुआ था कुछ कहीं गड़बड़ ना हो जाए, बट मैं भगवान को धन्यवाद देता हूं कि गवर्नमेंट ने मुझे इतना सपोर्ट किया। और कल डिप्टी सीएम का यहाँ फंक्शन था, इसी हॉल में फंक्शन था, और चाहते तो कल पूरा फंक्शन मेरा कैंसिल हो सकता था, बट गवर्नमेंट ने मुझे सपोर्ट की और कोई व्यवधान, डिप्टी सीएम केम एंड वेंट एंड देयर वाज नो प्रॉब्लम इन आवर फंक्शन एट एनी टाइम। आई एम थैंकफुल टू गवर्नमेंट ऑफ बिहार फॉर दिस। मैं धन्यवाद देना चाहूंगा मेरे फोटोग्राफर्स का। आप लोग प्लीज ऊपर आइए और आपका फोटो कोई और ले, प्लीज, लोग छूट जाते हैं इस बातों को। प्लीज आप लोग ऊपर आ जाइए। मेरा रेजिडेंट बहुत अच्छा फोटो लेता है। अमित कहाँ है? अमित इज अ वेरी गुड फोटोग्राफर, यू प्लीज कम। मैं फोटो बहुत खींचता था बचपन में, तो मेरा फोटो हाथ में छूट जाता था। मुझे ये बात याद रखना था कि जितने भी फोटोग्राफर्स हैं उनके साथ मैं फोटो खिंचाऊंगा, इनकी फोटो छूट जाती है। तो आई हैव रिटन माय डायरी कि इनका भी ध्यान रखना है, मुझे इनका भी फोटो खिंचवाना है। तो प्लीज कम, जितने फोटोग्राफर्स हैं, कैमरामैन आप भी ऊपर आइए, आपका भी फोटो होना चाहिए। थैंक यू। आई हैव टू टेल थैंक यू टू यू ऑल्सो। एंड एट लास्ट, सबको पता है कि बैचमेट्स कितने प्रिय होते हैं, और मेरा स्कूल का बचपन का दोस्त डॉक्टर, जिसके साथ मैं बड़ा हुआ हूं स्कूल से अभी तक में, खट्टी मीठी यादें सब है, लड़ाई भी होती थी, प्यार भी रहता था, डॉक्टर अतुल वर्मा, प्लीज कम ऑन स्टेज। यू आर विथ मी yesterday, today and tomorrow also. Atul Verma is a cardiac surgeon working at IGIC Patna. He and his wife are practicing at Hajipur, and he was with me from day one till now. I am thankful to him that he is there with me today also. Farewell में लोग चले जाते हैं, वैलिटी में चले जाते हैं, but Atul is with me. Thank you for being with me. हमारे डिपार्टमेंट के बहुत सीनियर जो अब दिल्ली में काम, संजीव श्रीवास्तव सर का नाम छूट गया था, आई एम सॉरी सर, आपका नाम नहीं बोल पाए सर. यू आर हियर एंड टिल द एंड. थैंक यू सर फॉर बीइंग विथ मी. So I thank once again to all those whose names I have not taken. I have tried my level best to remember each and every person who has made it happen today. Thank you one and all. Somehow the quiz results could not have been announced, but I am announcing them today. Dr. Meet Akshay Desai from Medanta, Gurgaon. He is the first prize winner. He gets the cash award of rupees 25,000 and 2,500, sorry, 2,500 plus the certificate. Dr. Meet Akshay Desai is here. Is he here? No. He will be given the first prize of 2,500 cash with certificate. He'll correct later if he's not there. He wants the picture, sure. आइए सर. So just 1 minute, we'll stop for national anthem, then we can conclude. I request all of you to please stand up for the national anthem.
While we start the national anthem, if the Chennai team is listening, you know the person to have for the next conference. We'll solve all your problems.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे तव शुभ आशीष मांगे. गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
Thank you one and all. I request my department faculties and residents to come on stage to have a group photo.
Those who have not got the bags, they can collect the bags from the registration counter on the ground floor. They are available now.
Sir.